Check, 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 check. Good morning, dignitaries, delegates, and respected faculty members. It's my absolute privilege to stand before this extraordinary gathering for CME and workshop on mechanical ventilation organized by Department of Emergency Medicine and Department of Anesthesia, Sri Siddhartha Medical College, Tumkur, under the aegis of Sri Siddhartha Academy of Higher Education in association with Karnataka Emergency Physician Association. Today's gathering is special because it gives all of us a chance to learn, discuss, and grow together as a clinicians. Mechanical ventilation is something we deal with so often, yet there's always something new to understand, something new to sharpen our skills. We are fortunate to have experts with us who will guide us through practical insights that truly matter in day to day patient care. I hope today's sessions not only enhance our knowledge but also encourage constructive decisions among ourselves. Let's make this workshop a day of learning, interaction, and shared enthusiasm. I once again welcome you all to the first ever CME and workshop on mechanical ventilation in Tumkur at Sri Siddhartha Medical College and Hospital.
Without further ado, I would like to call upon our first speaker of the day, Dr. Rashmi Ma'am, Associate Professor, Kidwai Memorial Institute of Oncology, Bangalore, to speak on the topic respiratory physiology. Also, I would like to call upon our chairperson for the session, our beloved HOD sir, Dr. Srinivas Kulkarni sir, professor and head of the Department of Emergency Medicine, Sri Siddhartha Medical College and Hospital. Dr. Srinivas sir is a Bharat Jyoti awardee from the President of India. He is the ex-South Zone EC member of ISAFBF National, ex-EC member of ISA Karnataka. He is a retired professor from MMCRI Mysore, AVMC Pondicherry, and JNMC Belgavi. He has a teaching experience of 21 years in anesthesiology and 7 years in emergency medicine. He has given lectures and chaired sessions in national, state, and ISA sponsored CMEs and PGXLs. He has 12 national and international publications and has presented papers in numerous national and state conferences. We welcome you, sir, and I would like to request you to give a brief introduction about our speaker.
Thank you. Hello. Thank you very much for your kind introduction. Now I welcome Dr. Rashmi. Change. Hello. Change the change. Slide. Hello. Come. Hey, put the Joji, put the CV. Yes. I warm welcome to Dr. Rashmi NR. She is MBBS MD Anesthesiology, Associate Professor in Kidwai Memorial Institute of Oncology. She is from my alumni, IMS Bellary. She has achieved second rank in MD examination, RGHS in 2010. First prize paper presentations in UA ISA faculty session 2020. And she has a faculty speaker, state, national, international conferences, quiz master in various academic events. She has around 12 publications in national and international journals, co-author of a textbook chapter, EC member of SOAPC, Bangalore City chapter, treasurer in AIDAA, Bangalore City chapter, reviewer in JOAPM and PEEP journals, editorial staff, Airway Journal, areas of interest, difficult airway, thoracic anesthesia, focus, etc. I will warmly welcome you. Stage is yours, madam. Thank you.
Good. Thank you for the kind introduction, sir. At the outset, I would like to thank the organizers for giving me this wonderful opportunity. So, I bring greetings from my institute, Kidwai Memorial Institute of Oncology, Bangalore. So, without further ado, I'm going to start the lecture, which is respiratory physiology. And when I started preparing for this talk, I was so dazed and confused as to what do I exactly put in this. So now I have all the experts, my seniors, and all who will help me if there is anything missing information, because respiratory physiology is so vast and it is so difficult to cover anything or even to exclude. What am I excluding? That doubt I always had. Hope I have done justice for my lecture. So I started with the question that when it's respiratory physiology, is it different from an anesthesiologist than for an intensivist? So as we ask the questions, the parameters probably remain the same, but probably the patients whom we cater to are entirely different. As an anesthesiologist, mostly we will be dealing with normal lungs, unlike in ICU where mostly patients would have diseased lungs. And in anesthesia, it is mild to moderate ventilation perfusion mismatch, whereas in ICU patients, we expect more severe VQ mismatch. And the most importantly, the goal with which we provide mechanical ventilation in anesthesia, which is a short-term duration and to maintain the normal physiology, unlike in mechanical ventilation where we are giving it to support the gas exchange, and our idea is to also prevent the ventilator-induced lung injury. So why do we have to know the respiratory physiology at all when we are talking about a mechanical ventilation? So these are some of the pictures. So do you think is it associated? What am I trying to talk about? So the falling buildings are telling that probably the foundation of these buildings is not good. So it is very important that for any building or a good tree to have good roots or a good foundation so that the building really holds up. So that's the importance of respiratory physiology. So why respiratory physiology? So mechanical ventilation replaces or supports normal physiology. The ventilator is essentially an artificial respiratory pump. The use of it correctly requires us the proper knowledge related to respiratory physiology. So again, there are a lot of ventilatory settings which we will be changing on a day-to-day basis, and we should understand that each one of them correspond to different physiological principles. So I'm going to deal with these physiological principles in brief. Sorry. So mainly, if we divide, the key processes of respiratory physiology can be broadly classified as the things which are related to ventilation. Then comes the gas exchange at the alveolar arterial membrane. Then there is a transport of the gases to the tissues, and there is utilization of the gases, the transfer of gases happening at the cellular level. This is the whole process of respiratory physiology. I'll try to explain each one of them as much as possible. So this is what I just mentioned. The overview has all these parameters which are explained in brief. So initially, to start with, the ventilation. What exactly are we trying to understand in this ventilation in the respiratory physiology context? So what is ventilation? It refers to the movement of inspired gas into and exhaled gas out of the lungs. So the normal breathing, and that one volume is called as a tidal volume. So fresh gas enters the lung in a cyclic breathing pattern, and the overall rate and depth is determined by the metabolic demand of the patient. In a quiet breathing, it's around 7 to 8 liters, whereas in a patient who is doing an exercise, it could go quite high to meet the metabolic demand of that patient. So what exactly drives our ventilation? So it is partly involuntary and partly voluntary. The brain initiates generates the impulses, which is carried through the nerves which are transmitting to the muscles, the respiratory muscles, where there is increase in the volume and the pressure changes inside the thoracic cavity, which allows the air to flow. And once the equilibrium is reached, there is no more signal which is coming from the brain, and thus expiration happens. So this is how the inspiration and expiration happens. And there is the most important thing for the ventilation to happen is the pressure difference. So this pressure difference allows the air to move inside the lungs. So minute ventilation is a product of the tidal volume and the frequency. I already mentioned that it depends on the metabolic demand of the patient. So what is tidal volume? It is the volume of the air which is inhaled or exhaled during a normal or quiet breathing, which is approximately around 500 ml or 5 to 7 ml per kg in a resting adult. And it is comprised of two important components. One is the dead space and the other one is the alveolar volume. So for a single tidal volume, the tidal volume is a sum of the alveolar volume and the dead space. I'll talk about dead space in a while. So generally dead space is around 1/3 of the tidal volume, or approximately 2 ml per kg. So what's the clinical significance of tidal volume? I think this is the most importantly meddled parameter on the ventilator. So and also an indicator, whenever a patient is not breathing well or having a low tidal volume, that would be one of the indications for us to put the patient on mechanical ventilator. And once you have started your mechanical ventilation, you're also going to change the tidal volume depending on have you achieved your minute ventilation, or if the PaCO2 is achieved, or oxygenation is good. So that is important parameter on the clinical, in the mechanical ventilator, and it also helps in lung protective surgery when we think of where you want to avoid ventilator-induced lung injury. So what is alveolar ventilation? So I spoke about the minute ventilation. Alveolar ventilation is the proportion of that minute ventilation which reaches the alveoli and the respiratory bronchioles in each minute, which participates in the gas exchange. So the dead space is the space where the volume of the gas which is not participating in the gas exchange, and alveolar ventilation is the amount of gas per minute which is taking part in gas exchange. So this comes with a formula where tidal volume is subtracted with the dead space and multiplied by frequency. This gives the alveolar ventilation. So do we have to know all volumes and capacities when we are doing? Probably in anesthesia as a postgraduate, probably you have to know. But the most important capacities and the volumes when we are talking about mechanical ventilators are our FRC, tidal volume I already spoke of. So I will just tell you a few words about FRC. So we all know FRC is the volume remaining in the lungs after a normal passive exhalation. And in a normal individual, it is around 3 liters. So the reduction in the FRC, how does it going to impact? So it is going to cause an airway closure in the dependent lung regions. So if the airway closure happens, there is ventilation perfusion mismatch which is going to happen, thus impairing the gas transfers. So this is an FRC slide, which all of you should know, that how is it going to change with posture and age. If you can see here, with the age, overall lung volume is going to increase because the elasticity is lost as we age. And similarly, the FRC. The first line being a patient in sitting position. This is how the FRC is going to change. See, in supine position, FRC is going to drop from here to here, whereas with induction of anesthesia, FRC is going to still drop. So these are the things which we have to keep in mind when we are dealing with patients, especially in ICU or already having a compromised lung. So coming to the dead space, what is a dead space? It's a fraction of tidal volume that does not participate in gas exchange, and it is composed of apparatus dead space and physiological dead space. Apparatus dead space, as you can see here, the amount which is produced with the endotracheal tube or an NIV mask, that amounts for an apparatus dead space. The physiological one includes both anatomical and alveolar. So the apparatus dead space is the one which is created by our artificial breathing circuits. So how does it matter? It is very important when we are dealing with pediatric patients, because as you can see here, in a healthy adult who has a tidal volume of around 480 ml, dead space of 120 ml, the alveolar ventilation is still possible with 360 ml of air in the lungs. Whereas in a pediatric patient who already has a very small tidal volume, the dead space is amounting to 8 ml and the alveolar ventilation volume is only 14 ml. If our apparatus is going to give more dead space, what is available for the patient's breathing becomes very less, thus making the patient more prone for hypoxia or hypercarbia. So that is what you have to keep in mind when you are using any gadget with, especially the pediatric patients. So coming to the physiological dead space, I told already that it's a combination of alveolar and anatomical, and it is influenced by various factors. The alveolar dead space is the volume of the gas that fills the units which are unperfused or poorly perfused. So mostly in physiologically, it is like theoretically, it comes in West Zone 1. I'll be telling you about the West zones. I think all of you are aware of it. The clinical conditions, the pathological conditions in which it can happen is a cardiovascular shock, where there is hypoperfusion to the lungs, or emphysema, or an embolus, pulmonary embolus, where that part of the lung is totally underperfused and there is no ventilation which is happening. Anatomical dead space, as you can see in the picture, is nothing but the one which is happening in the conducting airways. So what do I mean by that? If you can divide your airway like this, the part of it till the 16th generation, it is a conducting zone. And after that comes the respiratory zone where the gas exchange can happen. So the amount of air which is staying here is not taking part in the gas exchange. So this amounts to an anatomical dead space. So what are the consequences of increased dead space? So as I already told, it decreases oxygenation, or it also hampers the carbon dioxide clearance, thus the work of breathing is increased. So the next important factor is a transpulmonary pressure. It's a pressure gradient. This is the pressure gradient, which is the difference between the alveolar and the intrapleural pressure. So it is equal to, it indirectly tells us about the elastic recoil property of the lung. So as the transpulmonary pressure increases, the alveolar volume also increases. And this difference between the alveolar and the pleural pressure is always positive. Let's see what happens. So if we deal with intrapleural and alveolar pressure separately, we consider alveolar pressure to be 0, both during at end inspiration and end expiration. The alveolar volume pressure, we take it as 0. Intrapleural pressure, we always know that it changes from apex to the bottom, from apex being more negative and the base being less negative. So if you put on the formula, we'll get that at the apex, you have an 8 centimeter of water, and at the base, the transpulmonary pressure is 1.5 centimeters. So I already told that because of the increased transpulmonary pressure, it keeps the alveoli much more open. So how does our lung look? Because of this distribution, our lungs looks like this, which are more distended at the apex and less distended at the base. So what does it mean? That means that in your pressure volume curve, the more compliant lungs, because these alveoli are already distended, and there is a limit for an alveoli to distend. It cannot go on distending. So they cannot distend further, which the alveoli which are already in the apex. So this part of so this is less compliant. So this the steeper portion of the curve is the alveoli which are more compliant, in the sense that the increase in the pressure is converted to increase in the volume. So this comes generally in zone 2 and zone 3. So our idea is to maintain all of our patients in this zone. So again, I told about the alveolar pressure, considering it as 0. But here, what you have to see is the alveolar pressure is changing from inspiration to expiration. It is 0 at end inspiration and end expiration, whereas with inspiration, at inspiration, maximum, it reaches -1, and at expiration, it reaches +1. This is the difference. This is the intrapleural difference. And as you can see, both of them are going in the same direction, which means that the transpulmonary pressure is positive. So which helps to draw the air into the lungs. So hope you're all understanding. So again, it's the same thing. What happens if we add PEEP? Adding PEEP to a normal lung, still the transpulmonary pressure is positive. But under circumstances where the patient is obese or emphysematous or pathological lungs, where the pleural pressure becomes more positive, that is when the transpulmonary pressure becomes negative, and that is more deleterious for our patients. So the importance of knowing the transpulmonary pressure, because it is going to affect our atelectasis, and you also have to know whether the PEEP can be given to your patient or not. So if it becomes negative, the primary consequence is atelectasis. The secondary consequence related to this is hypoxemia, increased work of breathing, increased retention of carbon dioxide. So these are the different scenarios where the intrapleural pressure is affecting our pulmonary volume. So this is a normal patient. This is a patient who is induced and paralyzed. You can see that the pleural pressure is 0, airway pressure is 10, and the transpulmonary pressure is still 10. So lung volume expansion is good. Again, this is something which is deleterious because patient is intubated. The pleural pressure is -19 because the patient is having a forceful inspiratory effort. At that point, what is happening? Transpulmonary pressure is becoming 25, which is going to cause lung injury for the patient. So this is something which you have to be aware of. Next is an obese patient where the patient is already having an increased airway pressure. So the intrathoracic volume expansion would be much less because of the patient's pre-existing condition. So coming to the compliance. What is compliance? It is change in the lung volume per change in the per unit change in the transpulmonary pressure. So the extent to which the lungs will expand for each unit increases the unit increase in the transpulmonary pressure is called as a lung compliance. So normally what is told is for every 1 centimeter of water increase in the transpulmonary pressure, if adequate time is given, the lung will expand by 200 ml, which is important. Again, we have static compliance and dynamic compliance. Static compliance is something which is measured when there is no airflow, and dynamic is the one which is measured when there is airflow. So static compliance generally talks about when there is no airflow, it is mainly the elastance of the lung and the chest wall which you are checking. Whereas with the airflow, we will be checking about the airways because there is a flow there. And also compliance of the respiratory system together is the combination of compliance in the lung as well as compliance in the chest wall. So this is how they're related. And if you put up this formula, which is around 100 ml per centimeter of water in the respiratory system together, because the reciprocal of them adds up to that. So this is again the compliance. Normally what we see is when we put up the lung volume curve, the inspiratory curve is what we put. This is a pressure volume loop where inspiration and expiration both are put together. The compliance in expiration is different than in inspiration, and lungs are much more compliant during expiration. So next important factor is resistance. So we all know that we talk about resistance whether it is an OT or mechanical ventilation. It impedes the airflow, something which impedes the airflow. So the resistance is given by the formula peak minus plateau pressure divided by the flow rate. So normal airway pressure is, airway resistance is around 1 to 3 centimeters of water per liter per second. And when the airway pressure increases, for example, if there is a bronchospasm, so what you have to understand is, what if there is only increase in the peak airway pressure, or both peak airway and plateau airway are increasing? If only peak airway is increasing and plateau, the difference is more, then that could be your bronchospasm or it could be kinking of the tube, and you have to address the problem accordingly. If both are increasing, that could be because of a less compliant lung. So this again, resistance depends on various other factors, not just the airflow, about the gas density, the gas viscosity, and this is the reason where we use heliox during bronchospasm, which is a less denser gas, and it allows the gases to go inside the patient much easily than only the air or only the oxygen. So work of breathing. So this is something which is very important, which we talk more often in the mechanical ventilation. So there are two different types of work of breathing, what we talk about. One is the elastic work, which is done to overcome the elastic recoil of the lung and the chest wall. The resistive work, which is to overcome the tissue resistance and the airway resistance. So I'm not going into the detail of it. So this is a curve which talks about the total work, whereas for the resistive work and the elastic work, there are different curves which are coming. But work of breathing is indirectly depicted by the respiratory rate. So when both of them in the total work, so what happens if there is increase in one component? As you can see here, increase in the elastic work, where the lungs elastance is lost, the patient's respiratory rate has become much higher. Whereas this is increase in the resistive work, which is related to the airway narrowing. So there the respiratory rate is becoming lesser. So all these parameters, if you know, it will be easy for you to understand your patient and what is going on with your patient, for you to think of a remedy. So coming to the surface tension. Force excited by the fluid. So alveoli is all lined by an epithelium and a layer of water. So that is called as a surfactant. I'll be talking about it. So what is the action of that surfactant? The pulmonary surfactant is a complex substance composed of phospholipid and protein. So the main action of that is it reduces work of breathing and it stops the alveoli from being collapsed. It provides a stabilizing influence, allowing the alveoli of different shapes to coexist. So what do I mean by that? So as you can see here, without surfactant, because of the constant shearing pressure of inspiration and expiration, the alveoli may collapse. Similarly, what you can see here is, without the surfactant in the first picture, the smaller alveoli is collapsed and the airflow is going from here to here. But here, because of the surfactant, you can see that the alveolar pressures are balanced. Hope you're all with me yet. So far I spoke about ventilation and the parameters related to ventilation. So let's talk a few slides about perfusion. 5 more minutes. So perfusion, I'm not going into the details of zones, West zones, because you all know about it. It's a first year topic. So what is important here is how pathologically it is going to affect this thing. So what is important here is all the zones described are purely physiological and they are not anatomical. The borders between the zones changes with many physiological and pathological alterations or conditions. So when we talk about perfusion, something what we have to know is shunt. This is similar to dead space, which we talk about in ventilation, but here it is related to perfusion. This is the blood which enters the systemic circulation without participating in gas exchange. So this amounts to some amount of hypoxemia, which is happening in the blood. As you can see here, what is the impact of this? So minute ventilation in this patient is 7 liters where it is normal, whereas the minute ventilation increased to 8.3 to 5 liters because of the shunt, which means that the patient's respiratory rate has increased so much to compensate for the shunt fraction. So that is the importance. So we all know the shunt equation. And up to what level of shunt is acceptable? Physiologically, less than 10% is normal, but we need to worry when it is more than 20 to 30%. So again, ventilation perfusion ratio. This is similar to the VD by VT what we spoke about. This is a VQ mismatch. VQ matching refers to the coordination of the blood flow and the gas flow. So in a normal lung, generally we take it as 1. The scatter happens from apex to bottom. I'll show you in the diagram. So in the normal lung also, because of the perfusion, what is it explaining? From apex to the base, your ventilation is also changing and your blood flow is also changing. But the rate at which the blood flow is changing is much higher when compared to ventilation. Okay, so this is the VQ ratio, ventilation perfusion. There is one point, is usually third rib or the mid zone where the ventilation perfusion matches. This is in the normal patient. And here also, if you see, the ventilation and perfusion are changing from apex to base. So, and somewhere in the mid zone, they will reach 1. So this is a VQ scatter. So coming back to what happens if ventilation perfusion is mismatched. So it is less than 1, it is in zone 4. So in hypoxia, if this is normally, you will see this in zone 4. But if the patient is hypoxic and your ventilation perfusion ratio is less, that could be reversible with increased FiO2 in some of the conditions and not all the conditions. So when your VQ is 0 or if it is infinity, which means that there is a true dead space or a true shunt, which means that there is no perfusion happening in that place. So at that point of time, how much ever FiO2 you are providing, your shunt fraction is not going to change. The hypoxemia is not going to change. So you have to address the problem accordingly. So hypoxic pulmonary vasoconstriction, we all know that it is a defensive mechanism by the body. Whenever there is a hypoxic area, that part of the capillaries are going to get constricted. That will deviate the blood to the normal lungs, thus reducing the VQ mismatch. So again, this is a pictorial diagram which is showing the hypoxic in a normal hypoxic mixture where the blood is shunted to the non-hypoxic region. So something important what we have to know is the positive end expiratory pressure. What is a positive end expiratory pressure? Normally, at the end of expiration, our lungs have a 0 end expiratory pressure. But in some pathological conditions or in the patient's conditions, or the end expiratory pressure is kept positive so that the alveoli are not collapsing at the end of expiration. So intrinsic PEEP or an auto PEEP is a condition which is inherent to the patient or it is happening because of our meddling. How does it happen? There is a dynamic hyperinflation there. And the progressive hyperinflation results in a positive end expiratory pressure. So it could be because of the COPD or you have increased the respiratory rate so much that you're not allowing the lungs to recoil back to their normal position. So some amount of every breath, the air is trapped inside, which is amounting to the intrinsic PEEP. Can we really find it out on the ventilator? Yes, you can. If you see the curvature here, this amount at the end of expiration, it is not reaching the baseline, which means that some amount of air is trapped there. This is an intrinsic PEEP. But what is an applied PEEP? So PEEP is a very good parameter, but we should also know it's a double-edged sword. It has its own deleterious effects. So it is at the end of the exhalation, we want the lungs not to collapse. That's the reason we are doing PEEP. Applied PEEP is used routinely during mechanical ventilation, and we start it from 5 to 8 centimeter of water, and optimal PEEP is different for different patient. So the driving pressure, similar to the transpulmonary pressure, which is in a normal breathing patient, which is required for normal breathing. This driving pressure helps to drive the air inside the patient on a mechanical ventilator. What it is a difference between the plateau pressure and the PEEP. Or if plateau is not there, it is difference between the peak and the PEEP. So ideally, it should be kept less than 15 centimeters of water. So what you see here, this is the driving pressure, plateau minus PEEP. So here you can see that we have kept a PEEP of around 5 centimeters in this patient where it will not touch the baseline. So hope you're all lost here somewhere. Few more slides. So we spoke about so far ventilation only. Coming to the gas exchange. What exactly happens at gas exchange? I will just explain this in one slide. The oxygen cascade where the partial pressure of oxygen from the atmosphere drops down till the mitochondria. This process is called as oxygen cascade. And what we are interested here is this diffusion which is happening at alveolar and arterial level, alveolar capillary membrane in the lungs. So this is the formula of alveolar equation. And diffusion, it is by the Fick's principle. So what is the Fick's principle? It says that the diffusion is dependent on the area, the coefficient, and the pressure gradient, most importantly, and the thickness of the membrane which it is crossing. So this is a Fick's principle, which is important for us to know what is if the AA gradient, alveolar arterial gradient is much higher in any of the patients, which is normally should be 8 to 10 mmHg. If it is much more, we have to think that what could be the reason why the patient is having hypoxemia. So again, this shows that from the capillary end, from the venous to the arterial end, the capillary transit time is available, and at that transit time, the gas exchange is happening. So again, carbon dioxide diffusion, which is a reverse of oxygen cascade, where from the mitochondria, it comes out into the blood and then to the atmosphere. So again, this is the last slide, where we speak about cellular transport. We spoke about gas exchange, and from after the gas exchange, it is transported to the tissues, peripheral tissues, and at the level of peripheral tissues, the cellular respiration happens where oxygen is taken up and carbon dioxide is given back to the blood. So it's very important that we know the normal values in each setting so that you can adjust your mechanical ventilator so for us to have an impactful mechanical ventilation and the results. So to conclude, ventilators do not treat numbers. They support the physiology. Understanding physiology is the key to safe, effective, and individualized ventilation. These are my references. Thank you for your patience. Thank you, ma'am.
You have laid the foundation for today's CME and workshop on mechanical ventilation by describing all the various lung volumes, capacities, and all of the physiology which is necessary to understand the mechanical ventilation. So mechanical ventilation is nothing but the application of positive pressure to create a pressure gradient and to drive away all kinds of airway resistance. So you have described everything in depth.
Thank you, ma'am.
And anybody would like to anybody wants to ask any queries regarding this, most welcome. If you have understood all the volumes and capacities and pressures which Dr. Rashmi has been speaking about, I think you're very lucky because it's a very complicated topic which she has tried to simplify. Anybody wants to ask anything? I just wanted to say that last you came to the driving pressure.
Yes,
so the driving pressure is a very important thing which has to be understood very well. And I think, I don't know, maybe Gurudat sir will come to that. We nowadays have a new concept of mechanical power in which all these volumes are added, the tidal volume, the respiratory rate, and the compliance, the PEEP, everything is added to calculate the energy which is transferred from the mechanical ventilator to the patient's lungs. So that's a new concept which has come up, which combines all these things which you were speaking about. Okay, but that's a new thing.
And also, I didn't cover the neuronal control of the respiration. Where
Yeah,
we
that's
also have
another
this-
topic by itself.
The neural control, the newer
Yes.
modes has NAVA, where neurally assisted ventilator.
Yes.
So where the patient
NAVA.
synchrony is
Yes,
much
yes.
better.
Yes.
Thank you very much. Thank you very much, Dr. Rashmi. It was very nice to have you here.
Thank you, sir.
And
Thank
it
you.
was
Sir.
a very nice lecture. And I'm very much in gratitude that in a short time you have accepted the invitation and you came in here. Because of the Dr. Sudish was having some family issues, he went to his native place. Instead of that, we called Dr. Rashmi. It was a surprise for you also. But lecture was very apt and it was very good. Thank you so much.
Thank you so much.
Thank you, ma'am, for the insightful session. I would like to request our chairperson, Dr. Srinivas sir, to please felicitate our speaker.
Now we move on to the next session and call upon Dr. C.L. Gurudat sir, former professor and head Mysore Medical College and Research Institute and JSS Medical College, Mysore, on the topic Basics of Mechanical Ventilation. I'd also like to call upon the chairperson for the session, Dr. Gangadhar SB sir, professor and head Department of Anesthesia, Sri Siddhartha Medical College, Tumkur, Dr. Gangadhar sir is a pioneer in anesthesiology and was awarded the prestigious Dr. B.C. Roy Award on National Doctors' Day 2025 on 17 July. He was felicitated for his outstanding contribution at 6th Annual CME on recent advances in anesthesia, organized by CIMS ISA Mysore City Branch in December 2024. He was awarded Medical of Excellence Award at ISA Con State Conference, Bengaluru on 11th August 2024. He has been awarded Lifetime Achievement Award at the 35th State Conference, Shimoga in 2021 and at the 36th Annual South Zone Conference of ISA and 12th Annual State Conference of ISA, Puducherry. He was awarded as Eminent Teacher at the ISA Con 2019 by ISA Karnataka. He was the Chief Editor of Karnataka Journal of Anesthesia. He was also former ISA National Governing Council member, former President ISA Karnataka State Branch, former President Secretary ISA Bangalore City Branch, Organizing Secretary ISA National Conference Bangalore in 1993, Organizing Chairperson of 41st ISA National Conference Bangalore 2019, and was the governing council member of SARC Association of Anesthesiologists from 2011 to 2013. He has one state journal, two Indian journals, and 23 international journals. He has a keen interest in critical care, pediatric anesthesia, and obstetric anesthesia. We welcome you, sir, and I'd request you to please introduce our distinguished guest.
Good morning, everybody. Hello. Hello. Good morning, everybody. You're all welcome to this. This one CME as well as this one for. It is one of the prestigious things we conduct in our Siddhartha Medical College. And today, almost the starwards in the anesthesia, they're all here. Really, it is a great opportunity. I think everybody can meet them. Okay, today's speaker, Dr. Gurdat. Dr. Gurdat doesn't need any introduction. He is well known in this one, in the family of anesthesia and other things. So for the audience, for the newcomers, at least I want to introduce Gurdat for this. He is a current designation former HOD of Mysore Medical College in the Department of Anesthesia, the very prestigious Mysore Medical College. Then followed by, he has become an HOD in JSS Medical College after the retirement. And his also achievements is a Neon Excellency Award for Educational Institutes 2017 Coimbatore and Best Teacher Award in 2019 Mysore Medical College and Research Institute. And also Best Teacher in 2020 at JSS Academy of Higher Education and Research. Eminent Anesthesia Teacher Award ISA Karnataka, Associate Editor of Indian Journal of Anesthesia for 6 years. The Member Advisory Board IJA served in Army Medical. Basically, is an HLP. That is as captain as 5 years. Then think about it. Then put into national, international publication, 2 book chapter, presented many invited guest speakers. Many, I think, where you cannot without Gurdat, I think that this will be not there. And much more time I remember him with the machine. All the time. So he's a well versed in the machine. He's the authority over the machine, I think. So that is the thing. Over to the Gurdat.
Thank you, sir. Thank you very much for the nicest introduction I have ever had. And thanks to Dr. Srinivas Kulkarni for giving me this opportunity to be here. But when I was a postgraduate, maybe about 40 years back, that was in KMC Mangalore, we had only one mechanical ventilator, bird ventilator. And that was there for the whole hospital. It was the only one ventilator, and it was there in the OT. Somehow why it was in the OT, I don't know. And nobody knew how it was working actually. And one medical officer, I still remember, Dr. Somshekhar used to come once in 3 days. He used to, it used to be covered by a cloth. So I used to open it and then it used to make a lot of sounds, probably the lot of alarms. We didn't know what was, why it was making so many sounds, and it was an enigma for all the postgraduates. Then I passed my MD and then I went to Ballari Medical College as assistant professor. There also we did not have even a single mechanical ventilator. And the physicians, they used to request the anesthesiologists to intubate the patients, especially the patients with respiratory failure, like OP poisoning or even snake bite patients. So we used to intubate and then hand over the patients to the physician, the medicine department. And what they used to do is they used to connect the endotracheal tube to an ambu bag and give it to the relatives to ventilate. And they used to tell us that, intubating a patient in respiratory failure is like writing a, death certificate for the patient. So that was so common. Deaths were very, very common. We were very fortunate. I was very fortunate that by 2000, we got 6 Draeger ventilators to Ballari Medical College. And we were also very fortunate that all 6 ventilators were given to the Department of Anesthesia. And we started our respiratory therapy unit. And then the medicine people realized that most of the patients in respiratory failure would, they survive and go home. So that was the thing about the mechanical ventilation during those days. And now, the mechanical ventilators are the part of majority of the departments of critical care, the medicine, you take the emergency medicine. And every anesthesia workstation now has a mechanical ventilator. And because of that, you have to have a very sound knowledge about mechanical ventilators and how they work actually. Okay. A mechanical ventilator is simply a machine that can partially substitute or completely substitute the work of breathing accomplished by the patient. Suppose the patient is not breathing at all, he is not able to, generate a respiratory effort, then the mechanical ventilator will take over the complete work of breathing of the patient. Suppose if he can partially breathe or if he can attempt breathing, that is what occurs in ICUs, then it will partially support the the work of breathing of the patient. And the ventilators, when they were introduced as the negative pressure ventilators, and that was in early 1900s. Negative pressure ventilator means they would create negative pressure around the body of the body of the patient, and that's how the whenever intermittent negative pressure. So that's how the air would enter into the lungs. Whereas the positive pressure ventilators would they'll push the air positively with a positive pressure, intermittent positive pressure into the lungs, and that's how the ventilation occurs. And the positive pressure ventilators can be invasive and non-invasive. Non-invasive ventilators means you ventilate the patient with a face mask or nasal mask, whereas invasive ventilators you have to intubate and ventilate. Negative pressure ventilators can be a tank ventilators or KEPA ventilators. I would just like to tell you a few things about these negative pressure ventilators, which actually started the mechanical ventilation era. So these negative pressure ventilators, the tank ventilator, it's also called as an iron lung. So if you want to see an iron lung in India, you can still see it. It is there in the FMC Pune and beautifully maintained. One soldier is kept for just maintaining this tank ventilator. So actually, in the 1900s, early 1900s, the mechanical ventilation started with these tank ventilators. What these tank ventilators, the whole body of the patient would be introduced into the tank ventilator, only his head will be outside, and the intermittent negative pressure would be created by this air compressor, and that's how ventilation was being done. But there were a lot of problems with these tank ventilators. One of the problems with these tank ventilators, you can see no access for the patient's hands or any part of the body by the intensivist. The other problem was, normally when we breathe, just now Dr. Rashmi was talking about the negative pressure, negative pleural pressure we create. That's how, that same negative pressure is transmitted to the alveoli. That's how air enters. And because of that negative pressure that is created in the chest, a pressure gradient is created from the lower half of the body to the heart. And that's how, the blood will move from lower half of the body to the right side of the heart and cardiac output would be maintained. Just imagine here, whole body negative pressure is created. If the whole body negative pressure is created, where is the gradient for the blood to move from lower half of the body to the heart? That's how with these type of tank ventilators, there was quite a reduction of the cardiac output. The other problem may be a funny thing, or you can imagine those patients inside. Many times insects used to enter. There are incidences where rats had entered inside, and in the poliomyelitis patients they cannot move, and probably you can imagine. As such, mechanical ventilator, I always tell it is a hell on the earth. Anybody on the mechanical ventilator, and you can imagine these tank ventilators. So that was the problem in those days. That's the reason why another type of ventilators were introduced. These are called as a Kiras ventilators, more physiological. That means the ventilator is around, the shield is around the chest of the patient. So intermittent negative pressure would be created here. And that's how, more physiological this. And even now in Europe, so many places, these Kiras ventilators are back. Actually, many of the patients with neuromuscular disorders and even in COPD patients, where you want to avoid tracheostomy or you want to avoid unnecessary intubation, these Kiras ventilators are back and they are in quite a demand. So in 1952, what happened was there was a polio epidemic that was in Copenhagen, and even many of the European countries had this the polio epidemic. So during those days, many patients with polio developed respiratory paralysis, and most of these tank ventilators were full. So there was hardly any tank ventilator left for treating these patients with respiratory failure as a result of poliomyelitis. So what they did was they did a tracheostomy for many of these patients, connected these patients to a water's to and fro circuit, and they ventilated them. Surprisingly, because till then positive pressure ventilator had not been started, it was only negative pressure ventilation. So to the surprise of the people who treated these patients, many of the patients with these tracheostomy with positive pressure ventilators, ventilation survived. And many of the patients with negative pressure ventilation died. So that's how, the era of the intensive care and the positive pressure ventilation started. Actually, the first positive pressure, invasive positive pressure ventilation was done in Massachusetts General Hospital. You all know about the Massachusetts General Hospital in Boston, one of the most popular hospitals even today. And during those days, when anesthesia was born by W.T.J. Morton, first publicly demonstrated ether anesthesia in the same Massachusetts General Hospital under the ether dome. So that's how, the positive pressure ventilation started. And now we all are very, very familiar with positive pressure ventilation, and we are not at all familiar with the negative pressure ventilation. So before actually going into the modes of ventilation, so you have to understand how the respiratory cycle of a mechanical ventilatory breath occurs. So let me just talk to you about the respiratory cycle of a mechanical ventilator breath. You can see usually there are the inspiration, the expiration has to end, the inspiratory phase has to begin. So this is one phase, and the inspiratory phase has to occur and it has to complete, and the inspiratory phase has to change over to expiratory phase. So that way, so changing over from expiration to inspiration, inspiration changing over from inspiration to expiration, and expiration to occur. Normally, normal physiology of expiration is a passive one. It's mainly because of the elastic recoil of the lung, the expiration occurs. Even under mechanical ventilation, it is always the same. Expiration is passive. We are not going to do anything. Active phase is the inspiration. And inspiration has to be initiated. Somebody has to initiate inspiration. And this initiation of inspiration is what we call it as the trigger. That is changing over from expiration to inspiration. and the inspiratory phase that has to be controlled, and that we call it as a control or a limit or a target. And the inspiration has to end and the expiration has to begin, and this is called as cycling. So these things, variables, are very, very important. The starting of the inspiration, which is called as a trigger, and the limitation of the inspiratory phase, that is called as a limit or a control or a target. And cycling means it is always from inspiration to expiration. These things you have to understand a mechanical breath. So let us just discuss about the trigger. So the trigger, that is initiation of inspiration, can be by the machine or can be by the patient. If it is a machine triggered breath, means it is time triggered, and if it is by the patient, it is either pressure triggered or flow triggered. What is this time triggered breath? So suppose I keep a respiratory rate of 12 per minute, and that means every 5 seconds the ventilator automatically triggers an inspiration. That is what is called as the time triggered respiration or time triggered breathing. So the other important thing I was telling you about the patient triggering. So patient triggering can be either a pressure triggering or a flow triggering. So the pressure triggering is normally when the patient tries to take a breath, he creates a negative pressure, and once he creates a negative pressure, this negative pressure is immediately sensed by the pressure sensors, and the inspiratory valve will immediately open and the inspiration starts. So that is what is called as the pressure trigger. So this pressure trigger you can easily make out by the scalars on the ventilator, the screen curves. So these are called as scalars. Now this is a pressure time scalar, this is a flow time scalar, and this is a volume time scalar. So in the pressure time scalar, you can see this negative pressure is created by the patient. That is the pressure trigger, and immediately the inspiration will start. And this time between the patient initiating a breath and the ventilator responding is very, very crucial, because the ventilator should not delay in opening the inspiratory valve and to give either a pressure or flow of gases. Because if it time is longer, then there can be a dysynchrony between the patient and the machine. So that is what is called the response time. And the time to the pressure trigger, usually you can set to start with about -1 centimeter or to -2 centimeters. Then comes the flow trigger. Now the flow trigger is, normally there is a continuous flow of air through the circuit. So there are, two limbs of the circuits. One is the inspiratory circuit, the other is the expiratory. So when the patient starts initiating a breath, he takes away some amount of this flow. Once he takes away some amount of the flow, there is a variation or there is a decrease in the return flow when compared to the delivered flow. So these flow sensors immediately will sense this. That means the patient has initiated a respiration or inspiration, and they'll immediately open the inspiratory valve and the flow starts. So you can just see a small upward deflection, but more important is, again, even in the flow trigger, there is a negative pressure, negative deflection in the pressure time scalar curve. So you can again see this, and usually you set the flow trigger to about 1 to 2 liters per minute. So what has been found, many of the ventilators, especially the Mach ventilator, you can have both the pressure trigger and the flow trigger. You can adjust any one of them. But ideally speaking, is the flow trigger is always better. The advantage of flow trigger is more sensitive, one. The second thing is the initiating an inspiration by the patient by using flow trigger, the work of breathing is much less when compared to initiating a breath by using a pressure trigger. So that is an advantage. The other important thing is when you are setting the flow, the triggers, whether it's a pressure trigger or a flow trigger, you have to see that you don't make it too sensitive, the ventilator. That means if you are, setting a flow trigger of just about, say, minus 0.5 centimeters of water of pressure trigger or about 0.5 liters of flow, then what happens is the ventilator becomes so sensitive, even slight movement or vibration of the breathing circuits can initiate a breath. and that is called as auto triggering. So this you have to avoid. So, but you don't make it the ventilator as too less sensitive also. That means suppose I start with 5 liters per minute of flow trigger. So what happens is the patient will not be able to initiate a breath at all. He will not be able to trigger a breath at all because you have made the ventilator so insensitive. Then again there will be a fight between the patient and the ventilator, dysynchrony occurs. So this is very important regarding these the trigger setting. Coming to the second variable I was talking to you about is the control or the target or the limit. So this can be a volume control or a pressure control. In the volume control, you're going to preset a tidal volume. In the pressure control, you're going to preset a inspiratory pressure. So when you preset a tidal volume, what happens is the tidal volume, that is a volume, and the flow are independent variables. Whereas the pressure becomes a dependent variable. A pressure depends on the compliance and resistance of the lungs. So that becomes a dependent variable. Whereas in a pressure controlled ventilation, so the pressure is the independent variable, whereas the flow and volume becomes independent variables. Dependent variables depends on the patient's resistance and the compliance of the lungs. Now you can see here, this is the scalars of volume control, and this is the pressure control. In the pressure control, the pressure is always constant. So when you activate it, so what happens is the peak pressure is reached and that will be maintained till the particular inspirated time, and it will go for expiration. So here in the volume control, the flow becomes constant. So just by looking at the scalars, you can know whether the patient is volume control type of ventilation or he is on a pressure control ventilation, because in volume control ventilation the flow is constant. In pressure control ventilation the pressure is constant and the flow is decelerating in pressure control ventilation. So coming to cycling, cycling means the inspiration is ending and the expiration is beginning. That is what is called as cycling. So this cycling can be a volume cycle, time cycle, or flow cycle. So volume cycle, invariably, if you don't set in majority of the volume controlled ventilation, it will be a volume cycle, unless you have an inspiratory pause there. Otherwise, it is always once the volume is delivered, changes over to the expiration. So the time cycling is invariably it is in the pressure controlled ventilation. Whatever you have set the inspirated time, once the inspirated time is over, automatically it changes over to expiration. And the flow cycling is in the pressure support ventilation. Once the peak flow starts decreasing and reaches a particular value of the flow, it automatically changes over to the expiration. In all ventilators, you also have a pressure cycling is also there. So this, what is this pressure cycling? You always keep a maximum pressure. Once the, by chance, if the maximum pressure is exceeded, then it automatically changes over to expiration. Like for example, now you have put the patient on a ventilator, he starts coughing. So once he starts coughing, so he is going to create a higher pressure, more higher pressure than whatever the maximum pressure limit you have kept. So automatically, even though the volume may not have been delivered to the patient tidal volume, it changes over to expiration. That is called as a pressure cycling, which is not very commonly occurs. Now you can see this is the volume cycling one. So once the volume is delivered, so it changes over to expiration. And the same way you can have the time cycled one. This is a pressure controlled ventilation. You can just see the scalar because this is a flat one. That is why you can say it's a pressure controlled one. And once the time, inspirated time is over, it changes over to expiration. That is called as a time cycling. So this flow cycling, you should always understand. This is in the pressure support mode. In the pressure support mode is also, it is a pressure limited mode. And you can see this, the pressure time scalar, and you can see the constant pressure here. You should watch the flow. So what happens to the flow here? So, once you set up pressure support, by the patient's effort plus the whatever support we have kept, So patient will develop a particular amount of peak flow. And because it is a pressure limited type of ventilation, the flow is always decelerating. So once it starts decelerating and reaches the 25% of the flow, it changes over to expiration, and this is called as flow cycling. And always remember that in always pressure supported breaths or pressure support ventilation, the cycling is always flow cycling. So let us, by combining all these parameters or variables, now we can have three types of breaths. One is, the controlled or a mandatory breath, an assisted breath, and a supported breath. So what are these controlled or a mandatory breath? A controlled or a mandatory breath, everything is controlled by the machine or the ventilator. It is time triggered, and if it is a volume controlled one, once the preset tidal volume is reached, it changes over to the expiration, and preset tidal volume will not be exceeded, and all the breath rate, everything is by the ventilator. So that is the controlled breath. Whereas an assisted breath is just it is almost a controlled breath, except that it is triggered by the patient. In a controlled breath, the machine triggers the breath, whereas in an assisted breath, it is triggered by the patient. So you have to set a trigger for an assisted breath. Normally, nowadays in ICU ventilators, you don't have only the controlled mode of ventilation or controlled breaths. You have, majority of the times, it is always the assisted breath. You have to set the trigger. So now you can have two breaths. This is totally a controlled breath where it is not triggered by the patient. Here it is triggered by the patient. And once the patient triggers, the remaining thing will be looked after by the ventilator. So that is an assisted breath. And this is a supported breath, as I already told you, that it is triggered by the patient, and it is a pressure limited one, and it is a flow cycle breath. So these three types of breaths are there. So now just to compare these three types of breaths, this is a mandatory breath or a controlled breath. It is triggered by the time triggered, that is a machine triggered. You either preset tidal volume or preset inspiratory pressure, and depending on the type of breath what you have, it can be a volume cycling or a time cycling. In assisted breath, the same thing, except that it's triggered by the patient. Supported breath, it's triggered by the patient. It's a pressure limited one, and a flow cycling is the cycling that occurs. Now coming to the modes of ventilation. What are the modes of what do you mean by modes of ventilation? It is how and when a ventilator delivers a breath to the patient. That is called as a mode of ventilation. And these modes can be classified as basic modes and advanced modes. Advanced modes can again be subclassified as conventional and unconventional. So the basic modes, and majority of the times, you can manage any patient with only the basic modes of ventilation. So these are a CMV mode, that is continuous mandatory ventilation, pressure controlled continuous mandatory ventilation, assist control, SIMV synchronized intermittent mandatory ventilation, pressure support ventilation, SIMV with pressure support ventilation is also there, and CPAP with pressure support ventilation is the another mode. Now coming to the advanced modes or newer modes of ventilation, these are airway pressure release ventilation, biphasic positive airway pressure ventilation, the pressure release, pressure regulated volume control, volume support, auto mode, proportional assist ventilation, adaptive support ventilation, automatic tube pump. There are so many of them are there. Out of them, the PRVC, that is pressure regulated volume control, the volume support, and auto mode have become almost like a primary mode of ventilation. Majority of the times nowadays, we directly, instead of going in for a CME mode or ACME mode or SME mode, directly every one of us are going in for pressure regulated volume control, though it's an advanced mode, a dual control mode of ventilation. So some of the unconventional modes of ventilation are neurally adjusted ventilator assist, liquid ventilation, high frequency ventilation. I'll be talking about basic modes of ventilation, and Dr. Varun will be talking about the advanced modes of ventilation after my lecture is over. So let us just discuss about these basic modes. Many of them already have heard about. So one is a continuous mandatory ventilation. When I say CMV mode or continuous mandatory ventilatory mode, it is always a volume controlled mode, unless we specify PCMV. This CMV is only volume controlled ventilation. And here you can see that the the pressure is a dependent variable on compliance and resistance. Flow is always constant, and this is a flow time scalar, and the volume time scalar. Once the volume is delivered, it cycles to expiration. So that way, it is always a time triggered one, flow limited, and volume cycled. So in anesthesia, majority of the times what we have is the CMV mode only, because we paralyze the patient. Once we paralyze the patient, so they, even if you keep the trigger, so it will not get activated, because every breath is a time triggered breath. Now coming to the same one, which is pressure controlled instead of a volume control. In a pressure trigger control, the again triggered by the machine, that is time triggered. Only thing is, it's a preset. You are going to have an inspiratory pressure preset, and that preset pressure is immediately achieved. And once the inspiratory time is over, it cycles to expiration. So it's a time triggered, pressure controlled, and time cycle type of breaths. So one thing you should always remember, so with a pressure controlled mode of ventilation, the peak pressure and plateau pressure are same. So, and you are going to control it. That is the reason, because it's a dependent variable, whereas in volume controlled ventilation, it becomes, it's an independent variable in a pressure controlled one. In a volume controlled mode, it becomes a dependent variable. So the pressures can shoot up if the compliance of the lung is very low. In a pressure controlled ventilation, you are controlling. So that way, you can have a lower peak airway pressures. And another important thing here is, I told you the flow is always decelerating flow. With a decelerating flow, there will be a more homogeneous gas distribution, and there can be a better gas absorption with a pressure controlled mode. And usually majority of the times we go for volume control mode, but nowadays people are going in for pressure control mode. When we go for a pressure control mode, when we think that the compliance of the lung, just now Dr. Rashmi was talking about resistance, compliance, and all those things, the compliance of the lung is on the lower side. It is always better to go for a pressure control ventilation to prevent barotrauma, especially like in interstitial lung disease patients, ARDS patients, or even the pediatric patients, and all those patients where you do not want to increase the intracranial pressures, like patients with neurosurgeries or traumatic brain injuries, because any increase in the intrathoracic pressure is going to further increase the intracranial pressure. So what are the indications for this controlled mechanical ventilation or continuous mandatory ventilation? It is ideal when patient doesn't have any kind of respiratory effort, like he may be paralyzed as a result of neuromuscular blocking agents. It may be a traumatic brain injury, spinal cord injury, phrenic nerve injury, or motor nerve paralysis. In all, these are the indications for the controlled mode of ventilation. What are the advantages? You know that whatever the set tidal volume is delivered, the minute volume is guaranteed, and the PSCO2 you can definitely maintain with the respiratory rate, and workup breathing is zero for the patient. So there are certain disadvantages are also there. By chance, the ventilator stop working, or there is a disconnection. And there is a famous joke that around every day around 3 o'clock to 5 o'clock, many patients used to die. So that's because one of the servants there used to take out the plug of the ventilator and connect her, charging for mobile. So that's how, if there is a disconnection, there is always a possibility that patient is not having any effort. He'll go for severe apnea and hypoxia, and even death can occur. The other important thing is, patient is not doing anything, so there can be a disuse atrophy of the diaphragmatic fibers, and prolonged weaning is a problem with this. So what are the parameters you set? You set the FiO2, the tidal volume for volume control, and inspiratory pressure for pressure control, respiratory rate, IE ratio, and the PEEP you are going to set. Coming to ACMV mode, or assist control mandatory ventilation, or assist continuous mandatory ventilation. Only difference between CMV mode and ACMV mode, here you also set the trigger. Once you set the trigger, patient can always initiate a breath, and once he initiates a breath, and afterwards everything will be taken over by the ventilator. So his this thing is the patient can only initiate. That's all his role, and afterwards everything is done by the ventilator. Whatever the preset tidal volume will be delivered, and because it's a CMB mode, ACMB mode, it's a volume controlled mode, so it is volume cycling is usually occurs. So next you also have the same thing like pressure controlled, the assist control mandatory ventilation. Here again the difference is you're going to set the trigger, and that's how every breath can be pressure patient triggered, pressure limited, and time cycled ventilation. So what are the advantages of ACMV? Advantages: the set tidal volume is always given to the patient, and since the patient will be controlling the respiratory rate, because when we set the respiratory rate in ACMV, we always set the respiratory rate much lower than actual the patient rate. So patient can initiate the breath every time he initiates the breath, because it triggers the ventilator, and ventilator will give the breath. So you'll be more comfortable probably in ACME mode compared to CME mode. And again, it totally unloads the respiratory muscles. So again, disadvantages. One of the most common disadvantage with an ACMV mode is, suppose if you have set a tidal volume of 500 ml and the patient has a respiratory rate of 30. So that means every minute patient will be ventilated with a minute ventilation of 15 liters, and it is too high. And 15 liters definitely his PSO2 will drop. He'll develop respiratory alkalosis. Plus, afterwards he may not be able to trigger the ventilator, because the respiratory center now will not be able to get triggered or get initiated for initiating a breath, because the PSO2 has dropped. So, and all other problems of alkalosis can occur. So that is one of the problems. So in order to prevent that, you may actually sedate the patient, and more sedation may be required. And as such, diffuse atrophy and prolonged weaning can be a problem with ACMV mode. And because, in these CMV and ACMV modes, one thing is, the parameters, extra parameter you set is the flow trigger. So with ACMV and CMV mode, the machine will not be allowing the patient to breathe in between. So in the SIMV mode, or in the one thing is the IMV mode. First they introduced the IMV mode. Later on SIMV mode was introduced. In the IMV mode, the patient is also allowed to breathe in between the mandatory breaths. So you set the mandatory breaths, and in between the patient can breathe. So when they introduced this, the intermittent mandatory ventilatory type of mode of ventilation, they thought that now we have got the perfect type of ventilatory mode. But unfortunately, what used to happen was breathtaking used to happen. What is breathtaking? Breathtaking means, in this, there is no synchronization with the patient's breath and the ventilator breath. So when the patient is expiring, the ventilator may try to impose an inspiration or its mandatory breath. So that will again produce a dysynchrony between the patient and the ventilator. So that's why later they introduce what is called a synchronized intermittent mandatory ventilation. Here, the patient's breath will be synchronized with the mandatory breath. So that way, there won't be any problem as far as breath stacking is concerned. So how this synchronization was done? Suppose if I keep a respiratory rate of, say, 10 respiratory rate, so every 6 seconds, there is going to be a time-triggered breath, or it can be patient-triggered. So suppose if the patient is expiring, why breath-taking cannot occur here, why synchronization occurs is, so the last part of this period, that is, let us say that for 5.5 seconds, the patient is trying to inspire, then what happens is, the ventilator will give a breath early, and it will synchronize with the patient's breath. This is what is called as synchronized intermittent mandatory ventilation. And what are the indications? To provide a partial ventilatory support. And suppose you start with an ACMV mode, say 1 or 2 days, you think that the patient can be shifted to SIMV mode, so you can always shift the patient to SIMV mode. And also, this also has been used in the olden days as one of the modes for weaning also. And advantages are, respiratory muscle strength is preserved, because patient is allowed to breathe in between, and he is using his muscles of respiration. and decreases the mean airway pressure, because during his ventilation, he is having a negative pressure during his inspiration. So that way, mean airway pressure is much less totally. And I told you, it can facilitate wean. But one disadvantage here is when the patient, you are allowing the patient to breathe in between. So he may not have enough muscle strength. And naturally, his work of breathing, he has to increase his work of breathing to breathe spontaneously in between. So what will happen is, he may go for his muscles of respiration, may go for fatigue, and he may stop breathing at all, or he may stop initiating a breath at all. So that is one of the problem with the work of breathing, this increased work of breathing. The second problem, again, why work of breathing can increase, is the patient has to breathe through an endotracheal tube. So otherwise, if he is breathing by himself, that is different, but he has to breathe through the endotracheal tube, though you have kept a tube of maximum size tube for the patient, but the resistance through the endotracheal tube increases to 5 centimeters from 2 centimeters, and definitely, and once secretion starts accumulating inside, the resistance further increases. So if you are allowing him to breathe spontaneously in between, I don't think he'll be able to meet this increased work of breathing that occurs for that. So what you can do is, you can always give a pressure support for his the spontaneous breaths in between the mandatory breaths, or you can even go for automatic tube compensation. In the next lecture, I think this will be discussed about ATC. Now coming to the SIMV with PS, you can see this. These are the mandatory breaths. These are the mandatory breaths. This is again, the flow is constant. That means it's a volume controlled breath. It is a volume cycled breath also. Now in between, you can see these are the pressure supported breaths. How do you recognize in a scalar? So this is a pressure limited breath, and you can just see here it is flow cycled breath. So these are all the patient's spontaneous breaths are being supported by the pressure support what you have kept. So what are the parameters you keep? So you keep a tidal volume or an inspiratory pressure. Then minimal respiratory rate, you always keep a respiratory rate less than the patient's respiratory rate. Then IE ratio and the pressure support you have to keep, and the triggers also you have to keep. Now coming to pressure support ventilation, this can be used as a standalone type of ventilation or along with SIMV. So now I told you, this is all the breaths are pressure limited breaths triggered by the patient, and cycling is flow cycling. That's how the pressure support ventilation occurs. And you can also add a PEEP. So Dr. Rashmi was talking about PEEP. That PEEP is going to increase the FRC. That FRC increase means better oxygenation. Nowadays, we always have a PEEP. Normally also, when I am breathing, you are breathing, there is some amount of physiological PEEP. That is because of our vocal cords. The vocal cords come in the midline during expiration. They'll apply some amount of resistance for our expiration, and that they produce a PEEP. And normally also, every patient now on a ventilator, we always keep a physiological PEEP of 5 centimeters usually. And that is what is called as the CPAP with pressure support type of ventilation. And how do we titrate? How do you set the pressure support? This is again very, very important. So pressure support can be set by 3 methods. One is you can target a tidal volume. Second thing is you can target a respiratory rate. And third thing, basically why pressure support was introduced was to take over the work of breathing. So work of breathing target. So how do you achieve this tidal volume target? Suppose I want a particular tidal volume, say 6 ml per kg body weight for the patient for his body weight, and I say that 400 ml I want him to have. So I have a pressure support of say 8 centimeters, and he is having 300 ml of tidal volume. I'll increase by 2 centimeters, it gets 350. I'll increase by another 2 centimeters, I get 400 ml. Now this is the tidal volume targeted pressure support. Now that's how you can set. So in the respiratory rate targeted is, suppose you have set up pressure support, but the patient's respiratory rate is too high. So you can start increasing the pressure support till you get a respiratory rate of 20 or 25. So that is respiratory rate targeted type of pressure support. Third is most important thing is the work of breathing. So you set a pressure support and just palpate for the accessory muscles of respiration, especially the sternocleidomastoid. And if the tone of the sternocleidomastoid is high, that means the patient is using his accessory muscles. So it's a workup breathing is high. So you start increasing by 2 centimeters the pressure support, and just again palpate. If the tone of the the sternocleidomastoid has come down and it is not there at all, that means that is ideal pressure support. So indications can be used along with SAMV or a standalone ventilatory mode during weaning, especially. And they have compared SAMV weaning and the pressure support type of weaning. They have found PSP weaning is much better than the SIMV weaning. So advantages: better synchrony between patient and ventilator, because everything is by the patient, whether triggering, and he sets the what should be the inspiratory the amount of inspiration or the limit, that is the pressure limit, and also he sets the respiratory rate and the cycling, everything. So better comfort for the patient, better synchrony, and least definitely needs less sedation. Workup breathing is much less, better oxygenation, and shorter duration of the weaning process. There are certain disadvantages are also there, like each breath has to be initiated by the patient. By chance, because of the drugs what we give, or there is some amount of the central apnea is there, our patient is not able to initiate a breath, because with pressure support ventilation, every breath has to be initiated by the patient only. So then the patient can definitely go for severe apnea. That is one problem is there. And the second problem is, and because if you have not properly set the pressure support, then minute ventilation can come down, and in between, if the compliance and the resistance keep varying, again there will be a problem of minute ventilation. And you cannot straight away start with pressure support as the ventilatory support. So parameters you set already, I told you, the main thing is the triggers and then the level of pressure support. Just to conclude, there are many modes have been introduced, and I have introduced only a few basic modes. Dr. Varun will be introducing more number of advanced modes. But still the basic modes, you can manage 95% of the patients. And it is always better to know about all these modes so that you can be safe to the patient. Thank you very much for the patient listening.
Thank you very much, Dr. Gurdat, for extensive talk on the mechanical ventilation. It is not an easy subject to be understand. Dr. Gurdat made so easy to understand by all our either staff or the students and all the things.
Hope they have
So
understood.
thank you very much, Gurdat, for this. So now I got in a 5 minutes. Anybody wants to ask the questions or clarification, you can. It is open for the clarification.
Any questions from the students regarding basic modes of ventilation?
Our students are focused. Okay. Okay. I think there is no. I think where it is everybody is well understand on all the things. No more questions. By chance, if you got any questions, you can clarify during this time. Thank you very much. I am wind up the session. Thank you very much, Gurudev.
Thank you, sir, for that presentation. I request Dr. Gangadhar, sir, to felicitate our speaker.
Madhuri herself is a photographer. Wow. I will assist you on it.
Thank you, sir. Now I'd like to request our Dr. Srinivas sir to felicitate Dr. Gangadhar sir. Thank you, sir. As we are now thorough with the basics, let's move on to learn something advanced about mechanical ventilation. That is, advanced modes of mechanical ventilation. I would now like to call upon Dr. Varun Bhairappa, sir, Professor, Department of Emergency Medicine, Kempegoda Institute of Medical Science, Bengaluru. Also, I would like to request Dr. Sharat Kumar D. Shah, sir, Professor and Head of the Department of General Medicine, Sri Siddhartha Medical College, to be the chairperson for this session. Dr. Sharat sir brings with him an impressive 37 years of teaching experience in the field of medicine. He's completed his MBBS from Gulbarga and his MD from JJM Medical College, Davangere. He has been recognized for his excellence with the Best Doctor of the Year award from the National Medical Authority and has been honored multiple times as the Best Teacher of the Year. We welcome you, sir, and I would request you to please introduce our speaker.
Good morning. Good morning to everybody. I'm privileged to introduce our guest lecturer named Dr. Varun Bhairappa. Current designation, Professor and Head of the Department of Emergency Medicine, Institute of KIMS, Bangalore. Qualification, MBBS, MD, DNB, FNB, and EDIC. I think might have done many more. I welcome very much, sir.
So good morning all. Very privileged to come here and give a talk regarding mechanical ventilation. I think the stage is set rightly by Dr. Guridat sir and Dr. Ma'am Rashmi. We will be talking about advanced mode. So basic idea of this session would be, I'll be trying to just tell you what the mode means, because every mode is a lecture on its own. So it's very difficult for me to explain in detail. But the basic idea would be, I'll be trying to tell what the mode says, and if somebody tells you that this patient is on this mode of ventilation, what you have to basically understand. Okay, so some of the newer modes of ventilation, which is an extrapolation of the the basic modes which I'll be discussing on. Okay, so the first mode I'll be discussing on is something called as a pressure regulated. I think lot of the first mode I'll be discussing about the pressure regulated volume control. So what is this mode? The basic thing of all the advanced modes you should be knowing is they have a lot of patent modes. All the companies have their own patency, but the basic concept remains the same. So if you have your ventilator which says APC, APV, VTPC, VC, PCVG, that means that it is the same. Yeah, that means it is the same. So what basically this mode is, actually the PRVC means it's a misnomer. So why is it a misnomer? Is the main thing is it is a dual mode. So when I say what is a dual mode, it means that it is using two modes in a particular mode. So you had seen in the previous class that it's a volume control and a pressure control. You have something called as a control variable and which is a variable, and which one is something called as a varying one. So if you see in pressure control, you keep a pressure fixed. What keeps varying is always the volume, right? In a volume control mode, you keep the volume fixed. What keeps varying in the patient is always the pressure. So these are the basic things what a conventional mode does. So you don't have the control over the one which varies. So to negate this effect, we have something called as a pressure regulated volume control mode. So what does it mean is it's a dual mode. So when I say a dual mode, it means that a breath can be either a pressure control breath or a volume control breath. So the ventilator can give in a single patient during a respiratory phase, it can be a pressure breath or a volume breath. So both the breaths can be given in a particular respiratory cycle. So that is an advantage. That is the meaning of a dual mode. So the patient can have an assisted breath, can have a controlled breath. If by chance is completely sedated and paralyzed, that breath can be either a pressure breath or a volume breath. So that is the meaning of a dual breath. But the basic concept is it is not exactly like the volume controlled mode. It has PRVC. So what is this PR with respect to the VC? It is similar like a volume control mode, but there's some difference like a PR. So what is the basic concept of this mode is it gives the defined tidal volume to this patient without changing much in the pressure. That is the thing. That is why it is called as VTPC, that is volume targeted pressure control. So the exact terminology is volume targeted, but this volume targeted is given through a pressure controlled breath or is a pressure controlled volume guaranteed. So normally in pressure mode, you can't guarantee the volume because it keeps changing, right? So it keeps changing based on the resistance and compliance of the lung. But here you have a mode which will guarantee you the volume. And second thing, that volume is given in a pressure form of mode, pressure control mode. So it is safe to the lung. So that is why each breath is given in a pressure control mode. So what are the settings? This is what a normal PRVC mode you have. So the settings what you keep is FiO2. Okay, not much to describe on it based on the patient saturation. You can keep the rate. Okay, you can keep the tidal volume. So you're telling the ventilator, I need 350 tidal volume to be given to this patient in a pressured breath. So in a pressure breath, you can't define the volume in the conventional mode. Here you're defining the volume that I need 350 tidal volume, T inspiratory of 1 second, and a PEEP of 5. Okay, so these are the basic modes settings what you have to give. So how does this ventilator function? So basically what it does is the ventilator first gives 1 or 2 test breaths. So based on the test breaths, imagine it is giving a test breath of 100. So it gives a 100 ml volume and it measures how much is being delivered to the patient. It can be 100 also if it is a healthy lung, but most probably it will not be because you're ventilating for the diseased lung. So it will not give 100. It will give somewhere around 50 or 60. That is again based on the resistance and the compliance of the lung. Then the ventilator, what does it do? It tries to analyze what is the
patient's pressure required to deliver the volume of 350. So it indirectly calculates based on the resistance and compliance what is the least pressure that the ventilator can go to achieve the tidal volume of 350. So it gives two test breaths, then measures the compliance and resistance in the lung based on the feedback it gets. Based on that, it measures the what is the maximum pressure the ventilator can go to give the guaranteed tidal volume. So it sets up that inspiratory pressure. So if you can see here, the first breath is the test breath. I told you the first breath is always the volume breath. So volume breath is always a square wave pattern, like we saw in the previous session. So it is a volume control breath. So you have a square wave pattern. So it gives 2-3 volume breaths. Then it measures what is the inspiratory pressure required to generate 350 tidal volume. So slowly, progressively, it keeps increasing the the pressure to achieve this. So if you see the subsequent breaths are pressure, it's a decelerating flow pattern. It is not the square wave pattern. So subsequent breaths are decelerating pattern, and it at one point it will realize that this is the pressure required to generate 350 tidal volume. So that is an advantage of this dual mode, what we say PRVC, where the pressure is automatically adjusted till the tidal volume is delivered. So here, the advantage when compared to a pressure control mode is, in pressure control mode, I told you in conventional mode, you don't have a control over the volume. It keeps varying. So here you have a mode which can have the least pressure fixed, and the volume is also guaranteed. So imagine in a pressure control mode, you had kept a pressure of 20. So in 20 centimeter of water, it was generating only around 300, 350, which is insufficient. So that time, if you put this patient on a PRVC mode, it is not necessary it has to go at 20 itself. It will go at the least maximum pressure. It can be 22, 23, but the tidal volume generated is guaranteed. So it will make sure whatever tidal volume you fix, 350 or 400, will be given with the least amount of pressure. So keeping in mind the barotrauma, which can cause a complication. So this is an advantage of a PRVC mode compared to the conventional pressure control mode. Okay, so by definition, PRVC has been described as an adaptive targeting mode in which the ventilator uses a feedback mechanism. So I talked to you about what is this feedback mechanism on a breath-to-breath basis. So I told you this is the advantage. It's breath-to-breath basis. So sometimes if the patient during the course of the disease is the lungs are improving, that time what does it do? It's again give some test breaths. And once the test breaths has given, it will measure the pre-inspiratory pressure required to deliver that much of volume. If it finds that it is lesser because the lungs are improving, so the pre-inspiratory pressure has to reduce. So automatically it reduces. You don't have to do anything. So it uses a feedback mechanism by breath-to-breath basis by dynamically regulating the delivered pressures and achieving the desired tidal volume. Okay, so this is a basic concept how a PRVC mode works. Okay. Next mode is a BiPAP mode. Okay, so when we say BiPAP, most of the time we think of the non-invasive wave. So in the non-invasive wave, it is a small I. It is BI is the small I. So it is the bi-level positive ventilation. We are not talking about bi-level ventilation. We are talking about an invasive ventilation where it is called as a biphasic positive airway ventilation, which is BiPAP. So how is it different? So some ventilators, it will be written a duopap or BiPAP, whatever it is, both are the same. It is all company patented terminologies, but the mechanism remains the same. So it's a combination of pressure control and spontaneous mode. So what do you mean by combination of pressure control and spontaneous mode? So normally in a conventional pressure control mode, the patient will not be able to breathe, right? In between, the ventilator will not let the patient to breathe unless it is a assist control. Normal pressure control mode, patient is not allowed to breathe. But here you have used, there is a mode which helps you to breathe in between, being a controlled mode. So what is the advantage of this? So to place the patient on a conventional pressure control mode, you need the patient to be heavily sedated, at least a RAS score of 3 to 4, right? You need sometimes patient to be paralyzed also. So that can help you in oxygenation. That can be the advantage at one point, but other point, it's a disadvantage also because you're keeping the patient on a sedation for longer time. there is very high chances, as we discussed, about muscle atrophy, diaphragmatic atrophy, and weaning becomes a problem. So considering these disadvantages, they got this mode called as a biphasic positive airway ventilation, where a controlled mode which lets you to breathe in between. Okay, so it's the same. The principle remains like the conventional mode. It's a pressure control mode, time cycle, and this bi-level ventilation is always, most of the time, kept with a normal IE ratio. So the normal IE ratio we usually keep 1:2. So the IE ratio in here also will be normally 1:2. So what are the things you need to keep? You need to keep, obviously it's bi-level, so you have to keep two PEEP levels. So you keep something called as a P high. So this is the maximum airway pressure which can be achieved in the system, in the respiratory system, and low airway pressure. So this is something like PEEP, and this is the P inspiratory pressure. So you keep two pressures, two high pressures, and you keep one time. So the time spent on the high airway pressure is called as T high. The time spent on the low airway pressure is called as T low. Okay, but here you'll be setting only T high. You don't have the control of T low. So if you keep a T high, what does the ventilator do is it will automatically get to know what is the respiratory rate it is supposed to keep. If you keep a higher T high, that means the ventilator rate will come down. If you keep a lower T high, the ventilator rate will be high. So you keep a respiratory rate, T high, two PEEP levels. And one advantage here is, in the conventional modes, I told you, you can't breathe. So the expiratory valve is opening only at the time of cycling. So we discussed what is cycling. When there is a changeover from inspiration to expiration, the ventilator will open the expiratory valve and the patient expires. That is called cycling, right? Here, the expiratory valve is open throughout. So patient can breathe anytime. So he can breathe. So if you see here the second graph, here it's a totally controlled. Patient is not making any efforts. Here, if you see, the patient is making efforts even at T high. Patient is breathing even at T low. So this is an advantage. So patient can breathe even at a higher pressure and a lower pressure. Okay. So the IE ratio depends upon the ratio of T high to T low. So the IE ratio, you want to vary it. You want to keep 1:2, 2:1, whatever it is. You have to do variation with respect to Ti and T low. So most of the ventilators, when you fix Ti and T low, in the side, it will show you what is the expected IE ratio also. Okay, so this is a thing of bi-level, biphasic positive airway pressure. So the advantage of this is lesser sedation is required. Patient can be easily fasterly weaned because he'll be breathing even at the lower pressure and higher pressure. And the main advantage is, what we say is, the lungs which are recruited will not get de-recruited fast. So because the patient is able to breathe at the higher pressure, so de-recruitment of the lung is less compared to any other patient. So when we say de-recruitment, most of the time we'll tell it with respect to ARDS. So in ARDS, you don't want the lung to collapse very quickly at the end of expiration. So what happens if the patient is breathing at two airway pressures? There is some amount of pressures which is always applied. So the diseased lung or the alveoli will not collapse. So de-recruitment is less chances in biphasic positive airway ventilation. Okay, so the next mode, the newer mode is APRV. Okay, we spoke about bi-level. It's similar to BiPAP. Okay, it's similar to bi-level positive airway ventilation. It is again a combination of pressure control and spontaneous mode. Okay, and here again, what the thing is, you can set two pressures. Okay, here again you're setting P high and P low. You have to having two pressures, P high and P low, two times. Time spent on the inspiration and time spent of expiration. But how is it different from a bi-level? Bi-level, I told you, the IE ratio is always physiological, 1:2. Okay. Here you're spending more time on inspiration and very, very less time on expiration. So if you see here, inspiration is more and expiration is very less. Okay. So when the expiration is very less, what is the advantage? So when there is expiration is very less, patient takes in a breath, you're not even completing your expiration, the next breath starts. So the advantage of this is the alveoli is not de-recruiting. So this mode of ventilation is very useful in ARDS patients where you want more time on inspiration, okay, compared to expiration. You're compromising the expiratory phase because you're worried about the oxygenation. So you want the patient to breathe more in the inspiratory phase and less in the expiratory phase. you are okay for the CO2 buildup, you are okay for a permissive hypercapnia, unless there is a hemodynamic instability. So you are compromising the CO2 for oxygenation. You want the lungs to be recruited. So this mode has an advantage over the bilevel ventilation, where you're taking more time on inspiration. If the patient is on more on the higher level of higher P high, so more lung is recruited, and patient has less time for expiration, so less de-recruitment, so better oxygenation. So this is the main basic idea. So what are the things I already discussed? You keep a P high, T low, P high, P low, slope, and FiO2. So here nowhere you're keeping respiratory rate. So you need to keep that in mind. So respiratory rate, the ventilator assumes or calculates based on the ratio of T high and T low. So whatever T high, T low you keep, that will be the respiratory rate the ventilator tries to keep it. Okay. So if you see the basic differences, I have kept it in one slide so that it becomes easy for you to understand. BiPAP, I told you, it's more physiological. So you want IE ratio of 1:2. So yes, you are keeping some time for inspiration and expiration, but it's more for weaning, more for patients where you want, it's for COPD patients. Okay, these modes, this BiPAP is more for patients for weaning and for patients whom you wean for COPD patients. Here you want to use APRV mode, where you're using more of inspirated time. So it is more for patients with oxygenation issue like ARDS patients. So why this, this time, what basically happens during this fall or during this T low is, imagine a pressurized chamber. You have a pressurized chamber and you leave the chamber pressure for some time. What happens? The pressure drops. What happens during the drop in pressure is CO2 is eliminated. So the patients it's a pressurized alveoli. At one point, obviously, you can't keep it pressurized for longer time. You want the CO2 also to eliminate. So that time there is a release of ventilation. So that is why it's called airway pressure release ventilation. The release is the pressure, and this is the phase where the CO2 is washed out. You can't wash out the whole CO2 because the time is less, but you are compromising that because you want better oxygenation. So that is a difference between APRV and BiPAP. Okay, so this is a diagrammatic representation between APRV and biphasic positive airway ventilation. So I told you a volume is generated, pressure is generated. There is a sudden drop to release the CO2. T low is low. Here the T low, so normally it is 1:1, or maximum you can go to 1:1, 1:4. Here it's the reverse. It is called as an inverse ratio ventilation, where you're reversing the physiological aspect. You're giving more time for inspiration and less time for expiration. So it becomes 4:1. So the T high is always higher compared to the T low, and the ratio is approximately most of the time 4:1. And here it is 1:1. It is still not physiological because 1:2 is the normal limit, but still you can use this mainly for weaning and weaning from COPD patients. So these modes have been used for COPD and ARDS patients. Indications for APRV, we already discussed where you want to recruit the lungs, mainly where the disease process is heterogeneous, like ARDS patients, patients where you can't prone them, especially obese patients, hemodynamically unstable patients, where most of the ARDS net study, if you see, wherever there is a contraindication for proning, these modes have been utilized, where you can use APRV mode for patients who cannot have some contraindications for proning. So recently we had also used this mode for one of the patient who had severe spine injury and with ARDS, right? That time you can't prone these patients. So in such cases, we still use these newer modes where it can be an advantageous for us. Okay. Rest all indications will be for the same thing. Contraindications, you should be knowing where you should not use APRV mode. So you obviously can't use it in type 2 respiratory failure in COPD patients, because I told you, you're giving lesser time for expiration. Obviously the CO2 will build up and you will have the worsening of the respiratory acidosis. So COPD patients, a big no. Second is patients with bronchopleural fistula, patients with pulmonary arterial hypertension. Again, the CO2 will have a problem on the right ventricular function, and it can cause right ventricular dysfunction. So again, you can't use this in patients with pulmonary hypertension. Okay, so settings of APRV, FiO2 100% you start with. And how do you know what is the P high I should keep for this patient? So imagine you are ventilating this patient with a pressure controlled mode. So measure his P plat. That P plat will be his P high. So when you're changing over to PC to a newer mode, just measure the P plat of this patient. P plat will be invariably his current P plat will be his P high. P low is always 0. Theoretically, it cannot be 0. Theoretically, it cannot be 0 because it will never reach the baseline. But as a teaching purpose, we say that P low is 0. T high, normally we keep between 3 to 8 seconds. Okay, midpoint 5 seconds. T low, usually we keep 1/10 the value of T high. So if you kept 5 seconds as T high, 1/10 the value is approximately is the T low. And always when you're ventilating these patients, what is the important thing is look at the peak expiratory flow rate. So here I've given you an example. What should be the normally when you see the ventilator graphic, how the expiratory flow should look like. So if in the APRV mode, you want the expiratory, you want basically more time for inspiration. The expiratory, the expiratory limb should not touch the baseline and then the expiration begins. Then it becomes like a conventional mode. So the no use of it. So you want this inspiration. You don't want the expiratory valve to come almost, to the end of expiration and the next inspiration begin. So this is like what happens in auto peeping, right? This is on some of the example like auto peeping. You don't want this to occur. You want it to occur at the 75% of peak expiratory flow rate. So at the 75 point of expiration, the inspiration should begin. So that is where it is advantage. That is where the recruiting of the lungs begin. So this is how the graphic looks. So if you have any discrepancy in this, what you have to do is you have to adjust the T low settings by 0.1 seconds. So normally we adjust the T low to 75% of the expiratory flow. So we will change it by 0.1 second. So here, if you have seen at 0.6 seconds, it was ending here. We don't want this. We want more lungs to be recruited. So you try to decrease the T low so that the expiratory valve, the expiration limbs begins at the 75%. Okay, next mode we'll be talking about is adaptive support ventilation. So adaptive support ventilation is a mode that selects and continuously adapts to the respiratory rate, tidal volume, and inspiratory time depending on the patient's lung mechanics and efforts. Breath to breath, 24 hours a day from intubation to extubation. So this is what is the definition. So what the conventional modes we're doing is you fix something, it's fixed throughout the 24 hours or throughout the next shift or throughout the next time you change it, it is fixed. So ventilator will not do anything what you have told. So these smarter ventilation modes, what we say as, the newer modes, they use something called a feedback mechanism. So they keep taking the feedback from the patient. So you don't have to go and physically change the respiratory rate, tidal volume, keep monitoring the airway pressures. So automatically the ventilator starts doing it. It takes the feedback, the next breath it changes. So breath to breath, every time it keeps changing based on the resistance and the compliance. So if the resistance and compliance is poor, it will increase some variables. If the resistance and compliance is improving, it will decrease some variables. So that is the meaning of this adaptive support ventilation. So it's called as a closed loop ventilation. So closed loop ventilation means it is taking the feedback from the patient. It's a closed loop. It takes feedback from the patients and adjusts its own ventilator settings. You don't have to do anything. Okay, so it's good for optimal breathing. It reduces, obviously it's taking a feedback from the patient. The work of breathing is also reduced. So what are the parameters you can fix? So there are only 3 parameters you can fix. One is minute ventilation. Second is PEEP and FiO2. So only these 3 parameters you're fixing on the ventilator. No other parameters you're fixing. So if you see here, you're just fixing what is the percentage of minute ventilation the ventilator has to support. So initially, obviously, you want the whole minute ventilation to be supported. You start with 100. And next is PEEP and next is oxygen. So only these 3 parameters you set, the ventilator itself does all the things. So how does this ventilator do? So you have kept a minute ventilation of 7.5 liters. Imagine you have kept a minute ventilation of 7.0 liters. For 1500 into 5 is also 7.5 liters. For 150 into 50 is also 7.5 liters. So the most physiological is 50 into 500 into 15. So it plots a graph as per the minute ventilation. The minute ventilation is set based on the ideal body weight of the patient as well as the patient's height. So once you fix these parameters, it fixes the minute ventilations. And once the minute ventilation is fixed, it plots a graph. So this graph will be plotted on the ventilator. So once the graph is plotted, it does something called as a RT, resistance to compliance time constant. So it is based on the resistance and compliance. Based on the patient's input, it does the RC time constant. So normally RC time constant is 0.6 to 0.9. So basically what it does you fix these parameters. You fix the minute ventilation. So you tell that I want 8 liters to go to this patient. So you just fix based on his ideal body weight. And you measure, you tell this, I don't want this volume to be gone beyond a particular pressure. So you keep also fix the airway pressures. It gives 3 breaths to the patient. Once it gives 3 breaths, it will tell for this minute ventilation, I will require this much inspiratory pressure. The ventilator calculates. This is the rate I have to keep. Then it takes the feedback from the patient. What is the RC time constant? I told you what is the resistance complements. It will take the RC time constant. It will see the ratio. It also tells what is the patient's efforts, how much is he breathing, how much tidal volume he's generating. So based on this, again, there is a algorithm which is there, which will alter the inspiration and the tidal volume and the respiratory rate. So based on this, what happens? The tidal volume and the respiratory rate is fixed. So the minute ventilation will be given based on the feedback it gets from the patient end, and also what is calculated from the ventilator. So this is called as adaptive support ventilation, which has an inbuilt algorithm, which acts like a closed loop where it takes the feedback from the patient. You just fix only 2 or 3 parameters. It gives some breaths, finds what is the resistance and compliance, determines what could be the P inspiratory and the total rate. And again, it takes the feedback and it alters the P inspiratory and the respiratory rate. So this is called, it's adapting. So every breath, it keeps adapting and it keeps delivering the inspiratory pressure and the respiratory rate to achieve that minute ventilation. Okay, so if the graph, I told you the graph. So I told you this is the most physiological to attain this tidal volume, attain this minute ventilation. So if you see the plus point, normally when you start ventilating, the plus point, you have to see where it is. That plus point should be as close as to this. So if the plus point is somewhere in this zone, that means the tidal volume is more than the target. The respiratory rate is less than the target. So you have to increase the inspiratory rate and increase the respiratory rate. If the plus point is falling somewhere here, that means the volume is less than target, respiratory is more than target. So what is the intervention you need to do? Increase the inspiratory pressure, decrease the respiratory rate. If the plus target is coming here, that means the patient is going to apnea or hypoventilation. You have to increase the inspiratory pressure and increase the respiratory rate. So basic thing is this plus point should be as close to this dot point. This is what the ventilator tells. This is the physiological minute ventilation which can be given to this patient. So this plus point should be as close to this, the target point. Okay, last 2 modes, volume support mode. So volume support mode is like your pressure support mode. It's a spontaneous mode. So what we discussed in the previous session was in pressure support, you fix a particular airway pressure and the volume keeps varying in a spontaneous mode. So you don't have control over the volume. So again, it's a closed loop ventilation for spontaneous mode. So what does the ventilator do is you tell the ventilator that I want 300 volume to be given. We are talking during weaning, not ventilation. During weaning, I put the patient on a volume support and I want to make sure that at least 300 volume is being given during his weaning phase. So you keep FiO2, tidal volume, you tell I want 300, PEEP, trigger and slow. So what does it do is ventilator, it's just like a pressure support. So it gives a particular pressure and measures the volume. So if it feels that the volume is adequate, it does not increase the pressure support. If it feels it is inadequate, you can see it slowly increases the pressure. So this is a mode very useful in weaning as a part of pressure support, especially in patients who you have kept on long-term ventilation. You finish your controlled mode, you come to pressure support mode. And in pressure support mode, sometimes you're not sure the patient is too weak. He might not generate that much tidal volume. He might hyperventilate, especially in the night. There was a joke what sir was telling. In the night time, suddenly you put the patient on pressure support, suddenly you find he has gone into a cardiac arrest because of respiratory acidosis, especially in OP poisoning patients where, it's very difficult. The muscle weakness can, recur anytime. In such patients, volume support mode would be an advantage because you have prefixed a volume, and the ventilator itself will increase its pressure support to meet that demand of pressure support. Okay, so this is a very good mode for weaning in patients who are chronically on a ventilator. The last mode I want to discuss is a NAVA mode. Okay, so it is neurally adjusted ventilatory assist mode. So in NAVA mode, what is the advantage of this is all these things what we are saying is, yes, it is physiological, but we don't know it is not exactly physiological. So there is a lot of asynchrony. The ventilator and the patient keeps fighting always unless they're completely sedated and paralyzed. So once you remove that sedation and paralyze, there's always the ventilator gives the breath, the patient does not want or wants more. So there's always an asynchrony. To prevent this asynchrony, we have a tube like a Riles tube, which goes to the lower end of esophagus. That is where the diaphragm is, and it starts measuring the diaphragmatic contraction. So if the diaphragm is contracting, that means that patient is making effort. So once it comes to know the patient is making effort, then the ventilator gives some support. So that is the meaning of neurally adjusted. So you're taking the neural signals, which is most physiological. You're taking it from the diaphragm, it picking up the diaphragmatic signals, and then it is giving the breath. It is almost like the signals coming from the brain. So that is what the meaning of neurally adjusted ventilatory assist support. So it uses the cruel portion of diaphragm. It finds out what is the electrical activity of the diaphragm using a nasogastric tube. The nasogastric tube end has a bipolar electrodes. That is how it measures the electrical activity. And the peak inspiratory pressure is calculated using this formula. NAVA level into the maximum diaphragmatic contractility minus the minimum diaphragmatic contractility plus PEEP. Yeah, last slide. So the basic thing is you have to adjust the NAVA levels. So the NAVA levels, how you adjust is you keep it in the range between your 0.5 to 3. So when you're adjusting this NAVA levels, you should make sure the diaphragmatic activity is between 5 to 20 millivolts. So if the diaphragmatic activity is less than 5 millivolts, that means it is the patient is under responsive. So you should make sure the NAVA levels are decreased more. It's always the opposite. If the EDI levels are maximum, then you have to increase the EDI, the NAVA levels. So basic things as a resident, what you should know is it will measure the electrical activity from the diaphragm and then supports it. It's more physiological. It prevents asynchrony. It reduces the need for sedation and paralysis. So that is a basic thing you should understand with these modes of ventilation. Okay, last mode is this is a very new mode of CPR ventilation. What most of the time you have seen during your CPR, the alarms keeps going and it will not be delivering. And we always say disconnect it from the ventilator and put it on a manual breath and use one more personal. So this mode of ventilation in the newer modes of ventilation, if the patient goes to a cardiac arrest, you just press the CPR button. So once it presses the CPR button, automatically the FiO2 goes to 100%, PEEP goes to 0, and the peak inspiratory pressure goes to 60. So even if you're giving a 60 centimeter pressure, the volume will be delivered. That is a basic thing. So it goes to 60 and it becomes a volume control mode. So you just have to keep volume and respiratory rate. So as per the AHA guidelines, we keep somewhere 512 respiratory breaths. So even if during a CPR, when the compression is going, even the chest is compressed, the volume will be delivered. So this is a newer mode of CPR ventilation, which is coming in most of the ventilators. You don't have to disconnect the patient or use one more personal at the head end for the ventilation. Okay, to summarize, older modes have to be, there as we already discussed, it will solve 80 to 90% of all your disease conditions, but newer modes, you should be aware of it, where in what condition to be used, because if you're not well versed with it, you're going to do more harm to the patient. So it is a feedback mechanism what we use. So it is always individualized approach. So each patient is feedback is taken. So not all ARDS is the same. So every patient ventilation requires different ways. So that is why it is patient centric, and that is where you can use the advantage of this newer modes. It takes the feedback and very less parameters to be set. So that is one more advantage for in the newer modes. Okay, but obviously it requires expertise. Thank you for it. Any doubts?
Thank you, Dr. Varun Berappa. You are really covered from basics to near advances. Like last in the 10, you told larva something like that. So you are putting a tube to the nasogastric tube to know the electric stimulation. That's one a wonderful message for all the upcoming doctors. Usually they have not come across that one. I think they may be using for the better facilitation of the patient or to come out of the ventilator. I think that is a new point. I really congratulate you. Very nice. And I think this is a real teaching for almost all the doctors, not only new doctors like us, old doctors also, and a new teaching. Thank you very much. Thank you.
Thank you, sir.
Thank you, sir, for the insightful presentation on this complicated topic. I would like to request Dr. Sharat Kumar, sir, to felicitate our speaker. Thank you, sir. I would like to also request Dr. Srinivas, sir, to felicitate our chairperson for this session.
Thank you so much, sir. Problems are a part of life, and we as clinicians are well versed to solve them. On the same lines, we have our next topic, troubleshooting in ventilator. Let us welcome our next speaker, Dr. Vasudha D. Ma'am, Assistant Professor, Department of Emergency Medicine, MS Ramaiah Medical College, Bengaluru. I would like to invite Dr. T.S. Anand Kumar, Sir, Professor and Head, Department of Pediatrics, SSMC, to chair this session. Dr. Anand sir has over 20 years of teaching experience in pediatrics and has guided many postgraduate students as a postgraduate mentor. He is also an active member of the Pharmacovigilance Committee at our institution. He is a certified trainer in the basic NRP neonatal resuscitation program and has contributed to academic research with 6 original research articles and 2 case reports published in the national and international journals. He is a life member of the professional bodies including the IMA, IAP, IDA, IAP, and the respiratory chapter. We welcome you, sir, and we request you to give a brief introduction of our speaker.
Thank you, sir. So I'm very happy to introduce the speaker, Dr. D. Vasudha. She has done her MD from JIPMER and DNB in Emergency Medicine, and presently working as Assistant Professor, Department of Emergency Medicine, MS Ramaya Medical College. She is a rank student, second rank in MBBS, and done her MD from JIPMER, and certified AHA and instructor, ATLS instructor, and she has more than 10 publications in national and international journals. Areas of interest: emergency care, cardiac emergencies, acute trauma, and focus. She will be delivering the lecture on troubleshooting in mechanical ventilation. Welcome. Over to you, madam.
Thank you, sir. So good morning, everyone. Since morning, we had the opportunity to hear lectures from great teachers. So are you guys still with me? The delegates? Sleepy? You want to stretch a bit? You can stand for 10 seconds and sit down. Come on, all the delegates. Stand, stand. You can stretch for 10 seconds because this topic is very important for your day-to-day clinical practices, especially in the ICUs and the emergency departments. Yeah, awake? Okay, you can sit down. So now we'll have a discussion about troubleshooting ventilator alarms. So before going to troubleshooting, whenever there is a problem, there's an alarm on the ventilator. So what is the tendency you do? Do you go check? Yes? Yes? How many of you check? Really, but what I have seen, most of the people in my hospital go and mute the alarms because it is making a lot of noise. So you're not supposed to do that, at least after this lecture session. So why there is alarm? For the patient safety. So what is our duty as physicians is to troubleshoot it. So what are the alarms on the ventilator? So as the physicians on floor, at the end of each shift, you have to go to the ventilator and set the lower limit and the upper limit. For what all you should set, at least for volume, pressure, and rate. Otherwise, the ventilator also has auto settings, which is 10 to 15% of the patient's parameters. So American Association of Respiratory Care has divided these alarms into 3 categories. So one is the level 1, which is immediately life-threatening alarms like apnea, circuit disconnection, electrical power failure. Then we have level 2, which is potentially life-threatening alarms like high or low airway pressures, high or low exhale tidal volume or minute ventilation. And then comes the level 3, which is non-life-threatening alarms like high rate during a procedure. So what is the problem with these alarms? In ICUs or in the emergency departments, are there only the ventilators which are on, which is producing noise or which are on alarms? Is it? So what else it can be there? So there can be monitors, there can be infusion pumps. So what they tell is per patient in a day in an ICU, there are more than 150 alarms, of which more than 95% are non-life-threatening alarms or not important alarms. So, but what happens? You have heard that wolf story, right? So every day a person will be telling there's a wolf, but he'll be lying. So nobody will believe him when actually wolf comes. That's what happens. So since there are so many alarms every day and we are immune, it will lead to desensitization. So whenever there is an actual alarm, nobody goes and sees it or nobody addresses it. So that will lead to desensitization. So we can miss critically important alerts and compromise on patient care and safety. So coming to how to manage this alarm fatigue. So one thing, testing and calibration, and very important for us is patient specific alarm setting should be done. So now that we know the alarms, let us go to troubleshooting. It's not you go and shoot the ventilator. So as I already told, goal of troubleshooting is patient care or patient safety. So the first and foremost step is, at least at the end of this class, you're not going to mute the alarm. Do not mute or silent the alarm because there is some problem with the patient or tubings or the ventilator. So whenever there's an alarm and you have a patient on ventilator, do the risk assessment, see if the patient is having life-threatening hypoxia or non-life-threatening hypoxia. What are the hemodynamics of the patient, whether he's stable or unstable? Always start with clinical examination. We don't want to treat the machines or the sound, right? We want to treat the patient. So start your troubleshooting with clinical examination. So look at the chest and auscultate the chest. So what do you want to look? Chest expansion and the ET tube marking. Auscultate the chest for air entry, breath sounds, and any added sounds. Next, you look at the ventilator parameters. We'll have a discussion on what all to look. Then you can always use adjuncts like saturation probe, EtCO2, then point of care ultrasound, X-rays, and ABG as and when required. So this we already discussed in clinical examination. See the vitals of the patient and examine for air entry and added sounds. So coming to ventilator parameters, so the basics of ventilation, we have already discussed most of the things. I just want to highlight very important things. So in any ventilator, you have 5 graphs, of which 3 are scalars and 2 are loops. So what are the 3 scalars? It is either pressure time scalar, volume time scalar, or flow time scalar. 2 loops are pressure volume loop or flow volume loop. So these are the 5 graphs which will be there on ventilator. So as ma'am already told in the morning, so 2 important pressures we should be aware of. So what is peak pressure? It is the pressure which is generated by the ventilator to overcome both the airway resistance and the alveolar resistance. That is peak pressure. So what is plateau pressure? So the pressure which is inside the lungs after the tidal volume has been delivered, which reflects the alveolar compliance. So why this is important? Because there's something called as peak pressure and plateau pressure gradient. So normally it should be less than 5 centimeters of water. But if it is increased in airway resistance, so whenever the ventilator beeps an alarm of high peak pressures, what is the next step you are going to do? So we don't know whether the problem is because of airway resistance or with the lung compliance of the patient. So always put inspiratory hold. So when you put an inspiratory hold, what happens when you put an inspiratory hold? There is no flow happening, right? So the flow is cut off. So there is no airway resistance which is contributing. Then you will have 2 things. So one is elevated peak pressures with normal plateau pressure, or elevated peak pressure with elevated plateau pressure. So this is a very important slide. So as you can see in the first slide, so there is high peak pressure. Alarm was for high peak pressure. You put inspiratory pause. So then you saw that the plateau pressure is normal. So now the difference between the P peak and P plateau is more than 10. So there is some problem with the resistance. So this resistance can be contributed by your endotracheal tubes, ventilator circuits, or even the trachea, that is bronchospasm. So there can be small ET tube, kinking, biting, high flow rate, mucus plug, blood clot, or bronchospasm. There was a high pressure alarm, and then you put inspiratory hold, and you see there is a high plateau. So the difference is less than 10. So that means there is some problem with the compliance of the lung, which can be n number of causes like ARDS, pneumothorax, pleural effusion, air trapping, and others. So yes, I want somebody from the delegate to tell. This is a flow time scalar. So what do you see here? What is this? Yes, ma'am. You will know. Yes, as ma'am rightly said. So this is intrinsic PEEP or auto PEEP. Okay. So normally So what should happen? This is inspiration, this is expiration. It should touch the baseline and then next inspiration should start. But because of air trapping, the expiration is not complete. It is not touching the baseline. So there is intrinsic PEEP or auto PEEP. These are few important terminologies we need to know for understanding troubleshooting better. So that's why I'm re-emphasizing on it. So then this air trapping, so that was we saw on flow time scalar. So the same thing in flow volume loop. So normally it should be complete, but the expiration is not returning to the baseline. So this is air trapping or intrinsic PEEP. So this is the next graph where there is volume time graph. Now only the delegate. So what is there here? If this is there, what do you suspect in the patient? This. So volume is not complete. No, it's not returning the baseline. So what is happening? So there is leak. So there is leak. So if the leak can be, where leak can happen, where all leak can happen, there can be circuit leak, there can be your ET cuff leak, or even there can be bronchopleural fistula. So now let us come to the actual troubleshooting. So it depends on two scenarios, whether your patient is in distress or not in distress. So let us now assume that the patient is in distress. So next, what you have to do, you should disconnect the patient from the ventilator and bag with 100% oxygen. So then you see if the relief is there or not. So if there is relief, then it means the problem was with the patient or the ventilator. You should respond. Problem is with the ventilator. So there is some problem with the machine. If not, there is no relief, then the problem is with the patient. So no relief with bag and mask ventilation. So there is some problem with the patient. So then we'll see if the airway is obstructed or not. How do you see? So you're bag masking, right? So you will see if you're having any difficulty in bag and mask. So if yes, so there is some resistance happening there. So it could be tube would have been kinked. So you adjust the head position of the patient. Patient might be awake and patient may be biting the tube. So you can insert a bite block, or in rare case, you can even deeply sedate, not paralyze the patient. Then there can be some mucus plug or secretion present there. So you can suction and then see if there is relief or not. If you have done all this and still you have obstruction for bag and masking, then you have to change the ET tube. But you are bagging, but there is no obstruction. You're not feeling any resistance to bag and mask. So then what do you do? There's no significant airway obstruction, or there is no obstruction present in the tube or in the airways. So then you'll have to see if there is any problem with the lungs. So then you auscultate the patient. So where all you want to auscultate, sometimes the tube, so patients will be shifted, no? So from emergency to ICU to investigations. So tube might have been displaced, dislodged, or accidental extubation also could have been happened. So you auscultate, 5-point auscultation, epigastrium, here for gurgling sounds. Then you auscultate for bilateral air entry. Suppose one side there is good air entry. For example, right side there is air entry, but left side there is decreased air entry. So what do you suspect most commonly? Yes? Right? Main stem intubation would have been there. So you can just pull out the tube and adjust and again reassess. If not, if you're auscultating, there is right-sided air entry reduced. So there can be pneumothorax or hemothorax or pleural effusion or lung collapse, you don't know. So always remember your clinical examination is what matters the most. So your MBBS knowledge you should not forget. So you percuss, if you hear tympanic note, then there might be a pneumothorax. In a stable patient, get a portable X-ray. Unstable patient, if you have point of care ultrasound and lung sliding is absent, you can go for needle decompression and tube thoracostomy later. If on percussion there is a dull note, so there can be mucus plug which is blocking, causing collapse. So bronchoscopy you can ask for, or there can be effusion which might need thoracocentesis. So all this is to troubleshoot a patient if the patient is in distress. Okay. Now, a patient is not in distress, but the ventilator is beeping. So there is low tidal volume alarm. So whenever there is low tidal volume alarm, so the next thing you have to see is look at the pressures. So whether the airway pressure is low or airway pressure is high. So as we already discussed, if the airway pressure is low, what do you suspect? There is leak somewhere in the system. It can be in the circuit or ET tube disconnection. So check where is the leak. So whenever you're suspecting leak, again you are bag and masking the patient and you feel that you don't have any resistance. So okay, it's very minimal resistance. So then next what you have to do is you can auscultate the neck, because some air leak you can hear in the neck for sounds. Or you can also place a hand near the mouth and confirm the leak. So if you're suspecting cough leak, so what is the next step you do? Come on, you would have seen this, no? In your ICUs or EDs. So if you're suspecting a cough leak, so what do? Inflate the cuff. Excellent. So first thing is I'll try to inflate the cuff. So if I'm inflating and the sounds disappear, then my problem is solved. So if not, sometimes the leak might improve and again you can hear the sounds. So there may be small puncture in the cuff. So you might have to re-intubate or change the tube. So that was when you had low tidal volume with low pressures. So next is one more thing can happen. So the leak, it might not always be cuff leak. So there can be circuit disconnection. So you should always look at the inspirator limb, expirator limb, and the humidifier. Are they connected to the ventilators or not? All this you have done, but still the ventilator is alarming. Then maybe someone at the start of the shift wouldn't have set the limits properly. Correct. So they wouldn't have set the lower limit properly. That's why it is beeping. It is not set to the patient's parameters. So then check the ventilator limits. So then we had low tidal volume and high pressures. So this we have already discussed. High pressures can be, if high pressure is there, next step what do you do? Are you sleeping? No. So if high airway pressures are there, this we discussed, right? Next step what do you do? Yes, excellent. So you have to put inspiratory hold and check for plateau pressures. So if there is normal plateau pressure with high peak pressures, what is the problem? Resistance, airway resistance. If both are elevated, peak pressures and plateau pressures, what is the problem? Compliance, decreased compliance. Okay. This we have seen, we'll skip. I just have 5 minutes. So any doubts with the low minute ventilation and pressures? If not, high minute ventilation alarms can be there if the patient is physiological causes, pain, anxiety, metabolic acidosis, all these can cause high respiratory rate, in turn can cause high minute ventilation and high tidal volume alarm. So address the underlying cause. Go to case scenarios. Yes, I'll discuss case scenarios and then we'll wind up. I want anybody to volunteer for the first case scenario, otherwise I'll pick. So who wants to read the first one? Somebody from the back? Yes, come on. It's going to be simple. It's just a learning activity. Nobody is going to judge you. And I'm sure you will answer it rightly if you have heard the class. Can you stand up? Yes. Read the first one. Yes. You're working, you're an anesthetist or emergency physician?
Emergency.
Emergency. So, okay, you're in the ED and this patient is there and there's alarm. Luckily, you have gone and seen in that busy ED. So, there is high peak pressure alarm. So, what do you want to do next?
Inspiratory hold. And check for plateau pressure.
What do we have to begin with? Are we treating the ventilator or the patient?
Clinical examination. of the
Yes,
patient.
excellent. So you have to do clinical examination. So you have done. Then this is a clinical examination. Patient is tachycardic, tachypneic, blood pressure is okay, saturation is 88%. On examination, you hear wheeze. There is accessory muscle of respiration which is being used. So then now you have some diagnosis in your mind, right? So now next what you want to do? You have seen the patient. Then next is
There is severe bronchospasm.
yes. So clinical examination of the patient, there is bronchospasm. You can confirm it. So after clinical examination, next what do we do? You look at the ventilator parameters. So you have seen. So this is a ventilator graph. What is there? See, the pressure limit was at 40 centimeters of water, but the patient is taking more than that. So there is high airway pressure. Correct? You agree? Everybody agrees. It is not only for him. Everybody agrees there is high pressures. So that was high peak pressure was there. So next, what do you do?
Give bronchodilators.
How are you sure that it is only airway resistance and nothing to do with compliance?
Inspiratory hold.
Yes, you want to perform inspiratory hold. You have done that. Now what do you see? Yes? Yes. So there is increased peak pressures, but plateau pressures are normal. So now what do you suspect? Now your diagnosis is becoming clearer, right? With your clinical examination and ventilator parameters. You saw high peak pressures, then you did inspiratory pause, then you saw there is high inspiratory pressure, normal plateau pressure. So now you have a diagnosis. So what is it? Yes?
Airway resistant.
Airway resistant, excellent. So in this patient, what are you suspecting? Airway resistance can be in the tubings, ET tube, or patient's trachea or bronchioles. So what do you suspect?
Bronchospasm.
Bronchospasm. So how do you troubleshoot it?
Nebulize or bronchodilator patient.
Yes. So the clue was, so there was high peak pressures, but plateau pressure was normal. And on clinical examination, there was wheezing, accessory muscle of respiration, so severe bronchospasm contributing to the airway resistance. So you can administer bronchodilators and adjust IE ratio. Thank you. Very good.
Thank you.
Next, second case. We have to wind up the class. Pass the mic behind you. Yeah, some delegate you can give. Next delegate, whomever you find, you give the mic to them. Everybody is telling no. Take. CKD patient with right IGV dialysis sheath inserted on day 2. Inserted on day 2 of ventilation, is in distress on ventilator. This was the ventilator parameters.
Mode VCAC, tidal volume 400 ml, FiO2 38%, PEEP of 30 centimeter H2.
Yes, you have a CKD patient who had his right IGV inserted, and those are the ventilative parameters, and there is high peak pressure on ventilator. So what do you do? Same, it is the same routine. Yes, excellent. Clinical examination. So this is a clinical examination. Vitals of the patient, tachycardic, tachypneic, in hypotension, saturation is 85%.
Pneumothorax.
Don't jump into the diagnosis. This is what everybody does. Go step by step. Why do you tell it is pneumothorax? It can be pleural effusion, hemothorax, anything, right? Yeah. So you have done a clinical examination. So then in clinical examination, there is hyporesonant note. So now you're thinking of pneumothorax. But next, you want to see something on ventilator?
Pressure.
Yes. So for that, what do you do?
Inspiratory hold.
Inspiratory hold. What do you expect plateau pressures to be? Normal, elevated? Elevated. So you performed inspiratory hold. So peak and plateau pressures both are high. So problem is in resistance or compliance? Compliance. So now everything is fitting into place, right? So you did a bedside X-ray. This is there. So what is it?
Pneumothorax.
Right-sided pneumothorax. It is just pneumothorax, or what is it? We have a stable or an unstable patient.
Unstable.
His hypotension and tachycardic. So this is tension pneumothorax. So what do you want to do? Troubleshoot it by needle thoracostomy followed by ICT. Thank you. Very good. Next, last two scenarios. This is very easy. Give it to her. Nobody from that side? So post-operative patient, the low volume alarm sounds are there on ventilator. You hear this, I'll only do, it's very easy. You hear air rushing from the circuit and circuit connection near the patient. These was the ventilatory parameters. So exhaled tidal volume is just 150 ml. So that's why alarm was beeping. So it's low pressure or low volume. So on examination, patient is intubated, but still there is no chest raise happening. Audible hissing sound of air escaping. So there might be leak. So circuit disconnection might be there. So this was the volume time scalar. So there was leak. So circuit disconnection. Go and correct it. So last case. You can tell. 68-year-old COPD patient is on mechanical ventilation. I think nobody wants to break for tea or lunch or next session. You can tell. Read the next, last one.
PI is 0.8 seconds.
So patient appears fighting the ventilator.
Fighting the ventilator.
Yeah. So clinical examination.
Distant breath sounds, hyperinflated chest. So fighting the ventilator. Active expiratory effort. The jugular venous distension is that due to high intrathoracic pressure.
So you've done the clinical examination. Next you want to look at?
Inspiratory hold. Peak plateau.
You don't want to see the ventilator graph. This is what graph? Is it pressure time scalar or volume time scalar or flow time scalar?
Flow
time scalar. Only the negative graph which you see, if you want to remember it easily, it's flow time scalar. So what is there in flow time scalar?
Auto PEEP.
Auto PEEP is there. So yeah. So what do you want to do? How do you want to troubleshoot? So why I'll just summarize. So why auto PEEP is important? What is happening in auto PEEP? So you're not able to. So normally when you inspire, there is negative intrathoracic pressure. When you expire, the alveolar pressure and the atmospheric pressure will come to equal. So it will become 0. But in auto PEEP, because of air trapping, there is hyperinflation of the alveoli happening. Complete exhalation is not happening. Okay, so there's some amount of air which is left even after expiration. So there will be alveolar distension. So why this is important? What happens when there is auto PEEP? Your intrathoracic pressure will rise. When intrathoracic pressure rise, venous return will reduce. If venous return reduces, what is going to happen? Preload reduces. So if preload reduces, cardiac output will reduce. So patient will go to hypotension. And also right ventricular afterload is increasing. So pulmonary vascular resistance also increase. So it's a vicious cycle. So it's very bad for the patient. So that is why we should pick up auto PEEP. So auto PEEP can be because of numerous causes. So one of which is increased airway resistance. So increased airway resistance could be intrinsic or extrinsic cause. So in intrinsic, we commonly see is in COPD patients. So they will have dynamic expiratory flow. They will not be able to expire the air. So there is dynamic hyperinflation and expiratory flow limitation. So to troubleshoot it, what we have to do is we have to increase the expiratory time. We want to give the patient time to complete his expiration. So if the patient is intubated and you're suspecting auto PEEP, so what you can do is you can increase the expiratory time, or you have to reduce the minute ventilation. So reduce the tidal volume and respiratory rate, and so that the expiration time will be more. One more thing which they tell is you can also apply extrinsic PEEP. Okay. we'll end with that. So how extrinsic PEEP is going to help to overcome the auto PEEP. So you can see in the second image. So there is patient is having an intrinsic PEEP of 15 centimeters of water. Okay, so normally, as I told, when there is no auto PEEP, at the end of expiration, your airway pressure and alveolar pressure, atmospheric pressure, all will be 0. So during inspiration, you're able to generate a negative intrathoracic pressure so that inspiration happens. But in auto PEEP, already there is 15 centimeters of PEEP. So for a patient to initiate inspiration, he has to take so much negative breath that from 0, he should take minus 15 centimeters of pressure. He should generate that much of negative pressure for inspiration and airflow to happen. But if you apply external PEEP, suppose in ventilator you set about 8 or 10 centimeters of PEEP, external PEEP. So then the pressure difference between them, suppose you're keeping 10 centimeters of water as external PEEP or extrinsic PEEP, he has to generate only minus 5 centimeters of negative pressure to trigger the inspiration. So that is how auto PEEP is going to help. Okay, so with that, we'll end the session. Thank you. Hope you understood something, and next time you'll not mute the alarm. Thank you. And I also want to thank the organizers and Ramaya Medical College for giving me this opportunity. Thank you very much.
Thank you, ma'am, for the informative presentation. I request Rashmi ma'am to come forward and felicitate our speaker along with Anand sir. Thank you, sir and ma'am. I'd like to also request Dr. Srinivas sir to felicitate our chairperson for the session. I'd like to also request Dr. Gangadhar sir to felicitate our chairperson.
We now move to one of the most important segments of today's CME. It gives me immense pleasure to introduce our panel discussion on emergency management of respiratory failure, where our distinguished experts will share their clinical experience, practical insights, and evidence-based approaches. Hence, I would like to invite our panelists, Dr. Balasubramanya Hetzer, Professor, Department of Anaesthesia, Vijayanagar Institute of Medical Science, Ballari, Dr. Sahana G. Ma'am, Associate Professor, Department of Emergency Medicine, Vaidehi Medical College, Bengaluru. Dr. Abhishek HB Sir, KB Sir, Assistant Professor and In charge HOD, Department of Emergency Medicine, Chamrajnagar Institute of Medical Science, Chamrajnagar. Dr. Ganesh BS Sir, Professor, Department of Emergency Medicine, SSIMS Davangere. I would also request Dr. Sumalata A. Ma'am, Assistant Professor, Department of Critical Care Medicine, Adi Chinchingiri Institute of Medical Science, to assume the role of moderator for the panel discussion. Dr. Sumalata Ma'am is a PhD scholar at JSS University. She serves as a managing director of Mysore Healthcare and Research Innovation. She is affiliated with JSS and Adi Chinchingiri Universities and MHARI. She has received several recognitions, including the Prime Minister Fellowship for Doctoral Research in 2022, the Young Talent Hunt Award at Critical Care 2023, the Young Speaker Search Award at Criticare 2024, and the Best Poster Award at Criticare 2025. She was also awarded a scholarship from the Foundation for Excellence, an American NGO supporting MBBS education. Her area of interest is infectious diseases in critically ill patients. We welcome you, ma'am, and I request you to please introduce our panel members.
A warm good morning to everyone. So we thought we'll have a break for inauguration and then start, but still because of rescheduling of our Vice Chancellor's time, we'll start with panel discussion today. It gives me immense pleasure to be back here on stage, seeing all my very beloved teachers and very good friends and some old teachers whom I have learnt and younger generation. So feels extremely good to be on stage, and thanks Kulkarni sir especially for inviting me, and of course Dr. Jeevan Kumar. So it's an honor to invite our panelists today. I hope the students will enjoy this academic feast. First to introduce is our well-known Balasubramanya sir. He is president of ISA Bellary City Branch and past secretary of ISA Bellary City Branch. He's a member of IEC committee at BMCRC Bellary. He's been chairman of Scientific Committee ISACON Karnataka 2017 held at Bellary. He's member and resource person of Scientific Committee ISACON held at Bangalore. He's a reviewer of our own IJA, and he's received the Best IJA Reviewer Award for 22-23, and he has more than 15 publications. Welcome on board, sir. It's a privilege to have you here, and we are waiting for the knowledge sharing.
Thanks a lot, madam.
Another eminent panelist is our Dr. Sahana. She is Associate Professor, Department of Emergency Medicine at Vaidehi Institute of Medical Sciences. She is a medical simulator educator at, from Mayo Clinic, USA. She's a faculty for disaster management and pre-hospital care from UK. She's a faculty for postgraduate medical education. She's faculty at various national and international conferences, and she's already authored a lot of books in emergency medical care, and she's established emergency medicine department at a tertiary care settings. Her area of expertise is point of care ultrasound, toxicology, hemodynamics in critically ill, medical law and ethics, and wellness and resilience for medical professional and students. Welcome, ma'am,
Thank you.
for this panel discussion. Also, we have our eminent Dr. Abhishek KB. He is our first emergency physician registered under Ayushman Bharat, providing a lot of service. I had the personal privilege to meet him when he was serving in a very poor setup like Chamraj Nagar. I saw him dialyzing a patient, whole and soul, everything managed by one-man show. I really appreciate that. Professionally, his alumnus of emergency medicine, RMC, instructor, national faculty for ATLS, BLS. He has 4 international publications and he is HRI school project manager. He has received Sarvottama Seva Award from Government of Karnataka in 2022 and lot of achievements. First emergency physician being appointed to the by the government of Karnataka. Is pioneer in establishing emergency medicine department and rural and government medical colleges. First to launch MD emergency medicine PG and EMT technician courses at a government medical college. Really hats off to you for your service at a really poor and for the underpowered people. And finally, our last panelist is Dr. Ganesh BS. He is Associate Professor in Emergency Medicine Department from SS Institute of Medical Sciences and Research Center, Davangere. Sir has had a lot of achievements in his name. First rank university in MD Emergency Medicine, training center faculty under American Heart Association, one of the founding members of KEPA, that is your Karnataka Emergency Medicine Physician Association. His areas of interest are toxicology, emergency medicine research, and pre-hospital emergency care. Welcome, sir. So you have heard a lot of talk already. Let's move on to practice. We'll now go to scenario-based discussion so that we all can actually listen to experts as to how they manage when you have patients like this in your setting. So usually our textbooks are very clear, whether it is Harrison or Davidson or emergency textbooks or critical care textbooks, everyone gives one disease, one diagnosis, and one management, but it is not that in real life setting. So let's look at a patient who didn't follow textbook patterns. So what happens here is you have a 64-year-old retired bank officer, 6:10 a.m. You have just starting to open your eyes in ED after a refreshing hour of sleep, maybe. He comes with breathlessness. He has which has progressed over a period of 2 hours. So it's a very short history of breathlessness. And he says he woke up feeling tightness in chest, not pain, tightness. And he was unable to lie down. No cough, no fever, no wheeze, and again no chest pain. He is known hypertensive. It's controlled with amlodipine, and he has no cardiac history. So at triage, his rate is 36 per minute. Blood pressure is 104/62. Saturation is 84 with 10 liters of oxygen. Pulse rate is 118. He is afebrile, mildly sweating, unable to speak in short phrases, and there is no wheeze, crackles initially. JVP is borderline elevated, but not striking. Initial workup, you order an ABG. This is the ABG. pH is 7.31, PCO2 48, PO2 58. So you can all read it up. You do point of care lung ultrasound, which is indispensable in this setting. You see right lung, everywhere A profile. Left lung a bit here and there B lines. Everywhere slide is good. And no dense consolidation nor pleural effusion. IVC is collapsible. Mildly depressed LV function. No RV strain, no pericardial effusion. His daughter says, 2 days ago, he just had a bit of throat irritation, just like me. So I would like to invite Abhishek, sir. Now, the question is for you, sir. Over the course of next 20 minutes, this is what we are considering. And we look at this patient, we think it could be an early pneumonia, right? The other side, it could be early cardiogenic pulmonary edema, could be a small microaspiration at night. Nothing rules out pulmonary embolism here, okay? And a small LRTI. So there is no single unifying diagnosis here. So what would you do, sir, at this scenario? These are your questions. You have a bit of patchy B lines, mild LV dysfunction. So what do? You treat it as early pneumonia or early pulmonary edema?
So these are the everyday scenarios where we come across. So in this particular case, there are certain features which are suggestive of early pneumonia and certain features suggestive of LV dysfunction, but not confirmatory. So before giving one word answer, we would like to dissect it. So here we had patchy B line. So patchy B line in left lung suggests that there is early pneumonia that is setting in. That is point number one. So at the same time, there is mild LV dysfunction. So mild LV dysfunction can predispose to early pulmonary edema. So with this background, this is very intermediate or indeterminate situation where we cannot specifically tell whether it is early pneumonia or LV dysfunction or cardiac problem. With the history that is provided and point of lung ultrasound here pointing towards more of early pneumonia, that is scattered B lines. If B lines would have been symmetrical, bilateral, then purely it goes in favor of pulmonary edema. But here everywhere A profile is there. That doesn't mean that cardiac problem is ruled out because mild LV dysfunction is there. So with this background, we have to consider, in my opinion, we have to consider both early pneumonia as well as LV dysfunction, and we need to treat for both.
Okay, agreed. So we are in gray zone. What happens is I really empathize with emergency physician. Then you send the patient, stabilize everything. You think it is pneumonia and you treat with antibiotics and they go to critical care. And in critical care, I'll call back to Girish sir and say, sir, aapne kya kar diya? Ye to pulmonary edema hai. So this should not happen. It's a gray zone. Accept it is gray zone. If Harrison ever comes in your dream, please shoot him and say, you have not taught this in your textbook. So let's move on. And we accept that it could be both at this point of time. And how much weight do you give? Because there is a collapsible IVC also with LV dysfunction, which is mild. So what weight you will give and how do you manage your fluid setting in this point of time? And what importance you will give, whether you will give Lasix? These are the questions specifically.
The second question is collapsible. We have one more point of care ultrasound finding, that is collapsible IVC with LV dysfunction, mild LV dysfunction. So collapsible IVC suggests that there is decreased preload. So you can give fluids. That is highly acceptable when LV is normal, when ejection fraction is normal. So there is a table, if you see, if ejection fraction is normal more than 50%, then IVC collapsibility is highly reliable. If there is LV dysfunction, mild LV dysfunction, that is ejection fraction between 40 to 50%, then IVC collapsibility, we can give moderate weightage. So if ejection fraction is between 30% and 40%, then IVC collapsibility is not that reliable. And if ejection fraction is less than 30%, then IVC collapsibility is not at all reliable. So in this situation, collapsibility, IVC collapsibility with mild LV dysfunction, we would give moderate weightage, provided that we can, it doesn't mean that already there is a deficit preload that cannot be made out, because LV dysfunction suggests that there is some sort of LV dysfunction with the mild low EF. So low EF, we can take that there is some sort of systolic dysfunction. So there is elevated pressures. So it does not rule out that deficit preload.
So life is much easier when you have point of care ultrasound. So especially, and also if you have one unit chief. Imagine you working with two unit chief. One says, no, I disagree with this. I want to give fluid. The other one person cares, no, I want Lasix. And then final what happens is the PG gives IV fluid also and Lasix also. And the person who with next shifts comes and taunts the PG. Let's just connect the IV fluid to urine bag. Why pass through patient? So the whole point here taken is it's a gray zone. So fluid Lasix, sir, is going towards no fluid, no Lasix strategy, knowing very well that he may take in a bit of fluid and not giving both is also a bit safe. So the third question again to you, sir. When do you commit to positive pressure ventilation? Because he's bit, the ABGs are little haywire. There is a bit of hypoxemia, a little of hypercarbia, and anything else you want to rule out in this scenario?
So basically, we consider positive pressure ventilation. The most common cause is one is hypoxia, and the second most important, and where we as residents or early PG students forget, is work of breathing. So even though saturation is good, we need to assess for the clinical situation where there's a increased accessory muscle usage. Basically, positive pressure ventilation has to be advocated whenever there is increased work of breathing. That is number one. Second, hypoxia. Third, there is hypercapnia. So, or the fourth indication will be whenever there is impending respiratory worsening. In such situations, we need to give positive pressure ventilation. Saying this, so what to rule out first? So first thing to be ruled out is pneumothorax. Pneumothorax is one thing that has to be ruled out. Second most important thing is preload status. So if patient is having a hypovolemic shock or shock that is purely because of hypovolemia, putting the patient on positive pressure ventilation will work the shock. So adequate fluid administration is also more important before giving positive pressure ventilation. In our case, this is an ideal case where we can give positive pressure ventilation in this patient.
So, sir's message is don't hesitate to give you a BiPAP provided there is no pneumothorax. Anyways, point of care ultrasound as clear cut shown. And since it's a panel discussion on respiratory failure, don't think that your patient also has only respiratory cause of respiratory failure. There are other causes. There are neuromuscular disorders. There are dyselectrolytemia. There is a DKA. There is a renal failure. So please complete your systemic examination and make sure things are. Yesterday night itself, we had one myasthenia crisis patient in crisis, treated as community acquired pneumonia, but it was an aspiration pneumonia with myasthenia crisis because nobody bothered to see a LMN examination, neurological lesion that is there. And then if you retake history, it's actually a neurological patient coming with respiratory failure. So despite the panel discussion being on respiratory failure, the point to stress is other system, other diagnosis is also there. Don't forget that. So nicely put out there. How do you commit to positive pressure ventilation? Early positive ventilation will help both if it is an early pneumonia or a pulmonary edema. So last simple question, sir. Do you start antibiotics immediately or wait for more clarity here?
Before giving to this answer, we'll break it again. So when to give antibiotics? So whenever there is an unstable patient, irrespective of the cardiac status, and if you're thinking a little bit of infection also, you need to give. Unstable patient, immunocompromised patient, always early empiric antibiotic is indicated. So in which case we can wait? If the patient is stable and pointing towards more of purely cardiac cause like pure pulmonary edema where patient is improving with furosemide, in such cases we can wait. So when in doubt, always go for giving antibiotics. So in this case, with the background of throat irritation and patchy B-lines, yes, definitely early empiric antibiotic is indicated.
So that's definitely what evidence points towards. But we also forget we are in India. Patient has access to over-the-counter antibiotics without doctor's prescription. So if we take that into account, it's all likely that patient has already taken antibiotic one course and come to you. So thank you, sir. So that was a brief discussion of how to handle the uncertainties, because postgraduates needs to understand that no diagnosis is certain and no disease is certain in a patient. It keeps evolving and you have to adjust accordingly. So once you have learned that you have to arrive at a certain diagnosis and how to manage the borderline patient, let's go ahead and think of another scenario. So you are in ED again, you are dealing with a 72-year-old man with severe COPD, FEV1 almost 35%, presents with gradually increasing drowsiness since early morning. He slept poorly, he felt fatigued on walking a bit to the toilet also, did not use his nebulizers in the morning. His GCS is 14, respiratory rate is 32 for COPD, and saturation is 86% on Venturi, 40% FiO2. Accessory muscle use is active, mild pedal edema, no V's at all, surprisingly, the quiet chest pattern. So you see the ABG, it's a pure respiratory acidosis there as expected. 7.21 pH, PaCO2 of 72, PaO2 of 54. What I've missed is a bicarb there. It is there given in the end, which is 30. So you start NIV. Everybody starts NIV here. There is no doubt in this. You start IPAP of 14 and 6, and you reassess after 1.5 hours. He's now 15 by 15 GCS. He's alert. Respiratory rate has come down to 26. Accessory muscle hues has decreased. Blood pressure is okay. Heart rate is slightly on the higher side. pH has dropped. 7.21 7.18. PO2 is unchanged. PaCO2 has risen. It's basically respiratory failure worsening. Clinically, he is better, but numbers are worse. So the doctor sees him and says, he's improving. Please don't intubate him, doctor. I've seen him. This is common scenario in educated family. I've looked after him so many days. I know you give him BiPAP, he'll be all right. Don't intubate. Tracheostomy, I've taken care of 6 months and all. It's not possible. You push. He also says, give me some more time on this mask. So you're in gray zone now. Rising PaCO2, stable pH, which is coming down. Clinical comfort improved, hemodynamic stable, work of breathing has also improved. So what do you do now? The question is to Dr. Sahana. So how do you go about managing such a patient, which is basically a call of judgment? So how do you interpret a rising PaCO2 but improving comfort in a COPD patient?
I think we all should understand the first foremost thing before the discussion is clinical acumen or a clinical trajectory of how we see a patient holds higher than numbers. So with that in the background, the first question, how do you interpret a rising PaCO2 but improving comfort in the patient? So we have an elderly patient who came with a comparatively little low GCS of around 14, very dyspneic and even hypoxic with oxygen. But however, with the NIV trial, clinically looking at this, now the patient's level of consciousness is definitely improved from 14 to 15, where the GCS is improved, one of the things. And the respiratory component, where initially we had a tachypneic patient of 32 to 34 cycles per minute has now come down to around 26 cycles. So we see the respiratory component being improved, and the work of breathing is also improved in a patient, and he's maybe able to talk much better than before. So clinically, the patient is improved. And a few of the reasons in a patient with a background of COPD where uh, uh, PCO2 may transiently increase, but we don't have to treat it initially right away in the first hour or second hour, maybe because of a few factors. One is because of the physiological factor itself, where because of the initial treatment, whether the bronchodilators have been used or the NIV being used, the work of breathing has come down, the patient relaxes more, so the minute ventilation is reduced in such a patient. So the minute ventilation reduces, automatically the PCO2 is tend to rise in patients like this, though there's a clinical improvement. The other thing is, again, there's a chronic uh, PCO2 retention in a patients with background of a COPD. So again, which does not have to be, it's a renal retention of bicarb also. So we do not have to treat it immediately. And also the patient synchrony happens way before it can reflect on an EBG in case of COPD patients. So the initial thing in the first hour, yes, the clinical trajectory for this patient is still to go ahead with NIV, and sometimes the raising PCO2 may not be the actual thing to be treated. There are more reasons why we need to actually take a call for intubation, and initially may not be PCO2 to be the lone factor for intubation and consider it worsening respiratory failure.
So clinical judgment is hold on to NIV. So in that, can we optimize NIV is the next question. So can we escalate to a higher intensity NIV where you increase your IPAP? Or as ma'am has already answered, she doesn't want to stop the trial. So can we optimize the NIV a bit more? And or you can even try instead of BiPAP a machine NIV also. So what do your take on this, ma'am?
Well, again, now that we are done with the first 90 minutes as the case goes on and the patient is clinically improved, yes, we can continue now that the patient's mentation and work of breathing is good. We can continue or escalate the treatment with high intensity NIV, where a gradual increase in the IPAP can be considered. So the target may be around 20 to 24 centimeters of water, but however graded from 14 to 16, 18 and 20, and then holding on around 20 to 24, keeping the EPAP around 4 to 6 will help treat patients with COPD, because it helps in different ways. Like NIV is, again, these guidelines come from, I'm referring to the ERS, the ATS and the GOLD guidelines at the most recent ones, where NIV is one of the first line of treatments, especially for patients with exacerbation with COPD, where a trial of NIV is always has better patient outcomes and reduces the long-term mortality risk also in the patients. So again, having a graded increase in the NIV and then seeing the response will help in 3-4 things: eliminating the PCO2 and optimizing the oxygenation, and also reduce the work of breathing and holding on to the hemodynamics and not going on to ventilator. So escalating high intensity NIV is the next option in the second or the third hour for such patients.
Okay, so big yes to increasing and optimizing your BiPAP or using an NIV. So while you are putting the patient on NIV, what all signs that you need to see? Because it's not that you are giving NIV and the patient has settled and you don't need to worry. This is a patient who is most dangerous in your ICU or your ED, because you have not completely satisfied with the treatment that you have given. There is no good, exact, greatly treatment response that you completely want from the patient, because all guidelines say any pH 7.25 below, better to intubate rather than use your NIV. So we are sitting on clinical borderline here. So ma'am, what do you suggest for the students? What you will watch in this patient that you can, these signs are there, patient is deteriorating, I'll have to intubate, these kind of things that you look in the patient?
Yeah. So again, the red flag signs where you have to consider intubating a patient with a gray zone. You can have more clarity dividing them into a few clinical signs and maybe few adjuncts like an ABG by the bedside. So what is important to see clinically is first, again, the mentation. Is the mentation of patient worsening or improved from previous? And if the a patient is conscious, awake, with a GCS of 15, able to synchronize and understand and able to take breath, then you may not have to. But any falling GCS is a red flag sign for intubation. Next component, coming to the respiratory work of breathing. If the patient is worsening from being just tachypnic to having a paroxysmal breathing or shallow breathing, again, it's not a great sign. Again, use of accessory muscles, worsening of use of accessory muscles. And in this case, one of the things I want to point out is the silent chest. Again, silent chest is not very clinically well picked up by the PGs. So they assume the chest is clear. Normally, whenever you ask the PG, it's like, yes, they only understand two things. That is the crepitations or having, should I stop? Okay. So either the crepitations or a spasm is what predominantly the post-graduation graduates understand. But having a silent chest is a very alarming sign for COPD, where you should take an early call for intubation. And again, fourth thing being hemodynamic instability. Again, if the patient is being hypotensive, requiring inotropic supports or vasopressors, again, it becomes an indication to intubate early. And coming to a few of the adjuncts where you have a worsening of pH, drop below 7.25 or 7.2, again, it will be a sign. And in despite of your supplemental oxygen or NIV, if the patient is still hypoxic on the NIV,
then these are a few things where you'll definitely have to consider intubation in COPD patients. And considering this early is also very important. The reason is the fine decision. You cannot have a crashing patient. So predominantly auto PEEP, like how Dr. Vasudha was previously speaking in troubleshooting and other things, COPD patients tend to have this auto PEEP where they have a limitation in how much they exhale. So in this background, if you do not take a call for intubation, during the time of intubation, either the positive pressure ventilation or itself doing a bag wall mask is very difficult. You have more resistance, so they may become hypotensive, or they may crash before intubation, or just during post-intubation because of hyperinflation, the patient may again go into a stage of hemodynamic instability. So taking this clinical decision where in the first, second or third hour to decide, no, I'll move from NIV to invasive ventilation is a clinical acumen mostly, and you can use adjuncts like mostly ABG is one of the things for intubation.
Thank you, ma'am. Just last one word answer for before we break for inauguration. We have our chairmans here.
Yes.
So when does your pH become non-negotiable? Just a number, because textbook says 7.25, but we have stretched the limits here. Clinical practice in this particular patient, or I'll say enough is enough, I'm going to tube the patient. What pH?
If you, that's a difficult question in one word, but however, maybe 7.2 and lesser. With clinically deteriorating patient, you should consider tubing the patient. It's always safer than leaving the patient on NIV.
Thank you, ma'am. We'll
Thank you.
break for inauguration now and we'll restart after the inauguration. Thank you.
A warm and delightful good morning to all respected dignitaries and esteemed guests, faculty members, and dear delegates. With great pride and immense pleasure, the Department of Emergency Medicine and Department of Anesthesia Sri Siddhartha Medical College and Hospital warmly welcomes each one of you for CME and workshop on mechanical ventilation, being conducted today in association with the Karnataka Emergency Physician Association. The practice of mechanical ventilation is not merely about operating a machine. It is a careful balance of physiology, pathology, and technology. It demands in-depth understanding of respiratory mechanics, hemodynamics, and patient-specific requirements. This CME and workshop aims to provide participants with both theoretical foundations and practical hands-on experience, a combination that is essential for mastering this complex but vital aspect of critical care.
I would like to acknowledge and express my gratitude to our distinguished guests, esteemed speakers, resource faculty, and the organizing committee, whose dedication and expertise have made this program possible. I also thank all the delegates for your presence, reflecting your commitment to clinical excellence and patient care. Without further ado, I would like to request volunteers to kindly escort our distinguished guests onto the dais as we honor their presence and mark the beginning of the special occasion. Savyasachi, Dr. G. Parmeshwara Sir, Honorable Chancellor Sahe, and Home Minister of Karnataka in his absentia. Dr. Lingegowda KB Sir, Vice Chancellor Sahe. Dr. Ashok Mehta Sir, Register Sahe. Dr. Kiran Kumar Sir, CAO SSMC. Dr. Mallikarjun B. Sanikop Sir, Principal SSMC. Dr. Prabhakar GN Sir, Vice Principal SSMC. Then Dr. C.S. Swami Sir, KMC Observer. Dr. Manjunath Hetsi Sir, Dean and Director of CIMS Chamarajnagar. And Dr. Srinivas Kulkarni Sir, HOD of Emergency Medicine Department, Siddhartha Medical College. And Dr. Gangadhar Sir, HOD of Department of Anaesthesia. I would also like to call upon Dr. Ravi Kumar R. Sir, Assistant Professor, Department of Emergency Medicine, SSMC, and Dr. Jeevan Kumar J. Sir, Assistant Professor, Department of Emergency Medicine.
It is now time to seek the blessings of the Almighty as we begin this beautiful program. So, I would like to warmly invite Nidhi Gowda to render the invocation song.
वक्रतुण्डमहाकाय सूर्यकोटिसमप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा या कुन्देन्दु तुषारहार धवला या शुभ्र वस्त्रान्विता या वीणा वरदण्डमण्डितकरा या श्वेत पद्मासना या ब्रह्माच्युत शङ्कर प्रवृत्तिभिर्देवैः सदा पूजिता सा मां पातु सरस्वती भगवती निशेष जाड्यापहा निशेष जाड्यापहा. Thank you.
Thank you, Nidhi, for the graceful rendition. Now I would like to call upon Dr. Rajeshwari ma'am, our medical superintendent, to the dais, please. I would now like to invite Dr. Srinivas Kulkarni, sir, Professor and Head of the Department Emergency Medicine, to deliver the welcome address, and we kindly request the volunteers to escort him to the
A very good morning, the dignitaries on the dais, my dear colleagues, all faculties, delegates, and everyone. So this is the day we have dreamed 3 months back, and we have started working on it with our beloved Vice Chancellor sir encouraged me to do something. And Chancellor also told, whatever you do academics, so we'll definitely encourage you. Definitely we have to do in this institution. Then we went to our Vice Chancellor sir. He told, you do it, whatever you want, you take from me. That was the words told by the Chancellor. So I was very much impressed that we have to do something. We have to conduct a state-wise some conference or some CME workshop. Then we together, myself, Jeevan Kumar and Ravi Kumar and other people, we gathered together. Our postgraduates also told, we have to do some workshops, sir. We need ventilators, sir. It's a tough thing to know. Ventilator is the problem. Everywhere settings and what patient, what type of things, all the things we get respiratory failure patients. So we combined together. So it was the occasion we expected 3 months back. When I approached our Vice Chancellor, sir, we are conducting CME. He told, I will come, I will support you. Definitely you should do it. That was his words. I am definitely very much impressed with him, and I welcome sir. He was the person behind us to things to do it. I welcome our registrar sir, Mehta sir. He is the key person for all the academics. He encourages us. I welcome you, sir. I welcome our beloved principal sir, Dr. Sanikov sir. He is person always speaks with smile and tells us, you do it, whatever you want, we'll give you. That's words, we get it, so that we have done it, and his support was very eminent. I welcome you, sir. I welcome our Vice Principal, sir, Dr. Prabhakar, sir. He is backbone for everything. Whenever I go, ask him, we want this one, do it, I will give you. Whatever you want, you take it. So he was the person who tells us, encourages us to move forward. Any problem is there, you come to me, I will solve it. So that was the words. I got completely impressed with his activities. He was used to come to our department also. Whenever I tell, I want to meet you, sir, you come, I will be available. So that was the thing where I get the more encouragement, and our department was very impressed. His all facilities given to us. Thank you so much, sir. We are welcome to you. Then main important, our CEO, sir, Kiran, sir. He tells always, whatever required for emergency medicine, we do it in purchase committee. So I welcome you, sir. Thank you, sir. Our MS madam and MS sir, Venkatesh sir, he came 2 to 3 times here. He was having a busy work schedule. He is in absence of him, I welcome him and Rajeshwari madam, both MSs. They are the always the rounds. They come to us. They inquire things. They encourage us, and they correct us. We are happy to you, sir. Happy to you, madam. Thank you. I welcome my friend and my lifesaver also, my soulmate also, Dr. Manjunath S.G. He is from MMC. Now he is Dean and Director of Amraj Nagar. I am happy to welcome him for as a dash. So our KMC observer sir, Swami sir, he is also our department, anesthesia department. He's a very humble person. I am very much happy to welcome him for this occasion. Thank you, sir. And I welcome my teacher and also he's everything supported, and every moment he used to correct me. He is the person, Dr. Gangadhar sir, HOD emergency, HOD anesthesia. I welcome you, sir. Thank you, sir. I welcome my colleagues, Dr. Ravi Kumar, Dr. Jivan Kumar. Without them, this could not have happened. They are the backbones. They have each moment, everything, all collection of PPT, calling everyone, registration, everything. They have did very nicely. I am happy to welcome them. I welcome all the faculties. They have come from different places of Karnataka. They are very humble and they have responded very well. Every time they told, we are happy to come there. That was the word taken from everyone. I called them 2 to 3 times. Since they are having so many obligations, the compulsions, family things, still they have come to us and they have distributed their knowledge, they have spread their knowledge, and our delegates are very fortunate to have them. Really, I'm happy to have you here. I'm very much thankful to them and I'm welcoming them. And already sessions have been done. People have come across their knowledge and they are appreciated also. Thank you so much. I am welcoming all the faculties and their co coming people who with along with them also. Many people have come without my knowledge. I come across people who want to register still now. Because of seeing the faculties, they want to register now. So very happy to have you all people. Thank you very much. And also our delegates, without them, this function is nothing. So I welcome all the delegates. Have your very good feast also, knowledge also. Thank you so much for giving me opportunity to welcome all and will continue for the next session.
Thank you so much, sir. Shubham Karoti Kalyanam, Arogyam Dana Sampada, Shatru Buddhi Vinashaya, Deepar Jyoti Namastute. We fold our hands before the light that brings prosperity, auspiciousness, good health, abundance of wealth, and destruction of poor intellect. I request all the dignitaries on the dais to ignite the lamp of knowledge and mark the beginning of our program.
Hello. Now I request our Vice Chancellor to say a few words.
Thank you, Professor Kulkarni. Among the postgraduates, please raise your hand, whoever is from emergency medicine. Emergency medicine, postgraduate. Anesthesia PGs? Good. I was fortunate that I could hear the discussions about acid-base balance for a few minutes. Madam, may I know you are from which place? You were talking about acute acidosis. Yeah. Sorry? Vaidehi. Good, good, good. No, no, because I remember 35 years back when Dr. Fanindranath Tota was used to take class on acid-base balance, a hall like this, people used to sit on the floor. Added to that, ಕಿಟಕಿನಲ್ಲಿ ಬಾಗಿಲಿನಲ್ಲಿ ಎಲ್ಲರೂ ಸಹಿತ ನಿಂತ್ಕೊಂಡು ಅಷ್ಟು ಜನ ರಶ್ ಮಾಡಿ ಕೇಳ್ತಾ ಇದ್ರು ಬಿಕಾಸ್ ಹಿ ವಾಸ್ ಇಸ್ ಟು ಸ್ಪೀಕ್ ಫಾರ್ 59 minutes 59 seconds ಅಬೌಟ್ ಆಸಿಡ್ ಬೇಸ್ ಬ್ಯಾಲೆನ್ಸ್. ನೀವು ಮಾತಾಡ್ಬೇಕಾದ್ರೆ ಐ ವಾಸ್ ಜಸ್ಟ್ ರಿಮೆಂಬರಿಂಗ್ ಗೈಸ್, ಮೇಕ್ ಯೂಸ್ ಆಫ್ ದಿಸ್ exclusive opportunity to discuss about acid base balance, especially about mechanical ventilation. I'm happy. I must thank Dr. Prabhakar. ಯಾರು ಸಾಣಿಕೊಪ್ಪರ್ ಕರ್ಕೊಂಬಂದ್ರೆ ಪ್ರಭಾಕರ್ ಕರ್ಕೊಂಬಂದ್ರು ಅಂತ ಹೇಳಿ ನಮ್ಮ ಒಳ್ಳೆ ಹೀರೋ ಎಲ್ಲಿ ಶ್ರೀನಿವಾಸ್ ಕುಲಕರ್ಣಿ ಅವ್ರನ್ನ ಕರ್ಕೊಂಡ್ಬಂದಿದ್ದಾರೆ. ಲೆಟ್ ಅಸ್ ಗಿವ್ ಎ ಬಿಗ್ ರೌಂಡ್ ಆಫ್ ಅಪ್ಲಾಸ್. ಕುಲಕರ್ಣಿ ಅವರೇ, our chancellor being an academician, he always encourages this kind of academic activities. And probably ಪ್ರಭಾಕರ್ಗೆ ಸ್ವಲ್ಪ ಬೇಜಾರಿದೆ, ಯಾಕೆಂದ್ರೆ ಅನಸ್ತೇಷಿಯಾದವರು ಎಮರ್ಜೆನ್ಸಿ ಮೆಡಿಸಿನ್ ವಿ ಆರ್ ಆಲ್ವೇಸ್ ಟ್ರೀಟೆಡ್ ಲೈಕ್ ಎ ಸೆಕೆಂಡ್ ರೇಟ್ ಸಿಟಿಸನ್ಸ್. ನೌ ಪ್ರಭಾಕರ್, ಅನಸ್ತೇಷಿಯಾ ಇಸ್ ದ ಮೇನ್. ನನಗೆ ಐ ಕ್ಯಾನ್ ಗೆಟ್ ಅನದರ್ ಸರ್ಜನ್ ಬಟ್ ನಾಟ್ ಅನಸ್ಥೆಟಿಸ್ಟ್. ಅದಕ್ಕೆ ನೋಡಿ ಏನು ನೋಡಿ ಸಿಂಹ ತರ ಗರ್ಜನೆ ಮಾಡ್ತಾ ಇದ್ದಾರೆ ನಮ್ಮ ಗಂಗಾಧರು. We should always feel proud that I always feel that I must choose my anesthetist, not the surgeons. Suppose if there is any problem, Rashmi ಗೊತ್ತು ನಮಗೆ. In fact, even when we were operating supra major procedures in Kidwai, we could get another surgeon, but not the anesthetist. Especially when you remember about the table death, we can understand. So always learn. We are always there to help all these activities. Kulkarni, in coming days, see to it that our Siddhartha Emergency Medicine Department is the best department in the, not in state, in the country. We are always there to support you. Jai Siddhartha. Thank you.
Thank you so much, sir. We are pleased to have you here. I request our principal to honor our Vice Chancellor. Sir, 2 minutes. No, chair. Now I request our registrar to say 2 words.
Respected dignitaries on the dais and off the dais, I'm extremely happy to be part of this event as I'm witnessing the celebrative minds and celebrative people who are eagerly awaiting to attend the sessions today as well as tomorrow. It's a wonderful opportunity for all of you. And also, I'm happy to know that the participants have come from different parts of the state and attending this workshop. In fact, each and everyone must attend workshops of this type regularly, so that then only, in addition to your academic sessions, if you keep on attending these kind of conferences, workshops and all, so what will happen? You you meet different people and you come across different personalities and you exchange your ideas and thoughts and other innovative thinking, so that certainly you improve your knowledge as well as level of information. Unless we update ourselves from time to time, very difficult to survive in this world. As all of us know, this technology as well as the different areas, particularly in the medicine field, lot of things are happening from time to time. And if you can update yourself, and certainly you can become a good doctor, and certainly people will be remembered. I wish you all the best for this conference and workshop. Once again, I congratulate the Department of Emergency Medicine, particularly Kulkarni sir and other team members for having organized this. Thank you, one and all.
Thank you so much, sir. Now, I request our Vice Principal to honor our register. Thank you, sir. I request our guest, Dr. Manjunath, to speak some words.
Good morning, everyone. Greetings from Chamarajanagar Institute of Medical Science, Chamarajanagar. Respected dignitaries on the dais and off the dais, and dear faculty members and my dear students. So this is an occasion for each and every one of you to learn regarding the emergency medicine. Emergency medicine is a new subject coming into the field of medicine, and we do have our emergency medicine. Dr. Abhishek is a wonderful emergency medicine physician. Is the first emergency medicine physician in the district of Chamarajanagar. We have got very full-fledged emergency department in our institute. We got 4 postgraduate also, and I am also the faculty member of emergency medicine. We are doing very well, and even Dr. Kulkarni, as I said, is a colleague of mine in Mysore Medical College when I was head of the department of Mysore Medical College, and I am very happy that he is conducting this very beautiful program on mechanical ventilation, and I wish him good luck in his future endeavors. And he is a very good academician and a very good speaker also, and he was with me for nearly more than 10 years in Mysore Medical College. I wish him good luck, and I wish you all a good learning and a good academic feast, and I enjoy the day. Thank you very much. Thank you, Dr. Kulkarni, for giving me this opportunity to speak on this occasion. Thank you, Dr. Kulkarni, and thanks and each and everyone.
Thank you, Dr. Manjunath. I request our Gangadhar sir to felicitate or felicitate Manjunath. Thank you, sir. I request our CEO sir to speak some 2 words.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. Being an orthopedic surgeon, I may be a person, not the right person to speak. But being an orthopedic surgeon, I know one thing is that I should be close with anesthetist. Probably we are belong to non-invasive ventilation. What we are a student in 80s and in 90s post-graduation, most of the patients who are put under non-invasive ventilation used to die in wards only. Those time concept of ventilators was much less or not there. Then there is a 2000 plus after liberalization policy, health sector is converted into industry. During that time, I think these all high-tech hospitals, Wokat, Apollo, everybody, because of this ventilator concept, because of emergency, handling of emergency cases, those people are the one who excelled in emergency care. Why I'm saying is that any patients during emergency, they want the best of the best treatment. I think still those days, all these hospitals has come up very early and very well because of this emergency care and because of the ventilators and ICU facilities. And there is one more turn I can say that during COVID. COVID is the place where I was administrator in Janaga General Hospital in first wave, and I was state level administrator for ICU in second wave. I could see in government sector also, there were ventilator which was there and which was not underused. In 1781 only, government had a policy of putting at least 2 ventilators in Taluk level hospital and 10 ventilators in district level hospital. Those were underutilized, not utilized at all. During COVID, when the breakup was there, they find it so difficult. All these district level hospital, they were having less than 10 ventilators. In a month of 3-4 months, I think minimum 50 ventilators has come up. KCG had 100 plus ventilators. Why I'm saying is that when the people who face to face that keeping the patient in ventilator, managing ventilator is a challenge. And many, even I know that even medical colleges were outsourced their ICU facilities. They're not managing with their own manpower. Manpower was less and it was difficult for intensivist was not there. Anesthetist or physician, they used to manage the ICU care. They're finding very difficult. Manpower is the most crucial part in any ICU care. And it is a teamwork. The criteria for taking the patient into ICU is a teamwork. And the criteria should fulfill. And I visited many ICU, both private and government. Criteria is not followed. Even shifting of the patient is not followed properly. And when they shift the patient to HTU, again, the reshift to the ICU, some of the hospitals are more. So these are technical things where management is a challenge. And I remember the ICU was managed by central office by a tele-ICU facilities. We used to make rounds, used to go to each hospital and used to sit in a state level office and used to monitor. Because every guidance was keep changing for COVID and management is also keep changing. We involved all private sector people and also government people to give guidance to others people to manage COVID, especially in ICU situations. And even patients shifted from secondary level to tertiary level, and some tertiary patients who are not requiring only a minimal ICU care were shifted back to secondary level hospital. Those are exchange of patients was also done. ICU period was the most difficult which you have faced during COVID. And I remember Chamarajanagar tragedy. Chamarajanagar tragedy is it is totally mistake of somebody else and it is a collective thing. And what the retired judge has given a statement, I could really tell you, I could want to share that. He was blaming the medical superintendent and RMO and biomedical engineer because they are not done the oxygen audit properly. Oxygen audit was not done properly, so so demand supply was not met. This is ridiculous. That everybody knows that there is from Mysore to Chamarajanagar coming, there is a delay, totally delay. And there are some bureaucrats who are also involved, and the blame was putting on the doctors for punishment. When I was joint director medical, this file came to me. I wrote 1 or 2 pages note telling all the highlighted everything, and I wrote that it is a system and system failure. It can't be blamed anybody. It is totally a system failure. How can oxygen, if it doesn't come, what doctors can do? So that is the thing that I say nowadays. One thing I want to share you people is that people are not happy when the patient's relatives are not happy when the patient is shifted to ICU. This is what I am seeing because I visited many ICUs in private sector also. The exchange and the briefing of the patient is the most crucial part. It may be required even every 2 hours or 3 hours. Briefing to the patient is very important. And everybody thinks that when the patient goes to ICU, the chances of recovery is less. And to add to that, you know that ventilator associated lot of infection is there. I'm reading article, it is up to 30% of ventilator associated infection is the cause of death in ICU patient. This is very alarming, very, very difficult. So many, as a doctor, my own relatives I visited to ICU. I was trying to get them out as early as possible. So in one particular related cases, I could see that I was the one who said that stop the ventilator because the patient is already brain dead. So I don't want to continue to keep him and the patient there. I went there and removed it and declared it. That's it. So this is one thing the patient relatives got a very disbelief about the hospital in ICU setup. So that those needs to be clarification, and people know that now people are educated. People expectation are more. People ask many questions. It's very difficult. So teamwork is very important, and team also work is also important. One thing I want to specify, because I was handling organ donation also. ICU people can play a major role. Emergency and ICU people can play a major role in a brain death declaration. Motivating those patient relatives for organ donation is the most important thing. My experience says that is the failure of my own colleagues, my own doctor faculty and the health people. They don't motivate the patient for organ donation. You should at least put them in the ear that this can be, so many organs can be taken, and the patient is going to anyway going to die. If you to start, one people start, it makes a lot of difference. And especially the ICU people play a very major role. So this is the most important thing. I think needs to be stressed wherever you're working there with all your style stuff. With this, I thank the authority and I congratulate the HOD of emergency medicines having conducted a beautiful program. Thank you very much.
Thank you, sir. I request Jeevan to felicitate Shiva, sir. Now I request our principal, president of the inaugural function, to give a presidential speech. One minute. Before that, I request our Swami sir, I request our principal to facilitate some, sir. Please. Sir, front. Come, sir. Front, sir. Sir, Bunny, sir. Sir, please. Sir, please.
ಇಲ್ಲ ಪರಮೇಶ್ವರ್ ಇದು ಮಾಡ್ತಾರ ಇಲ್ಲ ಸರ್ ಸ್ವಾಮಿಗೆ ಸನ್ಮಾನ
Sir, I request our beloved principal, sir, to give a presidential talk.
Our Honorable Vice Chancellor, Dr. Lingegoda, sir, and all the dignitaries on the dais, and senior faculty members, invitees and guests, and also all the postgraduate students of anesthesia and the emergency medicine department. It is a pleasure for me to be associated with CMA and workshop on this mechanical ventilation, which is being mainly organized by the departments of emergency medicine and department of anesthesia. Now the department of emergency medicine shall be quite vibrant, because for any hospital to grow, hospital to get the name, it is ultimately the emergency patients, if they are treated well and they are taken care of, and all problems will be automatically get solved. And which we had a problem about 4 months back, and wherein we used to struggle to cater to the emergency department. And also all of it has started just about few years back, and initially NMC made it very mandatory, and that time we used to struggle to get, because I remember when about 5 years back when we started at Oxford Medical College to get the emergency medicine faculty, it was such a difficult program. And of course we could get some, and we could get the emergency medicine PGs about 6 years back only. And very happy, because this emergency medicine department has to grow, because it will take a big way for the whole college, whole hospital to develop in a big way. And I am very happy Dr. Srinivas Kulkarni has taken all the responsibility on his shoulders, and he's been doing a wonderful job, and he's trying to see to that all the patients are taken care, especially in red, yellow zones and all. And also at the same time, we are interacting with him regularly now and then, and we are happy that the things are moving on well in our medical college hospital. And I am happy the anesthesia department has joined the hands with the senior professor or Dr. Gangadhar, and a very nice person. And he moves, takes all the people into confidence, and such academic activities always appreciate, because whenever he comes, he brings along with him all the postgraduate students. Similarly, all the HODs make it a point to see to that they bring their own postgraduate students. It will become a very good academic feast, because the academic feast is very important, especially in the medical colleges, wherein the teaching or to the postgraduate student, not just because they are emergency medicine and anesthesia PGs, all the PGs will get benefited, because that is more important. And all the, because which I have been telling, and I ensure from next time onwards at least, all the HODs, whoever have come, bring your PGs along with you, make it compulsory. Okay, then it becomes more sensible. Okay, because these CMEs will become, and at the rate Dr. Srinivas Kulkarni and Gangadhari have done, they could have done a state level conference only with this level. Okay, anyway, you have invited all the faculties from the state and the big dignitaries from the state, and I am very happy. And our Tumkur SSMC has got some recognition by conducting a mechanical ventilation workshop on this CME. Okay, thank you very much for giving me an opportunity to talk on this occasion. Thank you.
Thank you very much, sir. I request VC sir to facilitate principal, sir. Now I request Register sir to facilitate our Prabhakar sir. Our sir, we have
Thank you, sir. Respected dignitaries, actually, I'm breaking the protocol. After presidential speech, nobody should talk, but I just wanted to share my the same. When we started this emergency medicine, in fact, that was my brainchild, and I convinced our chancellor to build the emergency medicine without any faculty. So we brought 3 PGs also, and that time Dr. Ravi Kumar, who has helped me, and he has joined. Later he also left, PGs without faculty. So we really struggled. Then I requested Jeevan for teaching purpose. Thank you, Jeevan. I have to mention all these efforts. And finally, we could find a very good emergency medicine leader, Dr. Srinivas Kulkarni. So we have promised him, you do whatever you want. Definitely, we are there with you. We want, because that is the face of the hospital. So once the emergency department is good, automatically the hospital will also improve. So in that direction, so he is doing, he has put a lot of efforts. So definitely management is with you, sir. So this is actually, when he wanted to conduct this program, he was hesitant. Then I said, it is nothing, you can do it even in a bigger way. Then he thought, sir, we could have done state level. Yes, no problem. Next, in another 6 months, definitely we can do state level also. Don't worry, sir. We are there to support you, sir. And I thank the emergency medicine, especially the PGs and the faculty who have worked well to conduct this kind of workshop. And Srinivas Kulkarni has taken even a smaller step also. Personally, he has visited the hotel rooms, the resort, all those things. He has taken so much of pain. Thank you. So that kind of commitment should be there for everyone. So then only the institution will grow. Thank you. Thank you very much.
Thank you so much, sir. Kind words. I request our registrars to felicitate our Prabhakar, sir. Now, I request our Jeevan and Ravi Kumar to be felicitated by our CEO, sir. ಎಲ್ಲರೂ ಹ್ಯಾಪಿ ಇರಬೇಕು. ಆಲ್ ಶುಡ್ ಬಿ ಹ್ಯಾಪಿ.
Some supposed to be.
Do this.
No, some supposed to be. I'm not sure.
Oh, thank you, everyone. Now, last Thanksgiving by Dr. Gangadhar, sir.
I request Vice Chancellor sir, Principal sir, and Prabhakar sir to felicitate our HOD, Dr. Srinivas Kulkarni sir. I would like to invite Dr. S.B. Gangadhar sir, Professor and Head of Department of Anesthesia, to deliver the vote of thanks.
The respectable dignitaries on the dais, half the dais, and my colleagues, and also PGs, postgraduates, and different delegates from the different places of the state or anything. The last but not the least, vote of thanks. To make a conference success, it is not only one man job. It is not possible also. So many people, so many hands, they're going to put this one, make the conference successful. Like that. First and foremost, when we made up in our mind to do the conference, what you call workshop and CME, the first met our chancellor. Chancellor has given a beautiful encouragement. Not only the encouragement, actually the way he has told, we have to do this. only the talk is not important. Finance also most important. He assured a very big amount, and given the conference, at least we got 80% we got successful. So like that, ಇವತ್ತು ನಮ್ಮ ಚಾನ್ಸಲರ್ ಆಕ್ಚುಲಿ ಸವ್ಯಸಾಚಿ ಪರಮೇಶ್ವರ್ ಬರಬೇಕಾಗಿತ್ತು. ಆಕ್ಚುಲಿ ಇವನ್ ಬಂದಿದ್ರು, ಇಲ್ಲ ಅಂತಲ್ಲ. Because of the even I told him to at least minimum 5-10 minutes he'll be there. But because of his schedule, the so many central ministers are there in Tumkur, he is unable to make it. But his mind is here only. He blesses. He wished the conference very great successful. So ನಾನು ಅವರಿಗೆ ಹೃದಯಪೂರ್ವಕವಾಗಿ ವಂದನೆಗಳನ್ನು ಸಲ್ಲಿಸಲು ಇಷ್ಟಪಡುತ್ತೇನೆ. The most important vice chancellor of our university, and also my good friend, and also my subject man. He is also anesthetist. That's the first point I love him. So Dr. Lingegoda, ಅವ್ರು ಯಾವ ಕಾನ್ಫರೆನ್ಸ್ ಹೇಳಿ ಫಸ್ಟ್ ಅವ್ರು ಮಾಡ ಆಮೇಲೆ ನೋಡೋಣ ಅಂತ ಹೇಳೋದು. ಆಮೇಲೆ ಅವ್ರ ಲೆವೆಲ್ ಬರೀ ಈ ಲೆವೆಲಲ್ಲೇ ಇಲ್ಲ, ಎಲ್ಲ ಇಂಟರ್ನ್ಯಾಷನಲ್ ಲೆವೆಲಲ್ಲೇ ಮಾಡೋದು. ಈಸ್ ಮೈಂಡ್ ಇಸ್ ಟು ಸೆಂಡ್ ಎವರಿಬಡಿ ಇಂಟರ್ನ್ಯಾಷನಲಿ. ಸೊ ಆ ಥರ ಒಬ್ಬ ವ್ಯಕ್ತಿ ಇರೋದು ನಾಟ್ ಈಸಿ. ಅಟ್ಲೀಸ್ಟ್ ಅವ್ರು ಹೇಳ್ತಾರಲ್ಲ, ಸೊ ಲಿಂಗೇಗೌಡರು ಈ ಕಾನ್ಫರೆನ್ಸ್ಗೆ ಎಲ್ಲ ರೀತಿಯಿಂದನೂ ಅವರು ಸ್ಪಂದಿಸಿರೋದ್ರಿಂದ ಸೊ ಆನ್ ಬಿಹಾಫ್ ಅವರಿಗೆ ಹೃತ್ಪೂರ್ವಕ ವಂದನೆಗಳನ್ನು ಅರ್ಪಿಸ್ತೀನಿ. And actually, Vivek Viraya has also done a lot of things for this conference and other things. So in his absence, I'll be grateful to him. Our registrar, Dr. Ashok Mehta, thanks you for the gracing this occasion and supporting our academic endeavors. Actually, Gurushankar or Bandila, he is also one man, control of examination. He also wished the conference. He appreciate our valuable presence, his valuable presence here today. The most, that is, I think, just now Dr. Kiran Kumar spoke on the ventilators, spoke on the anesthesia and other things. Our CEO, thank you very much for your constant administrative support. Always is supporting. Always, any meeting he is supporting, is give his opinion. That is also most important. ಅವರಿಗೂ ನಮ್ಮ ಹೃದಯಪೂರ್ವಕವಾದ ವಂದನೆಗಳನ್ನು ಅರ್ಪಿಸ್ತೀನಿ. My beloved principal, and also this one from Belgaum, KLE, Dr. Mallikarjun Sanikov, unimaginable. ಅವರು ನಗ್ತಾನೆ ಬರೆಸ್ತಾ ಇರ್ತಾರೆ. ಅವರು ನಗ್ತಾ ಇರ್ತಾರೆ. ಬ್ಯೂಟಿಫುಲ್ ಹೇಗಿರುತ್ತೆ ಅಂದ್ರೆ, ಅವ್ನು ರಿಯಲಿ ಸೆನ್ಸಿಟಿವ್ ಆದ್ರೆ ಗೊತ್ತಾಗುತ್ತೆ ನಾನು ಹೊಡೆಸ್ಕೊತಾ ಇದ್ದೀನಿ ಅಂತ, ಇಲ್ಲಾಂದ್ರೆ ಖಂಡಿತ ಗೊತ್ತಾಗಲ್ಲ. ಅವರು ಇವತ್ತಿನ CME ಮತ್ತೆ ವರ್ಕ್ಶಾಪ್ಗೆ ಅದ್ದೂರಿಯಾಗಿ ಸ್ಪಂದಿಸಿದ್ದಾರೆ. ಇವಾಗ ಕುಲ್ಕರ್ಣಿ ಹೇಳಿದಾನೆ, ಏನೇ ಮಾಡ್ಬೇಕಂತ ನಾವು ಕೇಳಕ್ ಹೋಯ್ತು ಅಂದ್ರೆ ನಮ್ಗಿಂತ ಮುಂಚೆ ರೆಡಿ ಇರ್ತಾರೆ. ನೀನು ಇಷ್ಟು ಮಾಡ್ಲಿವಲ್ಲ, even you had to discussion supposed to go up to 4 o'clock. Even it cannot stop at 3:30. ಈ ತರ ಎನ್ಕರೇಜ್ಮೆಂಟ್ ಅನ್ನು ಇರೋದ್ರಿಂದ ಐ ಥಿಂಕ್ ಥಿಂಗ್ಸ್ ಆರ್ ಗೋಯಿಂಗ್ ಆನ್ ವೆರಿ ವೆಲ್. ಸೊ ಅವರಿಗೂ ಸಹ ಈ ದಿನ ಈ ಸಮಾರಂಭದ ಇದರಲ್ಲಿ ಹೃತ್ಪೂರ್ವಕವಾದ ವಂದನೆಗಳನ್ನ ಅರ್ಪಿಸಕ್ಕೆ ಪ್ರಯತ್ನ ಮಾಡ್ತೀನಿ. ಅಂಡ್ ಅವ್ರ ಪ್ರಭಾಕರ್, ನೀವು ಪ್ರಭಾಕರ್ ಹತ್ರ ನೋ ವರ್ಡೇ ಇಲ್ಲ. ಏನಾರ ಕೇಳಿ ಎಸ್ ಅಂತಾರೆ, ಏನಾರ ಬರ್ಕೊಡಿ ಸರ್, ನೋ ಪ್ರಾಬ್ಲಮ್ ತಗೊಳ್ಳಿ ಅಂತ ಹೇಳ್ತಾರೆ. ಸೊ ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್ ಫಾರ್ ಯುವರ್ ಎನ್ಕರೇಜ್ಮೆಂಟ್ ಅಂಡ್ ಸಪೋರ್ಟ್. ಅವ್ರ ವೆಂಕಟೇಶ್ವರ್ ಪಾಪ 2-3 ಸಲ ಬಂದ್ರು, ಪಾಪ ಇನ್ನೂ ಮುಗಿದಿರಲಿಲ್ಲ. ಅವ್ರಿಗೂ ಆನ್ ಬಿಹಾಫ್ ಆಫ್ ದಿಸ್ ಒನ್ ಐ ಥ್ಯಾಂಕ್ ಯು ಫಾರ್ ದಿಸ್ ಒನ್ ಸೈಡ್. ಅವ್ರ ರಾಜೇಶ್ವರಿ ಮೇಡಮ್ 2 ಸಲ ಬಂದ್ರು, ಕೂತ್ರು, ಎದ್ರು, ಹೋದ್ರು, ಆದ್ರೂ ಕೊನೆಗೆ ಬಂದಿದ್ದಾರೆ. ಸೊ ರಾಜೇಶ್ವರಿ ಮೇಡಮ್ ಕೊನೆಗಿಲ್ಲ, ಆದರೂ ಸರ್ ಅವರ ಹೃತ್ಪೂರ್ವಕ ವಂದನೆಗಳನ್ನ ಅರ್ಪಿಸ್ತೀನಿ. ಅಲ್ಲಿಂದ ಬಂತು ಅಂದ್ರೆ ಸೇಮ್, ಬಿಕಾಸ್ ಇವತ್ತಿನ ಇದು ಸಮಾರಂಭ ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ ಕುಲಕರ್ಣಿ ಅವರ ಒಂದು ಪ್ರೆಸೆನ್ಸ್, ಅವರ ಒಂದು ಡೆಡಿಕೇಶನ್, ಒಂದು ಇಸ್ವನ್ನ ಇಲ್ಲಾಂದ್ರೆ ಖಂಡಿತ ಆಗ್ತಾ ಇರಲಿಲ್ಲ. ಸೊ ಆನ್ ಬಿಹಾಫ್ ಆಫ್ ದಿಸ್ ಹೃತ್ಪೂರ್ವಕವಾದ ವಂದನೆಗಳನ್ನು ಶ್ರೀನಿವಾಸ್ ಕುಲಕರ್ಣಿಗೆ ಅರ್ಪಿಸ್ತೀನಿ. ಅಲ್ಲಿಂದ ಮುಂದೆ ನಿಧಿ ಎಂ ಗೌಡ, ದ ಬ್ಯೂಟಿಫುಲ್ ಇನೋಕೇಶನ್ ಸಾಂಗ್, we set a graceful tone for this occasion. I thank for her also. So here ಇವತ್ತಿನ ಈ ಸಮಾರಂಭಕ್ಕೆ ಇದು ಸರ್ವೇ ಸಾಮಾನ್ಯವಾದ ಸಮಾರಂಭ ಅಲ್ಲ. GL Gurudat anta, he is the senior most guy in our department, Anaesthesia. He was holding in a Mysore Medical College. He also came as a speaker, and also this one is there. And another, just now I think everybody appreciated Dr. Manjuna, Dean and Director of Chamarajanagar. He was in Mysore Medical College. So on behalf of this, ಅವರಿಗೂ ನನ್ನ ಹೃತ್ಪೂರ್ವಕ ವಂದನೆಗಳನ್ನು ಅರ್ಪಿಸ್ತೀನಿ. ಅನದರ್ ಈ ಸಮಾರಂಭ ಆಗ್ಬೇಕು ಅಂದ್ರೆ ದುಡ್ಡಿಲ್ಲ ಅಂದ್ರೆ ಆಗೋದಿಲ್ಲ. ಸ್ಪಾನ್ಸರ್ಸ್, ಫೈನಾನ್ಸರ್ಸ್ ಅವ್ರು ಬೇಕಾಗತ್ತೆ ಈ ಸಮಾರಂಭಕ್ಕೆ. ತುಂಬಾ ಅದರಲ್ಲಿ BMS, ಆಮೇಲೆ IMID ಅಂಡ್ ಸೆಲ್ಯುಲಾರ್ ಅನರ್ಸ್ ಅಂಡ್ ಅವರು ಹೃದಯಪೂರ್ವಕವಾಗಿ ತುಂಬಾ ಇದರಲ್ಲಿ ನಮಗೆ ಧನವನ್ನು ಸಹಾಯ ಮಾಡೋದ್ರಿಂದ ಈ ಕಾನ್ಫರೆನ್ಸ್ ಈ ಮಟ್ಟಕ್ಕೆ ಸಕ್ಸಸ್ ಆಗೋದಕ್ಕೆ ಸಹಾಯವಾಗಿದೆ. ಸೊ ಇದರಲ್ಲಿ finally at this point actually there are many output thanks to delegates and also postgraduate students and interns, organizing committee members, and also department of our anesthesia, my department, department of emergency medicine, everybody they started work this one to make the conference very successful. So I call it a conference, nothing but a conference only, because even though it is a workshop and it is a what I call status is about this. So that's the thing I call this. So finally, I would like to thank the both MC, our technical and support team, and all the other teams, and also our IT team, and everybody. ಎಷ್ಟೋ ಜನಕ್ಕೆ ಪ್ರತ್ಯಕ್ಷವಾಗಿ ಪರೋಕ್ಷವಾಗಿ ನಾನು ನೋಡ್ಲಿಕ್ಕೆ ಆಗಲಿಲ್ಲ, ಕೇಳಲಿಲ್ಲ ಅಂದರೆ ದಯವಿಟ್ಟು ಕ್ಷಮಿಸಿ. ಎಲ್ಲರಿಗೂ ನಾನು ಹೃದಯಪೂರ್ವಕ ವಂದನೆಗಳನ್ನು ಅರ್ಪಿಸ್ತೇನೆ. ಥ್ಯಾಂಕ್ ಯು ವೆರಿ ಮಚ್ ಫಾರ್ ಆಲ್.
Thank you so much, sir. Now I request everyone to kindly stand up.
I thank Gangadhar sir and for his presence and chairing the session, everything support given to us. I thank you, sir. Now, national anthem, please get up for the national anthem. All of you be seated. Here only we will get you juice and also fruits. And we will start the panel discussion continuously.
ಹಲೋ, ದಯವಿಟ್ಟು ಕ್ಷಮಿಸಿ. ಆಕ್ಚುಲಿ ನಾನು ವೋಟ್ ಆಫ್ ಥ್ಯಾಂಕ್ಸ್ ಹೇಳಬೇಕಾದಾಗ ಒಂದು ಒಂದು ಆಕ್ಚುಲಿ ಬಹಳ ಸಲ ಮಿಸ್ ಆದರು. ಇವತ್ತು ನಮ್ಮ ನಡುವೆ ಎಡಿಟರ್ ಇನ್ ಚೀಫ್ ಆಫ್ IJA, ಇಂಡಿಯನ್ ಜರ್ನಲ್ ಆಫ್ ಅನಸ್ಥೀಷಿಯಾ, ಡಾಕ್ಟರ್ ಮಾಧುರಿ ಕುರುಡಿ ಅವರಿದ್ದಾರೆ. ಶಿ ವಾಸ್ ಹೆಡಿಂಗ್ ದ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಇನ್ ಹುಬ್ಳಿ. ಸೊ ಇಟ್ ಇಸ್ ವೆರಿ ಪ್ಲೆಸರ್ ಟು ಹಸ್, ವೆರಿ ನೈಸ್ ಟು ಹಸ್. Extremely sorry because we forget it. It is a great accommodation. But only thing, not an editor. She written books. There is also this one. She's there since from morning.
So we have written a book on scientific research paper. She is the editor of that book, and all the postages. I think it's better to take this book. It's a very good book, and it is published by JP Publications. So it's a very, very good book. It is displayed in our stalls here. All the postages, please take this. It's a very good new book.
We will continue with the panel discussion now. I request the panelists, Dr. Balasubramania sir, Dr. Sahana ji ma'am, Dr. Abhishek KB sir, Dr. Ganesh BS sir, to grace the dais for panel discussion.
So I think we had a fruitful discussion on how to arrive at a diagnosis and when to intubate, when to wait for NIV. Dr. Sahana gave a very insightful view of how to hold back your invasive mechanical ventilation and giving lot of importance to clinical examination of the patients over lab results. So continuing from that stage, so you are the resident now. So you have a challenging case at disposal. You have a 42-year-old man with leptospiral sepsis, already leptospira IgM positive, referred from a peripheral center and shifted to ICU after 12 hours in ED. They have stabilized whatever they could in ED. He's on almost 10 ml of NORAD. He has ongoing upper GI bleed with platelets of 22,000 and an INR of 1.5. Little scary scenario. Then you assess the respiratory status. Respiratory rate is 40. It is shallow. Saturation has started coming down. He's on HFNC initially while shifting from ED. He's drowsy but arousable, and there is a thick blood-stained oral secretions there. Cold extremities. Perfusion is not adequate, and no significant wheeze or bronchospasm, but his ABG shows this. His pH is 7.1, PaCO2 of 30, hypoxemia, PaO2 of 52, and lactate of 7. So there is no clear-cut waiting here. Okay. You do a lung scan, there's extensive B lines and one right lower lobe consolidation, suggestive of a pneumonia with possible going towards an ARDS. And echo, LV dysfunction is also there, a mild, dilated IVC. Stomach, there's already full stomach and aspiration risk. Okay, there is nothing I can do. I can't wait in this scenario. You decide that intubation is needed. And as a resident, you attempt a direct laryngoscopy. My God, you have no view at all. Complete active oozing is going on. Video laryngoscopy, lens is completely obscured by blood. You do some suction, you see, clear if possible, but still you can't get any orientation. Patient is desaturating to 68. BP falls to 82 systolic. So if the patient is now hypoxemic, this coagulopathic, blood is pooling, you're not able to tube, hemodynamically unstable, and there is just no help. What you will do? So I would call to God, Lord Subramanya, I'll say, Devre Subramanya, help madu anta. And to our luck, Lord Subramanya sends Bal Subramanyam, sir. So over to you, sir. Pratyaksha agidira, your resident is struggling. How will you manage? Because we need senior most person there. We can't manage this situation alone. God has only sent you. You have to manage this now.
This is a case of severe form of leptospirosis. It's a wheel disease characterized by triad of jaundice, acute renal failure, and hemorrhage. Hemorrhage can be both from any part of the body, including from the lungs. So already resident has tried intubating, but he failed. So before going for second attempt, I would like to optimize certain conditions. Like I would like to brief the team about my action plan, and also I would like to assign the responsibility to the each team members. Then definitely I'll go with the 30 to 40 degree head and up position, and oxygenation should continue throughout. Patient is already on HNFC, high frequency nasal oxygen cannula. Probably he's getting a FiO2 of more than 80%. That should continue, and in between the attempt, you can add one more source of oxygenation, that is the NRBM mask, or may go with the NIU mask with the CPAP mode of ventilation. So that is the second thing. Third thing, already he tried suctioning. Here, continuous suctioning is required by using rigid suction catheter, which is wide bore, such as Yonker type. So for this type of scenario, a method of intubation of choice will be, in my opinion, will be awake intubation with continuous suctioning. So why not DSI? That is a delayed sequence induction, because here the patient is drowsy but arousable. He is not agitative. And second thing is that even after IV induction or sedation, patient oxygenation may not improve. With regarding to rapid sequence induction, this patient is an anticipated difficult airway, and moreover, the intubation may take a lot of time. So there are going to be a apnea, a long duration of apnea period, which patient may not tolerate. So I would like to go with awake intubation with continuous suctioning by using the wide bore rigid suction cannula by a method described by Dr. Jim Ducanto. That is called as Salat technique. That is a suction assisted laryngoscopy and airway decontamination. So it is performed like this. So by using the rigid suction cannula, I'll introduce through the right side of the mouth. Then gradually I'll suction the oral secretions, and I'll keep the suction catheter at the hypopharynx for the continuous suctioning. Then meanwhile, I will go with the video laryngoscope, preferably CMAC, because with the video laryngoscope, either no or lesser external laryngeal manipulation is required, also for a better coordination with the team members. I'll gradually introduce the video laryngoscope till I visualize the epiglottis. Till I visualize the epiglottis. Once I visualize the epiglottis, with my index and middle finger, I push the section catheter to the left side of the mouth, and also we can stabilize the section catheter by using the blade of the video laryngoscope. Then, with the help of the bougie, I think I will be able to intubate the patient.
So that was a wonderful in-detailed answer. So if you actually as a student observe Sir's answer, see there is a lot of preparation that went on, both mentally and getting things organized before you go towards intubation of this patient. So you should first recognize that you need help, okay, even if that's an emergency scenario. Because if you just give drugs and attempt, things are not going to help. The message is that. And then, as Sir said, go towards the technicality, the salad technique or the next thing. So there is also a little bit of problem in the patient in terms of pH. pH is 7.1. So I'll just combine the question 2 and 3 here and ask Sir, what is the induction agent in terms of severe acidosis with this pH? And how do you optimize this pH in such a scenario? Because lactate 7.1 pH, patient is going to be apneic. By the time you tube and you take a little longer time, pH will drop to 6.9 and cardiac arrest. So it's a very delicate scenario. So how do you go about this, sir?
So there is a severe metabolic acidosis, which I can reduce from the ABG analysis. And in this scenario, propofol is totally contraindicated. The ideal agent of induction agent would be ketamine, which is because it is sympathomimetic and also cardiostable. Also, it has got a bronchodilator activity. And other alternative will be etomidate, but it can cause a transient suppression of the adrenal gland.
So, sir,
regarding the pH, the pH is 7.12, and carbon dioxide is 30, and bicarbonate levels are not given. Probably it will be around 9 to 10, and lactate levels are high, which is suggestive of acute metabolic acidosis with the partial compensation because there is a decrease in the carbon dioxide levels. The treatment for lactic acidosis will be the treatment of the cause. Here the cause is tissue hyperperfusion because of the massive bleeding from the upper GI tract. So also I would like to improve the perfusion by using IV fluids, and also we can give vasopressors and sodium, the correction of bicarbonate. So actually it may not be required. Generally it is not required, but this is ongoing and the treatment is not immediately possible. So hence the partial correction may be tried with the target pH of 7.2 and bicarbonate levels of 15. Suppose if there is any respiratory acidosis, fortunately there is no respiratory acidosis, which is very difficult to treat because with the positive pressure ventilation, there can be insufflation of the stomach and there's a more risk of the aspiration. So if at all there is a respiratory acidosis, I'll treat after the airway is secured with the endotracheal tube.
So the take-home message is no textbook tells you to give soda bicarb because there is no class 1 indication here. But you need to realize the local need there because there is a bit of acidosis and patient was breathing at around 40 and suddenly you are going towards an intubation where the respiratory compensation may not be there, and maybe, as sir said, optimize the hemodynamic status a bit more, give a bit of fluid if LV dysfunction is mild, and maybe optimize your NORAD, and more importantly, in acidotic condition, vasopressin acts better. So you maybe start a low dose of vasopressin also. So that's a trick and trades of practice that it will not be given in textbook. So thank you, sir. Thanks for the advice there. So finally, what's your next choice in an Indian setting? Do you go for a bougie guided attempt or a supraglottic device or a front of neck access if all of this what you have tried is failing?
So actually, as per the difficult airway guidelines 2025, once the intubation fails after 3+1, that is a fourth attempt by a senior personnel, so next the plan of action should be supraglottic insertion of the supraglottic airway device. Here, I'm not sure whether you can go with that. If at all, I will go with the second generation supraglottic airway devices like LMA, ProSeal or iGel for temporary securing the airway. The one more problem here is that the patient is having pneumonia and ARDS, so airway pressures are going to be very high. So I don't know whether I will be able to ventilate with the with the supraglottic airway device in place. So other choice will be bougie guided intubation attempt, as I told, and my next choice will be emergency front of neck access using needle cricothyrotomy.
Thank you, sir. It's a nightmare scenario for anybody because first of all, you're not able to put a definitive airway, and then you're looking at supraglottic airway device, temporarily managing coagulopathic patient. You want to front of neck access also, he'll bleed. So as sir told, it's a very challenging scenario. Call for help. And some PR management exercise. One of the team members should sit with the family when you're attempting and say, this is the scenario we are just trying to save. Okay, that actually helps in a real life world where you give constant update to family. One member is taking care of the social part of it. So thank you, sir, for the wonderful discussion. So moving on, we have learned about how to manage emergency airway, difficult airway in an ICU and ED setting. So, and if I can ask our Ganesh sir, are you vegetarian or non-vegetarian?
Pure vegetarian.
Pure vegetarian, nice. So it's night, 8 o'clock, monsoon night, not a chilly night now. Just your wife have cooked nice gobi manchuri for you. You want to eat, and it's raining. It's a very good, nice romantic music going on. But unfortunately, you are also on call and in a very busy tertiary ICU. There is a sudden surge of emergency that hits your unit. One after another, there are 4 sick cases that have come, all different cases, and all requiring invasive mechanical ventilation, and residents are overwhelmed. The PGs are like, ye kya night duty hai yaar, senior to ghar mein gobi manchuri kar rahe hain aur hum duty kar rahe hain. We'll do one thing, we'll call up Ganesh sir, spoil his night. So they give a call, but Ganesh sir, being Ganesh sir, obliges, don't worry, I'm there, I'll come. So finally you call up some more pre-duty, post-duty, off PG. You set up 4 teams because you have 4 different cases now. So this is the scenario 1. Severe asthma exacerbation with status epilepticus, 32-year-old woman. She's diaphoretic, she's gasping, there's a silent chest, NIV has failed and she's tiring rapidly. pH is 7.26, PaCO2 72, with PaCO2 6. On NIV, FiO2 60%, it's just barely holding on. She's completely exhausted. Okay, so resident has intubated and you have to shoot orders for mechanical ventilation. The question for you is, what initial ventilatory settings would you start immediately after intubation to minimize the dynamic hyperinflation in an obstructed asthmatic patient? Of course, because all your drugs will take some time. Patient is intubated. So how do you manage the settings, initial settings?
Looking at the scenario, the diagnosis is very clear. It's acute severe asthma, type 2 respiratory failure. There is a saying in one of our old books, mechanical ventilation books, which says that if you can clearly ventilate a patient of acute severe asthma, you have intubated a wrong patient. It has to be a difficult ventilation after intubating a acute severe asthma patient. So here my goals for giving orders for the resident or ICU nurse would be,
I need to optimize the respiratory failure by proper ventilation. I need to make sure that hemodynamics are maintained with the amount of ventilation, ventilator settings I'm going to choose. And also I need to prevent the air trapping, which is going to be dynamic hyperinflation. I also need to maintain something called permissive hypercapnia in this particular patient. Young patient slowly fails on NIV or HFNC onto ventilator. So my initial settings would be, I would like to get an immediate chest X-ray for this patient. So just to know that whether it's an infective exacerbation or a non-infective exacerbation of acute severe asthma. So the settings may be volume or pressure control. You can choose any of these two. If for infective exacerbation, it's always better to go for pressure cycle ventilation. So initial settings would be go for the lower tidal volumes and lower respiratory rate, like 6 to 8 ml per hour of tidal volume, and respiratory rate also needs to be around 12 to 14 per minute, with the PEEP starting at 5 centimeters of water. And IE ratio, maybe you can start with 1:2. The goals for ventilation for this particular patient should be, you need to minimize the time of inspiration and also give more time for the expiration in this patient. This can be achieved by decreasing the respiratory rate and also increasing the flow rate on the ventilator. So whether it is volume control or pressure control which you are choosing, increase the flow rate to 60 or sometimes up to 80 liters per minute on the flow rate. So this would always help. Additionally, you should always remember there has to be adequate sedation, paralysis, as well as bronchodilators and steroids, which you can use parallelly for this particular patient.
Sum up, any control mode of your choice, lower rate, that's the general tendency, because it is a airway expiratory flow problem, other end of spectrum. So I'll just like to sum up students. See, ARDS is one end of the spectrum, COPD asthma is another end. ARDS is a alveolar problem, COPD asthma is a airway problem. So you will have to keep a lower rate, so as Sir told, and a very high IE ratio 1:3.3, even 4, and a very lower rate, because duty cycle time is what you want to take care of. And the moment you cut short the duty cycle time, even expiratory time comes down. We don't want that. And one very, very important thing is, as soon as you wash out the CO2, there will be a drop in BP, because it's a sympathetic stimulation. So keep your NORAD ready. So another similar case, as we discussed with Sahana ma'am, same patient you can take something like that with pH of 7.19, PCO2 of 92. There is no chance that you can, and intubation has been done, and there is marked chest hyperinflation. Obviously, you can see it's a completely barrel shaped. There is a DHI that went on a lot. And so, how do you tackle this patient on a ventilator compared to asthma?
So the here challenge is the patients are little older in COPD compared to the asthmatics, and also PCO2 retention will be much more further in case of COPD patients compared to asthma patients. Again, the challenge would be to maintain the optimum ventilation and maintain permissive permissive hypercapnia, in the sense I am not talking about keeping the PCO2 at a higher level. It's always about the management of the pH. We all know that the central chemoreceptors responds more to the pH, which will keep the patient's respiratory drive rather than compared to the hypoxic peripheral chemoreceptors. That's where we try to keep the pH somewhere around little lower level, like we maintaining the respiratory acidosis up to 7.3 or probably 3 to 3.5 is that's what the most of the books mention. So here again, my choice of ventilation should be, I can choose either pressure or volume control. Anyone is acceptable. I would like to go with a volume control ventilation in this patient with a lower respiratory rate of 12 and tidal volume around 6 to 8 ml per kg body weight. With here, definitely I would like to go for increased IE ratio, inspiratory to expiratory ratio of 1:3 or maybe 1:4 as required. And initial FiO2 can be started with 60. No need to go with the higher FiO2, because our target PO2 as well as target SpO2 for these kind of patients would be somewhere around SpO2, even if you maintain around 88 plus or minus 2, and PO2 levels 70 to 80 mm of Hg are also very optimal for this patient. That would be more than enough. And adequate ventilation and bronchodilation as well as steroids in parallel with the ventilator settings are always required.
So very crisp answer there. See, what Sir gave a very enlightening message is, we ventilate for pH. We do not ventilate for PCO2. As long as the pH is in acceptable range, accept a PCO2 which is little higher. I've seen patients who came with 90 PCO2 and then the night resident vigorously washes out the CO2 and tomorrow, next day morning, he says, I don't know why the patient had a seizure, I had to give Levipil. It's just rapid shifts of the pH in the brain that caused a seizure, okay? Then you'll end up doing a CT brain to rule out there is some IC bleed, okay? So it causes that rapid shift of carbon dioxide has caused seizure in the patient. So be little slow. You can take over a period of 12 hours, 18 hours also. And there is one more component. These patients have a bicarb of around 30, 34. So suddenly you'll end up pushing the patient into a metabolic alkalosis by overcompensating. So go slow when it comes to COPD as per Sir's advice. So next scenario, you move on to the third bed. This patient has a post-op respiratory failure. He was operated for a pancreas tumor, thoracotomy, and coexisting esophageal tumor, pull-up done, this, that, diaphragm excised, a bar part of it. So post-op extubated, looks good, but third day he started hypoventilating and he's drowsy and desaturating. So his pH is 7.34, PaO2 52, PCO2 41. Point of care lung ultrasound shows a basal collapse with poor diaphragmatic excursion and intubation is done. What instruction do you shoot for initial ventilator settings for this patient for your postgraduate?
Yes, here it's more of a post-op respiratory failure with type 1 changes, type 1 respiratory failure changes. Here I would like to get a D-dimer levels immediately just to make sure that whether I'm literally treating the atelectasis versus the embolism because it's a post-operative period. Once I send the D-dimers levels, I would like to go for the recruitment maneuvers here, where I can always look upon the driving pressures, I think which was discussed previously. So try to look at the patient's driving pressure. Driving pressure is basically a difference between plateau pressures subscribed by the PEEP values. So in this kind of recruitment maneuvers, we try to reduce the driving pressure so that patient can start recruiting more of the alveoli in the non-ventilated patients. So for here, the initial ventilator setting should be, I would like to go for the pressure control ventilation with the FiO2 starting from 60, which can be escalated to 80, where we can increase the PEEP value. So starting with 6 to 8 centimeters of water can escalate to 10, and also pressure support can be added above that with 15. And keep the respiratory rate on little higher level, near normal, maybe 16 to 18 respiratory rate I can keep for this patient. And sequential ABG values as well as sequential X-rays will always help in this patient.
So basically, the importance is on PEEP to open up the collapsed alveoli. So, and a normal rate would suffice, and possibly wean early, as Sir told. Once control mode things settle down, lungs open up, work of breathing is high. Come down, and you can go ahead with the pressure support. So, final case, another end of the spectrum. There's a ARDS patient with severe viral pneumonia. So this is a 45-year-old woman in septic shock on noradrenaline, dyspnea. ARDS is diagnosed on HFNC. She's worsened. PaO2 is very bad. So you have intubated. So the resident doesn't know what is a lung protective open lung ventilation. So what is the initial settings that you do in a classical ARDS patients? How do you begin with tidal volume per kg body weight? What is the initial PEEP FiO2? So what is the starting respiratory rate that you start in this kind of patient?
Again, the ARDS management, we learned a lot of information from the ARDS net protocol, which happened somewhere in 2001 to 2, and it is still being followed at most of the places as well as ICUs. Accordingly, where we go for lung protective as well as recruitment strategies with a low tidal volume and high PEEP is the main funda here. So here we want to keep the respiratory rate at higher levels. Try to look at the patient's basal respiratory rate before you intubate. Say before you intubate it, before the patient goes into respiratory fatigue or loses the work of breathing. So baseline respiratory rate is somewhere around 35 or 40. So you can always start your respiratory rate at around 28, 30. No need to say that we want to increase the PEEP and maintain the minute ventilation. It's not going to work like that. So you need to make sure that you give more time for the inspiration here. Like Varun sir was already discussing about APRV settings, where we give more time for the inspiration in ARDS patients. So here, how to give more time for the inspiration is, one is try to increase the respiratory rate and reverse the IE ratios, like you can bring it down to 1:1 or maybe 1:1.5 if the patient was previously on 1:2. So then increase the PEEP in a incremental way, like initially start with 8 to 10 centimeters of water with a pressure support additional of 10 centimeters, where we can always escalate. So when we increase the PEEP, we think that we are increasing the pressure. Basically, we are trying to reduce the driving pressure of the patient. So driving pressure, this is what ARDS net guidelines also came up with. Initially, they thought by increasing the PEEP, so they are recruiting more alveoli into the picture, but they failed. They found more mortality. So then they try to increase the PAP, like peak inspiratory pressure, or the plateau pressures also they try to increase. Still, they were seeing the more mortality. Then they tried to manage the driving pressures. The driving pressures came into the picture and helped a lot. When the driving pressures are reduced to the minimal with increased respiratory rate as well as inverse ventilation, then they started seeing that the mortality is coming down on these patients. Much more challenging thing on this patient will be already on NORAD. So any increase in PEEP always again reduces the venous return. So that could be much more challenging. So most of my residents says, sir, we'll do everything. Hypertension go there, we'll increase the NARAD, we'll start dobutamine by looking at the EF and all. But as per my experience, if the patient goes into hypotension after intubation, it's always a challenging in the initial first 24 hours, increased chances of mortality. And my intensivist always say that you send the patient on NARAD, they are not coming out. You make sure that you don't send the patient on NARAD. That's what my intensivist always says that. So here protective strategy is higher respiratory rate, higher PEEP and inverse ventilation.
Thank you, sir, for a crisp answer. Basically, what you are looking at is for postgraduates, COPD asthma is one end, this is another end. I repeat that you need a lower rate for COPD asthma, whereas ARDS, you want to maintain the mean airway pressures, you give a higher rate. PEEP itself, it's a class in itself, how to set PEEP. There are at least 7 to 8 ways of setting PEEP. If I have to minimize as early as possible, sedate, paralyze, prone, whatever is required. So overall take home message is don't, as soon as you intubate, do not set a rate of just 14 as you set on an OT ventilator. As simple as that. Each patient is different. Each ventilator settings, everything you will have to think of for that particular patient and then manage. Thank you very much for all the panelists for sharing their deep knowledge and helping the students break up things, what textbook gives and what clinical practice. We usually see there is a large difference between what textbook says and what clinical practice is. Trying to bridge that gap, excellent way of putting it through for the students. Thank you once again.
Would like to thank the panelists and moderator for that insightful discussion. I'd request Dr. Madhuri ma'am to felicitate our moderator and panelists. I request Dr. Rashmi ma'am to felicitate our moderator and panelists.
So I want to honestly confess one thing, sir. It's very difficult, sir. It's really, I think. Thank you. Thank you so much. Thank you so much. No, no, no. Okay. Thank you so much.
As we proceed with our CME program, we now move to a session of great practical importance: how to maintain ventilator and monitoring. Proper maintenance and vigilant monitoring are essential for ensuring patient safety and optimal ventilator performance. Hence, I'd like to invite the speaker, Dr. Santosh S. Ujjinappa sir, Assistant Professor, Department of Emergency Medicine, Basaveshwar Medical College and Hospital, Chitradurga. Also, I'd like to invite Dr. Manjunath Edji sir, Dean and Director, Chamarajnagar Institute of Medical Sciences, Chamarajnagar, to assume the role of the chairperson for this session. Dr. Manjunath sir did his MBBS MD DA from Government Medical College, Mysore. He is an experienced Army medical officer and was posted for 1 year in Shillong, Meghalaya for Assam Rifles. He was a consultant anesthesiologist in Kerala for 5 years before joining the government service in 2000. He was the president of ISA Karnataka State Chapter, former secretary and president of ISA Mysore City Branch, Mysore, governing council member ISA Karnataka State Chapter. He was also a former editor of Karnataka Anaesthesia Journal. He was an MCI inspector and member of Equipment and Syllabus for Specialty of Anesthesia, NBE, Panel of Examiners and National Board of Examination, and member of Specialty Board in Anesthesia. He was awarded the Lifetime Achievement Award 2025 at the ISA State Conference, Mangalore. We welcome you, sir, and we would request you to introduce our speaker.
Good afternoon, everyone.
At the outset, I would like to thank the organizers for giving me the opportunity to speak, opportunity to chair this session. And Dr. Santosh S. Ujjanappa is Assistant Professor in Department of Emergency Medicine, Basveshwara Medical College and Medical College Hospital and Research Center, Chitradurga. He did his FRCEM, DNB, and ECFMG certified USA course, and he is a AHA certified instructor in basic life support and advanced cardiac life support, certified in advanced trauma life support ATLS from RCS UK, and key achievements and contributions are pioneered the establishment of emergency departments and was instrumental in obtaining Medical Council of India MCI recognition for postgraduate seats. Established the hospital's first code blue team and a 10-bedded emergency ICU, initiated a dedicated stroke team and commenced thrombolysis for acute stroke patients. It's over to you, Dr. Santosh.
Good afternoon. First of all, I'd like to thank the moderator for such beautiful introduction of mine. I'd also like to thank Siddhartha Medical College faculty, especially Kulkarni sir, for providing me this opportunity to speak this day. So today's topic of mine is on the maintenance of mechanical ventilator and ventilated patients and their hemodynamic monitoring in the ICU. So the topic is quite vast. And I'd like to begin with thinking about the hardware of the ventilator. So let's compare. This is not working. So I'd like to compare our ventilator with, let's say, would you board a plane which has not undergone safety checks? Let's say you're boarding a plane in an airport which has not undergone safety checks. That wouldn't be safe, is it? That's how it is. If you don't do safety checks, if you don't have safety measures before putting your patients on the ventilator. ICU outcomes are very much important, especially in ventilated patients. To begin with, already the ventilated patients would have a mortality risk of 30%. All the ventilated patients would already have a mortality risk of 30%. So it is very essential that we start with how we take care of our ventilators, right? So to begin with the ventilation, we'll have to visually inspect. Right. So visually inspect the ventilator for the battery backups and UPS backups. It should always be above 80%. Just like you need to have a fuel in your aircraft, that's how important your battery is in your ventilator. And always check your gas supplies and their pressure. Remember, your pressure in your air and O2 supplier cylinders or the generators should be at least 50 to 60 psi. One of the other speakers were mentioning the incidences which have happened during our COVID pandemics because of loss of pressure or delay in getting the oxygen supply to the respective generators. So it is very essential to maintain pressure and visual inspections, and always inspect for cracks, leaks, and contaminations. Right. So I'd like to begin with, I'd like to start telling you about the hardware of the ventilator itself. If you see here, there is a O2 supply, there is an air compressor. So the O2 supply usually goes through a color-coded pipes. The O2 supply would be white-colored pipe, and air supply would be a black-colored pipe. We will show you in your workshops. So O2 supply and air compressor would go into your ventilator, and there is a blender within the ventilator which blends according to the FiO2 you're setting. According to the FiO2 you want to give it to the patient, the blender mixes the air with the oxygen. And that after that it is pressurized, then after that it goes through the inspiratory valve, then there would be a flow sensor. Then because your air is compressed, air and oxygen is compressed, all the air and oxygen, when it gets compressed, it gets cold and dry. So if you supply that cold and dry air into the patient, it would definitely cause harm. So that's why we need to have humidifiers, right? So air and oxygen goes through the humidifier where it gets humidified. Then through the humidifier, it gets into the patient. So ultimately, there is an inspiratory limb and an expiratory limb in your circuit. If you remember your Bernoulli's principle, through the inspiratory limb, it would directly go, because it is a horizontal pathway, it would directly go into your expiratory limb. So the brain of the ventilator is expiratory valve. The brain of the ventilator is expiratory valve, which always sets what kind of PEEP you need. PEEP is positive end expiratory pressure and peak inspiratory pressure. PEEP and PIP are being maintained by your expiratory valve. So expiratory valve, either they come in diaphragm or they are mechanically in rod kind of pathway in the olden days, and there are other modes of expiratory valves. So they, according to their movements, they obstruct the expiratory flow. They obstruct the expiratory flow in such a way so that pressure builds up in the patient's lungs, right? So expiratory valve is much more important, and it's most important. And post your expiratory valve, there is another flow sensor. And if you see here, there is microcontroller, which gives PEEP adjustment and mechanism. So this microcontroller is connected to your software within your ventilator. So that software where you can modify your FiO2s and your PEEP and PIP pressures, right? So this is the hardware itself. So you need to know your hardware very clearly so that you can operate your ventilators smoothly. Yeah. So like I said, there are various sensors, FiO2 sensors, flow sensors. There is a test lung that you should be using. Before you start the patient on ventilator, put the patient on the test lung, check if there is any leaks, check if it is properly ventilating, check if the pressures are adequate, check if the volume is being delivered, check if the FiO2 is being properly maintained. So like I already mentioned, compressed gas will be cold and dry, and it runs through an humidifier. Yep. So when expiratory limb is it creates the resistance, like I said, it creates the peak inspiratory pressure, PEEP, as well as time of inspiration and time of expiration. So I hope I am clear about this. Expiratory limb is most important here. And we need to have a checklist before we start, right? So one is, like I said, power supply. The next is the airflow. If the pressures are being very well maintained, and the monitors. If your monitors are working well, if the settings are adequately running, if you have run your pre-check lists, if you have a checklist, if you have documented it properly, and if your alarms, one of our speakers have already told about alarms. So if alarms have been properly set, so all of these may make an important decision when it comes to before starting the patient on ventilation. The cleaning and disinfection. We should always use a hydroalcoholic solution. We shouldn't be using acidic or alkaline solutions to clean the ventilators. It could be corrosive on the ventilators itself. And you shouldn't be directly spraying, rather use a cloth to clean the ventilator. So infection control measures. So you should always maintain a closed suction system. Closed suction system is very much important so that the infection spread is controlled. We are already going through a lot of sepsis, septic shocks, especially in India. It is more seen compared to Western countries. So we should take care of our ventilators. We should make sure that it is a closed circuit system so that it reduces WAP. And like it is mentioned, closed suction catheter should be changed every 72 hours, and make sure there is no breaks in the circuits, and avoid breaking the circuit unnecessarily. The much more frequently you break the circuit, maybe for suctioning, maybe for some other reasons, maybe for moving the patient, it induces more and more infection. And make sure the nebulization is so the bacteria can by touching, maybe there is no hand hygiene, maybe it's not a closed system. More closed it is, and lesser the chances of infection. And yeah, that is also there. Yeah, there could be viruses within the air itself. And nebulization should also be inline nebulization, so that it doesn't also cause infections. The documentation again is one most important with checklist. So at every change of shift, your nurses or a respiratory therapist or the doctor in charge itself could always make sure the documentation is adequate. Make sure you have done all your checks. The filter has been changed, the suction system has been changed, humidified water has been maintained, and settings have been done, alarms and troubleshooting. So when should we replace the entire circuit? Immediately, the entire circuit should be replaced when there is a visible contamination on your circuit, there is a significant leak in your circuit, expiratory valve is malfunctioned, circuit collapse or a kink, foul smell, or accidental aspiration of the water within the circuit. So this is again one most important thing that you should remember when you should be changing the circuits. We have seen the same circuit as ran through multiple patients in some institutions. So that's definitely not acceptable. So we have to ensure circuits are most important in order to avoid VAPs and infections. Yeah, so these are the schedules. Bacterial and viral filters should be changed between every patient. HME filters should be changed every 24 hours. Breathing circuit between every patient. O2 cells should be changed every 12 months. Flow sensors according to the manufacturer, and the batteries every few years. Right, so do ventilator performance check, like I already told, it should be done at change of every shift or a patient. Troubleshooting has already been taught by other speaker, so I won't go into this much. So let me just be clear and very short and concise here. High pressure alarm will be set because of secretions or kinked tube or biting, or if the HME is blocked, or low pressure could be because of disconnection or a cuff leak or a loose circuit. And low volume alarm could be because of the leak, and apnea alarm could be because of a disconnection, and high frequency alarm could be because of decreased sensitivity. Right. So if you see the picture here, so we have an oxygen supply and we have an air supply. It goes through the ventilator where it is gone through the blender, then it is compressed, then it goes to the humidifier. That humidifier eats the air and oxygen to up to 37 Celsius, makes it humidified, sends it here back into the inspiratory limb. There would be a flow sensor here, and it goes through the expiratory limb to the ventilator. So the flow sensor is here, and expiratory valve again would be here. This has already been spoken. What are the initial settings? So ideally, lung protective strategy, according to it happens according to the predicted body weight. What is predicted body weight? If anybody could tell me what is predicted body weight? Predicted body weight is according to the height of the patient. So the patient could be 120 kilograms, or he could be 50 kilograms. The lung volume doesn't vary much. So the lung volume depends on the height of the patient. So predicted body weight is according to the height of the patient. If you see the calculation, it is upon the height in inches, and this is the particular formula to predict the body weight. So make sure when you're setting a tidal volume, you're using the predicted body weights and not the actual body weight. And your plateau pressure should not be above 30 to avoid barotrauma. This has already been discussed, the PEEP selection and FIO2 strategy. So I won't go into that. The curves, I'll just tell you another doctor has already discussed. So this is the auto PEEP. Auto PEEP is nothing but breath stacking or air trapping. So in the flow time diagram, if you see the expiratory limb is not reaching the baseline, it could mention that there is a auto PEEP, breath stacking or air trapping. So this is the flow time diagram again. So this tells us the resistance, this tells the compliance, and this is the auto PEEP. Yeah. And one more important thing is mechanical power. If the power is increased, the mechanical, you should be calculating mechanical power as well. If the power is above 17 joules per minute, the ventilator induced lung injury could be increased. So you should calculate mechanical power and make sure the work of breathing is lesser. Make sure you sedate your patients. Yeah. And driving pressure. Driving pressure is something where the amount of pressure you need to insert to put the flow into the patient. So it could be hindered by your resistance or your decreased compliance as well. So driving pressure is the difference between PEEP plat and the PEEP. So this is one important slide where if the PEEP plat is increasing and there is no change in PEEP and the driving pressure is increasing, that increases the mortality. If the PEEP plat is increasing, if the driving pressure is increasing, it increases the mortality. It could cause the volutrauma or a barotrauma. Right. So I'll talk about some of the monitoring aspects where there is a static compliance and dynamic compliance. What is compliance? If anybody could tell me what is compliance? What does it tell us? It is the stretchability of the lung. So imagine your lung as a balloon, how stretchable it is. If it is, let's say, if it is a case of ARDS, ARDS is where the balloon is filled with water already because of increased permeability. So if it is already filled with water, your compliance would be lower. Yeah. So so static compliance is where when there is no airflow, what is the stretchability when there is no airflow? Dynamic compliance is where when the airflow is happening, what is the stretchability? So according to these static compliance and dynamic compliance, we can predict the ventilator associated lung injury. So these are the specific formulas. VT divided by P plat minus PEEP for the static compliance. This is P peak minus PEEP for the dynamic compliance, and this is for airway resistance. So these are also important components that we should be calculating in order to avoid ventilator associated lung injury. Right. So static compliance. Right. So static compliance, like I said, it's when there is no airflow, the stretchability is predicted by static. When there is flow present, that is dynamic compliance. And the pressure used for static compliance is plateau pressures. For dynamic compliance, it is peak pressures. And static compliance shows the lung stiffness. And dynamic compliance shows the lung stiffness with airway resistance. So for example, ARDS and fibrosis, the compliance static is already increased because of the, let's say, because of filled air or because of fibrosed lung tissue. And dynamic compliance is where the narrowed airways. So let's say the compliance could be okay, but the resistance can be high. The compliance could be normal, but the resistance can be high because your airways are narrowed in probably cases like asthma and COPD. Yeah. So, and one more significant thing is RAS monitoring, Richmond Agitation Sedation Scale. Why do we consider RAS here is, so the patient asynchrony and dysynchrony we should be avoiding. If the patient is not synced with the ventilator, it's like a bad marriage. The husband and wife both are fighting, so it can end up, so husband is like the ventilator, wife is like the patient itself. In between, the child is suffering, which is your lung. Yeah. So asynchrony and dysynchrony should be avoided. RAS is very important, where there is mild sedation, moderate sedation, and deep sedation. So anything less than -3 to -5 is deep sedation. Anything above that is moderate sedation. So we should make sure that -3 and -5 is avoided, so that it prolongs our weaning process. It fatigues our respiratory muscles and your diaphragm. And we should also ensure that there is a spontaneous breathing trial given every day, and awakening of the patient should be done every day, so that weaning would be easier. Right. So this has already been, I've already spoken to you about all this. So let me speak about ventilator-induced lung injury. So we have already discussed volume trauma. If you are giving anything above 6 ml per kilo, you could be inducing lung injury, volume trauma. So ensure that your peak pressures are and plateau pressures are lesser, so that volume trauma, barotraumas are happening less, and adequate PEEP is necessary. PEEP keeps the alveoli open. If the PEEP is inadequate, your alveoli could collapse, which can lead to atelectotrauma. Biotrauma is where, if you minimize the driving pressure and inflammatory response, your biotrauma is also reduced. And optimized sedation and ventilator settings are necessary to adequately synchronize and ventilate the patient. VAP. So this is most important. VAP happens when the patient has been ventilated more than 48 hours. Yeah. So in order to prevent VAPs, which is more common in our Indian ICUs, where all the precautions are not taken adequately. So head of the bed elevation should be at least 30 to 45 degrees head end elevation. Oral care should be given, and daily sedation vacation should be done. Spontaneous breathing trial should be done. Peptic ulcer prophylaxis, DVT prophylaxis. Cuff pressure should be maintained between 25 to 30, so that there is no leakage in the ET cuff happening. Subglottic suctioning helps frequently in reducing the VAP, and tracheostomy should be considered if you are ventilating anything beyond 7 to 10 days. So VAP is another important concept, and you should maintain all of this with your checklist. We have already discussed few cases in panel discussion, so I'll just probably skip this scenarios. Just to say, ARDS, you need to have low tidal volume, high PEEP, and probably inverse ratio, where your inspiratory time would be higher. And ABGs again are very important. ABGs should be done every 6 hours, up to 4 to 6 hours, to ensure that oxygenation and retention of the carbon dioxide are avoided, and your pH is very well controlled. COPD exacerbation. COPD again, it was discussed in your panel discussion, where your respiratory rate should be lower, your I and E ratio should be longer, so that you're expiring your air through prolonged expiration time, and pressure control mode would be better, and you have to minimize your air trapping, auto PEEP, or breath stacking. Make sure there is a sedation is lesser. If you're adequately sedated, you wouldn't have generated auto PEEP. Yeah. Septic shock plus ARDS. So this is again one of the most frequently encountered cases, where you have again set your tidal volume for 6 ml per kilo. Your PEEP is 10. Your driving pressures are less than 15. Mechanical power is less than 17. So we should also remember your driving pressures and mechanical power. Never forget those, and make sure your antibiotics and fluid resuscitation is happening very well. If you have ventilated everything, if you have done good antibiotic coverage, if you have resuscitated fluid, if you have done good fluid resuscitation, but you have not set your ventilator properly, it's not going to give a good ICU outcome. So everything together gives a best outcome of the patient. So right. So few more slides where I'd like to discuss about pulse pressure variation. Pulse pressure variation is where if you put an arterial line, so if you see a pulse pressure maximum and this is PP minimum, PP maximum and PP minimum, and this is how you calculate PPV, PP max, PP min. So this is your arterial line and this is your stroke volume variation. For stroke volume variation, you would need a special monitors where some thermodilation techniques are used where you can monitor your stroke volume. So pulse pressure variation and stroke volume variation. Right. So why are these important? Stroke volume variation and pulse pressure variation. So this is what tells us. So how is it measured? Through arterial line. So stroke volume variation is measured through your special cardiac monitors where flow track monitors or this is done. So why are these important? Because for your fluid responsiveness, if the patient is fluid depleted, if you're giving your fluid and the pulse pressure variation is adequate, so that means he's a fluid responder. Yeah. So if anything above 13% of pulse pressure variation, that means the patient is fluid responsive. If anything lesser than that, that means probably patient needs vasopressors. He may not need fluids anymore. If the pulse pressure variation is already higher and the patient's blood pressure is still dropping, he won't respond to your fluids. You may need to start your vasopressors. Similar with the stroke volume variation. So make sure learn these concepts of pulse pressure variation and stroke volume variation. And there is one more significant concept which is dynamic arterial elastance. So this is a ratio of pulse pressure variation and stroke volume variation. So again, if anything, so if dynamic arterial elastance, if it is anything above 1, that means cardiac output won't raise above the map. You should add vasopressors. And because it is a vasomotor demand, it is not anymore fluid responsive. Yeah. So it's a ratio of pulse pressure variation and stroke volume variation. If it is anything above 1 is fine. If it is anything less than that, it needs vasopressors and not fluids. Yeah. Right, so I'd like to conclude with this. Thank you so much.
Thank you, Dr. Santosh, for a cooperative lecture on monitoring of the ventilators. And the session is open for discussion. Any questions from the audience? Yeah, definitely new chapter. Any questions from the audience, especially from the postgraduates? So just to add to that, so as you said earlier, the monitoring is very important. Just like that, what we are doing in our anesthesia regular checkup, just like you mentioned that the moment the flight taking off, before that you have to do everything that we are called a cockpit drill. That I think everyone knows about the cockpit drill. And the same thing, like just like anesthesia machine, what we are doing here also we have to do it. So before the connecting the patient and after connecting the patient, and a periodic checkup is also important. Especially you have got ICU, biomedical engineer will be there, OT technicians will be there. You have to tell them that routine checkup is also very important, especially periodic checkup, weekly checkup and monthly checkup, and you have to do all those things before connecting the ventilators. Second thing regarding your troubleshooting, sir.
Yes, sir.
Troubleshooting also you have to be very careful.
Yes.
As far as the machines are concerned, I think all the speakers spoke about that, and especially changing the circuits. So we have got silicon circuits are available, and as well as the Portex circuits are available, and especially the ventilator fellows, they will go, instead of giving the silicon, they will going to give the Portex. So the disposable Portex you have to identify, and for each patient you have to change it. For silicon, I think ordinary washing and so drying is also most important for each. When the patient is weaned off, you have to take and wash it with a water, clean water, and then you can make them dry and then reconnect it. That's also possible nowadays. Regarding VAP, I think I talk about the VAP in detail. So nowadays, just like our septic shock bundles, VAP bundles are also available now. VAP protocol bundles are there. So you need to see those things. VAP bundles nowadays. Okay. Thank you very much. Thank you for availability, sir, because it is time is running out of time. So any questions, post-graduates can ask him during the lunch hour. Thank you, Dr. Shilvas Kulkarni.
I call Dr. Arun sir to felicitate. Now, there is just 15 minutes break up for lunch. After that, we start the panel discussion. Whoever has not done lunch, please go and have it. After that, we will have panel discussion and one last lecture. Then we go to workshop.
No, no issue. I think after that, otherwise I'm under your care today. Sorry, it's not one book before I forget. Then I will come. No, it is the working from conference. One extra copy for the department library they have got. Extra copy for the department and come. Copy for the library. Very good. Thank you for all of it. ಮೊದಲೇ ಹೇಳ್ಬಿಡ್ತೀನಿ ಯಾಕಂದ್ರೆ ನಂಗೆ ಆಮೇಲೆ ಗಡ್ಬಡಿಯಲ್ಲಿ ಹೋಗ್ಬೇಕು ನಾನು ಅದಕ್ಕೆ ಎಲ್ಲ ಮುಗಿಸಿ ಬನ್ನಿ Actually, all the topics are very good and excellent.
ನೀವೆಲ್ಲ ಬಂದಿದ್ದಕ್ಕೆ ಆಗಿರೋದು ಸ್ಪೀಕರ್ಸ್ ಫಸ್ಟ್ ನೀವು ಹೇಳಿದ ತಕ್ಷಣ ಒಬ್ಬರೆಲ್ಲ ಬಹಳ ಖುಷಿ ಆಯ್ತು ನನಗೆ.
ಅದು ಮಾಡೋ ಹಿಂಗ್ ಮಾಡೋ
ಬೆಳಿಗ್ಗೆ ಸ್ವಲ್ಪ ಕಡಿಮೆ ಬಿಕಾಸ್ ಆಫ್ ದಿ ಕೋಲ್ಡ್.
Last time Mangalore when I gave to panel, 3 students were there. Mangalore, only 3. But we always remember yesterday university is one because it will spread. So never get disheartened. Sometimes I did my first lecture in my group. And the second one I did in a TV. Difference of one. Now, not so, all of you my school was full. What disheartening. Then I remember you until never get disheartened because your task can come in the last, beginning, it can come in the in between, but it should never come. Because these are all learning for us. And I felt I learned organization. Do not give everybody a very favorite convenient time. So now it is like playing for a cricket team. Sometimes you may be the opener. You may not, your turn may not. Sometimes you may be an expert player. You may not get a chance. So you should not script for it. There is a script matter. In the India, how do your is also very important function. Because if you put on your goal, not like this. You should be flexible. Never put your go around. It's all out of my experience and knowledge. I never knew all these things. I was never into it. And see, when I knew, it's not that it's good. Sometimes it's just not your day. No, sometimes I will tell you, you will have given an excellent talk. I'm getting a lot of trouble. But sometimes it just goes by. Something happens. But you know, how to take it to one talk I was happy to tell you. But I thought this would upset me. I said, okay, sir, I didn't go to Arjun. Then I'm getting quick. That was his become. That can happen. One more thing is, never you are writing just to cover it. Problems can come to you. It's not about my our teachers say class. Nada, but he talks in fellow you could be talking. He people will because physical topic. He had a topic. Last thing, I'm confident I will take my share. My son was making a joke, mommy, emergency medicine. Emergency medicine support
You could catch a running toy probably. Maximum we should not have 0 o'clock.
3:50 not. 3:50
Is the last target.
No working in you on the way. ಸಿಕ್ತು ಇದೆ ಇತ್ತು ಇಲ್ಲೇ ಇತ್ತು ಇದು ಕೆಳಗಿತ್ತು ಬಿಕಾಸ್ ಆಫ್ ದಿಸ್ ಇದು ಹಿಂಗೆ ಕವರ್ಡ್ ಇತ್ತಲ್ಲ ಇನ್ನ ಗೊತ್ತಾಗ್ತಾ ಇಲ್ಲ ನಾನು ಕಾರ್ಡ್ ಬುಕ್ ನೋಡ್ತೀನಿ ಇನ್ನ ಪ್ಲಾಸ್ಟಿಕ್ ಬಂದು ಕಾರ್ಡಿನ ಜರುಗುತ್ತೆ ಲೆವೆಲ್ ನೈಟ್ ಸೇಲ್ ಆಗುತ್ತೆ this is in my handbag ಇದೆ ಇಲ್ಲ ಒಂದೊಂದು ಪ್ಲೇಸ್ ಏನು I know organization ಆರೂವರೆ ತಕ್ಕ ಮಾಡ್ಕೊಂಡು ಕೂತಿದ್ದೀನಿ because once in a while we do nursing it cannot be too strict ಗಂಟೆ ಅದೆಲ್ಲ we do activity conference ಮಾಡ್ತೀವಿ and the people will also not come every and then I finished my solution. Now the solution is BiPAP तो सही है हाँ हाँ ಒಂದು ಇಂಟ್ರೊಡಕ್ಷನ್ ಇದೆ ಆಮೇಲೆ ಇನ್ನೊಬ್ರು ಬಂದಿದ್ದಾರ ಅದಕ್ಕೆ ಡಿವೈಡ್ ಮಾಡ್ಕೊಂಡು ರಾಜೇಶ್ ಸಂತೋಷ್ ಅವ್ರಿಗೆ ಒಂದು ಫೋನ್ ಮಾಡ್ತಿದ್ರು ಆಯ್ತು ಡಾಕ್ಟರ್ ಉದಯ್ ಬಂದಿಲ್ಲಲ್ಲ ಹೌದೌದು ಕಬಡ್ಡಿ ಸೈಡ್ಗೆ ಕಮ್ಮಿ ಅಂತ ಮತ್ತೆ ಫೋನ್ ಬಂದಿತ್ತಂತೆ ಪಕ್ಕ ಬಂದಿಲ್ಲ यहाँ तक रियल में कंट्रोल और रियल कंट्रोल ಅವ್ರ ಜೊತೆ ಇದ್ದಾಗಲೇ ಅವರು ಏನು ಮಾಡ್ತಾರೆ Are you a member of ISV? Yes, ma'am. Okay, right. ISV and ISTCA. Emergency medicine in body. Okay, okay. Yeah, there is no limit to becoming a member. Why not become a member? Why not become? Always you have to be ventilators must be most of them you one bed almost to be in every level to open it. ಅದಕ್ಕೆ ನಮ್ಗೆ ಯಾವಾಗಲೂ ಫೋಟೋಗಳಲ್ಲಿ ಮಾಡಿ ಮನೆವಾಗಲೇ ಕಳಿಸಿ ಹಿಂದೆ ತಗೊಂಡು ಮಾಡ್ಬೋದು biggest panel discussion that they were on a higher medicine PPs ಇದೆ ಅವರು ಎಲ್ಲ Make an announcement there. They can come. They deserve to have them. One, two, three, four. All our timing is one day to ಒಂದು ಫೋಟೋ ತೆಕ್ಕೊಂಡ ಬಿಡೋ ಇವತ್ತು ಎಲ್ಲ ಗೊತ್ತಿಲ್ಲ ನಾನು ಗಡ್ಬಡೆ ಬಂದಿದ್ದೀನಿ in the background. Some good. Even if our college discussion is not good, the photo is good.
I request all the delegates to assemble here for the panel discussion. I invite Dr. Madhuri Krudi Madam to the stage for starting NIV panel discussion. I request all the panelists, Dr. Rajesh, Dr. Deepak, Dr. Santosh, Dr. Bhavya Madam. I introduce Dr. Madhuri Krudi. She is well known to all over India and international also. She is a professor, past HOD of Department of Anaesthesia, Karnataka Medical College and Research Institute, Hubli. Now she is editor of Chief Indian Journal of Anaesthesia since 2025 till 2028. She is associate editor, JOAP, CCP, associate editor for Practical Evidence of Anesthesia Knowledge, associate editor for Vapor, official newsletter of ISA National, associate editor of Indian Journal of Anesthesia 2022-2023, advanced course in medical education for 1 year, ISA IJA Best Peer Reviewer Award in 2016-17, ISA National Proficiency Award 2021, ISA President Appreciation National Award 2023, ISA Karnataka Eminent Anesthesia Teacher Award 2024. More are there. Publications are innumerous. International publications, international lecturers, national lecturers, so many things are there. It's a privilege to have her here. Give a big applause. Over to Madam. Thank you.
Thank you, sir, for that very sweet introduction. So it is a privilege for me to be in Tumkur here today to present this panel discussion on non-invasive ventilation. And I thank the organizing committee, especially Dr. Srinivas Kulkarni, for inviting me to present this session. So I have with me 4 esteemed panelists. Dr. Deepak, he is a specialist in emergency medicine. He is currently Associate Professor, Department of Emergency Medicine, Sridevi Institute of Medical Sciences and Research Hospital, Tumkur. He has done his MBBS from MS Ramaya College, Bangalore, and Diploma in Anesthesia from Mysore Medical College, and DNB in Emergency Medicine from Manipal Hospital, Bangalore. He has several achievements, having been awarded the President's Gold Medal for DNB in Emergency Medicine from the National Board of Examinations. and he has completed his IDCCM fellowship in critical care from ISCCM, and he has worked as a consultant in critical care at Ramaya Memorial Hospital. And I really welcome you, Dr. Deepak, to this session. We have another eminent panelist with us today, Dr. Rajesh. He is currently consultant emergency physician at Narayana Hrudayalaya, Bangalore. He has done his MD and DNB in emergency medicine. He is an American Heart Association certified instructor, both for basic life support and ACLS. He has done a certificate program in diabetes mellitus. And he has worked as assistant professor in JNMC Belgavi and STM Medical College, Dharwad. And has also worked as a senior resident in BMCRI, Bengaluru. It's really an honor to have you with us in this panel discussion. Welcome, sir. Then we have with us, slide please, the one more panelist, Dr. Santosh. He is a specialist in emergency medicine and critical care. He has done his fellowship in critical care medicine from Critical Care Education Foundation, Mumbai. He has done his DNB in emergency medicine. He is a certified instructor for comprehensive emergency care and life support. He is a certified instructor for basic cardiac life support and emergency nursing life support, and certified instructor for STEMI workshops. Welcome, sir. Welcome to the panel discussion.
Thank you, madam.
We have Dr. Bhavya Shivalingaya, a consultant pulmonologist and associate professor. She is one of the consultants owning the SJ, the Lung Care Bangalore, which is a very, which is an institute which which manages only lung cases. So that's very unique. And she has done her European diploma in respiratory medicine from United Kingdom. She has done her IDCCM, MD and DNB in respiratory medicine. And as I said, she's the founder and managing director of this SJ, the Lung Care. She has worked as Associate Professor, Department of Respiratory Medicine, Postgraduate Guide for 3 MD students and 1 PhD Pharmacology student. And she's an active member of ICCM and European Respiratory Society. She has multiple peer-reviewed publications in areas including sleep medicine. Yes, I'm very interested in sleep medicine. So, and COVID-19. So with this introduction, let us move on to the topic. So the topic for today is non-invasive ventilation. And as I was discussing with everybody today, non-invasive ventilation is said to be, one of the main weapons or astras of the emergency physician. So as soon as the patient comes with respiratory distress to the emergency medicine or casualty, I think the first thing that you people have in to battle it out is the non-invasive ventilation. So a few things have been spoken about this topic in the previous sessions, but this topic is solely on non-invasive ventilation. So we'll go on to some of the simpler aspects of non-invasive ventilation also, in addition to the advanced aspects, depending upon how much ever we are able to cover in the whatever time is allotted to us. So first of all, what is non-invasive ventilation? We hear this terminology very often, but what exactly do you mean by non-invasive ventilation? Can anybody tell from the audience, any of the postgraduates? Don't get scared. This session is yours. Fast, because I don't have time. As the word suggests, non-invasive means the provision of ventilatory support through the upper airway using a mask or similar device, but it should not be an endotracheal tube or a supraglottic airway device or a tracheostomy. It should be none of these, but you should be providing ventilatory support through the upper airway. It also means the mechanical ventilation without the use of an invasive artificial airway. That is what is the meaning of non-invasive ventilation. Now, what about the physiology of non-invasive ventilation? Is it the same as invasive ventilation, or is it different from non-invasive ventilation? So, Dr. Rajesh, can you enlighten us on this?
basic physiology of non-invasive ventilation is similar to the invasive ventilation. It's mainly is to provide positive pressure ventilation, which means the air is pushed to lungs with the help of ventilator and face mask through upper airway tract. Thereby, it decreases the work of breathing, and it also increases the functional residual capacity, and also it increases the alveolar recruitment, and thereby it will increases the adequate gas exchange. When coming to basic mechanics like initiation, trigger, and limit of a ventilator parameters, now in non-invasive ventilation, the initiation is by patient and limited by PEEP set at pressure value, and it is mostly cycled by patient breathing effort only. Unlike in invasive ventilation, where all three parameters can be controlled with help of a ventilator only.
Yes, rightly said. So that is how you can, there are some differences between invasive and non-invasive ventilation, but more or less the physiology is nearly the same. So what are the goals of non-invasive ventilation? Why, what would be our primary goal when you put a patient on non-invasive ventilation? Dr. Santosh?
Yes, madam. Especially while looking at the goals of non-invasive ventilation, especially we in emergencies, we'll see lot of patients with acute distress, acute respiratory distress. So acute goals, let me short-term goals when you look at, so to give the patient comfort first. So patient will be breathing and they will be having shortness of breath, use of accessory muscles, everything will be there. So for that, we have to give them, decrease the work of breathing and then give the comfort first. Then we'll look at the improvising the oxygenation and decreasing the CO2 levels. Then we'll give the minimizing the risk of of progressing it to further respiratory failure. And one more very important thing is to prevent endotracheal intubation. See, and that endotracheal intubation and post-intubation management, it has its own pros and cons. So with the proper use of NIV, we can actually avoid the risk of endotracheal intubation. And we have seen many cases with OHA, with obesity hyperventilation syndrome and chronic obstructive diseases. For such cases, with the use of proper NIV and intermittent NIV, at home-based NIV also, we can improve the quality of life, improve the quality of sleep also, and then prolonging the survival of the patients is also that is possible with the proper use of NIV. Those are long-term, yes, long-term goals, yes.
Now the next question to Dr. Deepak. The next question to Dr. Deepak.
Yes, ma'am.
What are the types of non-invasive ventilation? Are there any types or categories, or it is just non-invasive ventilation?
Okay, when we talk about the types of non-invasive ventilation, we should understand the history, how this the ventilation, how it began. Probably in the 1800s, there was a concept. Many patients, I mean, if they had any respiratory fatigue or any respiratory issues, so then they never used to get ventilated. So there was no concept of ventilation. So probably around 1800s, they thought, okay, we can assess the patient with some sort of normal physiology of respiration. So by 1940s, 1950s, so they developed, I mean, the researchers developed, there was something called as iron lung. So iron lung, so which was negative pressure ventilation. They used to put the patient thorax inside an iron lung, and then they used to use a vacuum so that it used to expand the chest. So thereby the patient would inhale the air, and then by giving some compression, the exhalation used to occur. So they tried to mimic the negative pressure ventilation. So this is one of the way of one of the type of ventilation, that is non-invasive negative pressure ventilation. What we use nowadays is non-invasive positive pressure ventilation. What we see nowadays with using our ventilators is it is positive pressure ventilation. So we are altering the patient's normal physiology. We are giving pressure from outside so that the patient's respiration is supported. So those are the two types of non-invasive negative pressure and non-invasive positive pressure ventilation. There is one more concept which was used very much in the late probably last 4 or 5 years back during the COVID pandemic. So the use of HFNO. HFNO is also one of the way of non-invasive ventilation. But as per definition, what we have learned is minimally invasive or non-invasive is using a mask or any other interface. But in HFNO, we use a nasal cannula. Again, that invades the the human body. So that is minimally invasive. So these are the three types of non-invasive ventilation. Yes, madam.
Yeah, you can see here in the slide, the nasal cannula, which sir was talking about, the heated inspiratory circuit, the active humidifier, the air oxygen blender, and the flow meter, which are a part of the HFNO equipment. I think if any of you have used it, you will be familiar with this. Right, sir? Okay. So now, having known what are the types of non-invasive ventilation, Dr. Bhavya, can you tell us what are the devices that you need for non-invasive ventilation?
Okay, here looking at the devices, I would like to divide into three different parts. And we being respiratory physician, we use lot of portable ventilators compared to the conventional ventilators. Conventional ventilators. The portable ventilators are better than conventional ventilators, and we have only very less option to change the settings, maybe spontaneous or timed. And few advanced portable ventilators have some volume and pressure setting also in that. So second part is conventional ventilators. We all know about it, which has been talked since morning. Coming to the circuits, this portable circulator is usually single limb. I mean, I'm just talking about what we commonly use in our practice. Portable one will have only single limb, it is an inspiratory limb. And our conventional ventilators will have dual limb. You can see here dual limb. One is for inspiration and one is for expiration. So we should be very careful which limb we use for the ventilators, whether it's portable or it is conventional ventilators. Again, the mask, I mean the facial interfaces. Here we have 5 to 6 kind of the facial oronasal, which covers both nose and face, nose and mouth. And we prefer using this oronasal one because the patient who comes in the emergency settings will be mouth breathers often because they'll have the distress. So oronasal mask is always preferable. But for the long term, nasal mask can also be used. And here again the difference is people doesn't I often see them missing between the oronasal mask of this conventional ventilator and portable ventilator. They are different. As I said, conventional ventilator will have expiratory limb, so the mask will not have any vent for the carbon dioxide to go out. The portable ventilator have the mask which has a vent for the expiration. So whenever you are connecting the patient, you should make sure you use the right mask to the patient. The vented one for portable, non-vented for conventional, single limb circuit for the portable, and dual limb for the conventional ventilators. And these are the most common devices we use along with the monitors and oxygen and all, which are the additives.
Can you tell us something about the CPAP helmet? Because I heard that
This is not commonly used.
It's not
ma'am.
used
Commonly
much.
used is nasal, oral. Even the oral one is not used. Full face mask is also not used as of now. Not frequently used.
Okay.
Yes, ma'am.
Okay. So I think the interface is very important. That is the interface, the device that connects the ventilator tubing to the face. That is very important, and we'll come on to that later on, why it is so important for the success of non-invasive ventilation. So now, I think you've also told about the hybrid ventilators, right? What are hybrid? Is there anything called as hybrid
Is
ventilators?
like the portable one, portable ventilator, which has a more smarter than the regular portable ventilator, which has the pressure support and volume control mode also in that. But again, saying that it is not as smart as conventional ventilators. People who are on long-term ventilator support, whom we have to step down or send them to the lower ICU, there we can use this hybrid ventilators.
Okay, so that is, we are actually discussing the ventilatory modes. So Dr. Santosh, Dr. Deepak, can you tell us what are the ventilatory modes that we can use for
Okay, madam.
non-invasive ventilation?
Yeah, there are various modes. Obviously, the patient, depending on the patient's condition, we have to use ventilator smartly. So there are various modes. It depends on, again, I mean, uh, uh, globally, what we use are certain modes, but certain companies give certain, they have their patent of certain modes. Most of the mode, this one, the, uh, it is very common to the global the modes that we use. So most of the common modes that we use are CPAP, pressure support ventilation. There is a BiPAP, and there is a concept of AVAPs or IVAPs. So what is this CPAP, continuous positive airway pressure? Here in this mode, there is a continuous pressure that is given from the ventilator to the patient. So it doesn't depend on the inspiration or expiration of the patient. So during the entire process of respiratory cycle, the patient receives a constant pressure. Whereas in biphasic or bi-level positive airway pressure, there are two pressure set points: inspiratory positive airway pressure and an expiratory positive airway pressure. So these two difference, I mean, in between whatever IPAP minus the EPAP, that is what is the constant pressure, just like CPAP. So in between those two pressures is the continuous positive pressure. But there is a pressure that is given through the IPAP. This IPAP, what it helps is, it helps it patient's ventilatory support. It helps the patient's respiratory fatigue, it will come down. And this EPAP, expiratory positive air pressure, it keeps the alveoli recruited. So that these patients, especially a patient with COPD, this mode helps. So that both the patient will have ventilatory failure and an oxygenation failure. So in such patients, this mode would help. So there is one more mode that I was talking about. Nowadays, we all talk about artificial intelligence and this one. So even the BiPAP machines that are available nowadays are using the intelligent modes, wherein the sensors in the BiPAP machines will, I mean, the NIV machines will sense the patient's respiratory efforts, the volume, the rate. Is the patient going to sleep, or is the patient going to apnea? So the machine itself triggers the breaths and triggers the volume, and it controls the pressures. It will not be constant. In BiPAP or CPAP, we can put the patient under certain pressure supports. But in AVAPs, we can control minimum this amount of pressure has to be given. It will sense if there is any leak, it will increase the pressure, and if there is any respiratory fatigue, it will increase the pressure. So likewise, so that is called as average volume assisted pressure support, or intelligent volume assisted pressure support. Volume assured pressure support. So this mode helps certain volume that has to be given to a patient. So these are the basic modes. And there are, as I said, certain companies have their own patented modes. So all of them will work almost similar on similar lines.
Okay. So you have to be smart enough to select the mode, right? Which mode to use. And that depends upon your experience also. Okay. So, Dr. Rajesh, this non-invasive ventilation, where can we use, in which setups? Can we use it in the OT, in the ICU, or in the emergency medicine department, ward? Where to use, like?
Actually, this the endotracheal intubation, as an emergency physician, we try to avoid the endotracheal intubation as much as possible. So the use start from emergency medicine department, and also mainly in ICU also, and it can also used in a ward also. And some of these devices now it came as like portable devices. It can be used in home care setting also. Some of rehabilitation centers also it can use. And majority these patients are sleep apnea patients, so they can be used in home care.
Yeah. And I think, because in the emergency medicine department, if you have a qualified emergency physician sitting there to treat, fine, he will be good in intubation and all. But many of the hospitals, casualties, they still have only medical officers sitting there, and I don't know, in some institutes, the casualty will be full of patients. And sometimes the medical officer may not be good in intubation also. So in such a case, I feel non-invasive ventilation would be the best weapon, I mean the best tool to use in a patient with whatever respiratory distress, right? You agree with this? Yeah. So, Dr. Santosh, having discussed all these things about non-invasive ventilation, about the goals and the physiology and where to use and what to do, can you tell us how to select the patient for NIV? And in which cases would you not prefer to use non-invasive ventilation? Is it that it is so rosy that you can use non-invasive ventilation in any patient who comes in respiratory distress?
Exactly not, madam. We cannot use it for all the patients who are having dyspnea. So one thing is we'll use it for dyspnea, that is for sure. One mandatory criteria is a patient should be conscious, oriented, and he should be able to clear his own secretions, and he should be at least one dyspnea. Along with that, one relative contraindication is hemodynamical in unstable patient. We are not supposed to use it as a first line because some of the times patient might deteriorate also. And for a selection of patients, patient should be like a PF ratio of maybe less than 300 or 200, like that. Then increase with patients with increased work of breathing and like those kind of. When it comes to like proper diagnosis kind of words, I need to put with the strong evidence. NIV has better use in only COPD as well as acute cardiogenic pulmonary edema. And one more thing is immunocompromised states. Because for such immunocompromised patients, if we put on invasive mechanical ventilation, very difficult to win them off. So better to use them, use and put them on NIV trials only. But if there is real indication to intubate, definitely there is no option to do that. Then we're coming to the blood gases, we can definitely make use of arterial blood gases. If there is profound hypoxia, hypercarbia, then depending on the A gradient also, you can decide whether to intubate or whether to put them patient on NIV. And one thing is a patient should not be very sick. Patient should be patient should have some mild to moderate kind of breathlessness, not in severe respiratory distress. For such patients, we can put them on non-invasive ventilation.
That means you mean to say if there is life-threatening hypoxemia, then definitely it is a contraindication to non-invasive ventilation.
Exactly,
right?
ma'am.
Okay.
And coming to the contraindications, like one more thing, that impaired consciousness, that is an absolute indication to intubate the patient, not to put on NIV. So for such patients, we need to avoid NIV, directly go ahead with the endotracheal intubation. Just especially this, that is one trial we can give that for is CO2 narcosis patient. With the careful monitoring, so we can still give a trial of NIV, but I will prefer to go ahead with the endotracheal intubation only. But with the patient with the multiple facial faciomaxillary injuries, faciomaxillary edema, abdominal distension, bowel obstruction. For such patients, definitely we need to be very cautious and better not to put them on non-invasive ventilation if there is a real indication.
Yes. They're not able to swallow, not able to
Yes.
cough, impaired
Yes,
consciousness.
exactly.
All these, you should not try non-invasive ventilation.
Yes.
But I'm sure that during the COVID pandemic, all these contraindications none of us followed during the COVID pandemic. We were so scared of intubating, and we knew that intubation is not going to lead to anything good. So I think there were no selection criteria for non-invasive ventilation. Everybody was selected for non-invasive only, right? You must have had experiences, no?
Yeah, definitely. And during that times, endotracheal intubation, it was a like aggressive strategy whether to go invasive.
Yes, yes.
So, but we tried put them on non-invasive ventilation as long as possible, as long as patient tolerated NIV. Then, if there is a real indication, then
And
intubated.
so much of studies were getting published, and
Yes.
so much of literature was coming out almost every day, all contradicting literature, that we really didn't know what to do.
Yes, ma'am.
Okay, thank you. So, Dr. Bhavya, can you tell us that once you have selected the patient that you have to put non-invasive ventilation, what are the steps? How do you initiate non-invasive ventilation? You just put or you have to follow some steps?
Thing is like before starting NIV, we should make sure of three things. The first thing, whether all the monitors are there, the pulse waves are working there, oxygen connection is there, and the nursing staff, is she trained to handle that case? Make sure that it hardly takes few seconds. Second thing is, if at all that patient needs any intubation, then you should be confident about the intubation or inform the people or your seniors so that inform them this is a case maybe having obesity hypoventilation or severe obstructive sleep apnea or COPD which needs intubation and you need their help so that if they are not in the center they will have adequate time to reach the ICU. The third thing is your time. You have to sit with the patient and tell them what you are doing to them. You just put that mask on their face, no one will tolerate. Again, you will get call from nursing staff saying that the patient is not putting the NIV mask. So sit with them and tell them what is this mask, how it works, and how it benefits the patient. And what happens if he is not going to use the mask. And most of the patient will understand it. Okay, sit with them, take the mask near their face and ask them to feel the feel how it feels having the mask around their face on the machine with a lower pressure like 10 by 5 IPAP of 10 and EPAP of 5 and put it around their nose and mouth, but do not strap it. Let them feel it, let them breathe slowly. Once they are okay, then touch this mask over their face and again ask them to breathe slowly and not to coordinate with the machine. Many of the patient will start breathing according to the machine. They'll try to take the inspiration with the machine and breathe out through expire with the machine. There they will have the problem. So convince them to take their own breath so that machine will start listening to them. So these are all things to make them comfort so that they can use the NIV mask. After doing like this of 2 to 3 minutes, you can strap them initially loosely, snugly fit, and later you can tighten it. And just sitting next to them for 5 to 6 minutes will help them to have this mask. After this, you would have started with 10 by 5 and patient is tolerating well. Slowly you can increase to 12, 5, depending on what case it is. If it is COPD, we keep on increasing the IPAP to wash out the carbon dioxide. And if it is like restrictive lung disease or there is an hypoxia, then EPAP is the one which is we increase. So initial 5 to 15 minutes, from 10 we can increase to 12, 14 if patient is tolerating well. In this 15 minutes, if vital parameters are doing good, so you can assess every 15-20 minutes and keep on increase the pressure to the maximum level needed. So in portable BiPAP, we can go up to 18 to 20, and on conventional ventilators, sometimes we can go up to 30, but usually we end up putting it around 16 to 24. So all that need is to talk with the patient, that needs your time. So later, after 1 hour, we have to repeat the ABG and see whether your thing is successful or partially successful or failure. So that next you can take the call.
And what about sedation? Do you need to sedate the patient?
Usually no. If you sit and talk to them, they will get to know. For especially the carbon dioxide narcosis or respiratory failure cases, we don't. Some paper says use mild sedation, but most of our practice we don't use any IV sedations.
Okay.
Until unless they are very restless or running out of the bed, we don't.
So encouragement, reassurance, these are the most important,
Correct.
right?
Just tell them like you are doing well from the time them to now. Yeah, I have achieved. I'm happy with you. All those things will encourage them and make them use that mask.
Yes, because they are conscious, they are able to you are able to talk to them and they can understand what you're telling. And you have to also keep checking for air leaks, add humidifier, it is very important, right? Okay, and keep checking the straps, readjusting the straps as needed. So the next question, that what are the how can you predict the success of non-invasive ventilation? Dr. Deepak, can you tell us? How can you predict the success? Ki in this particular patient, my non-invasive ventilation is going to be successful. Can you tell that, Dr. Rajesh?
Success mainly depend on the patient selection initially, and also the equipment preparation and how to monitor the patient. Patient selected should be patient cooperative, conscious, and it should be synchronized with ventilation efforts with NIV machine. And in coming to lab parameters like ABG parameters, like pH should be somewhere around more than 7.25 to 35 is the ideal patient. And also there should not be hypercapnia should be more than 60 to somewhere around 90. In clinical experience, most of my patients who had a like chronic COPD patient, you can take a patient of advantage like CO2 range more than 80 to somewhere 90, 95 also. But patient with the acute conditions with the CO2 retention, some of like poisoning or patients, better to put them early with invasive ventilation.
Yeah, so the criteria for the success and for the risk and failure of non-invasive ventilation, they include this PaO2 FiO2 ratio less than 150 at baseline and up to 1 hour after initiation of NIV. That indicates that it is going to be a failure, right? And tidal volume more than 9 ml per kg of predicted body weight at 1 hour, and higher SAPS 2 score, SOFA score, Apache 2 score. Patients with community acquired pneumonia, ARDS, immunosuppression, and there is something called as the HACOR score. So who can tell me about the HACOR score? Can anybody of you enlighten us on the HACOR score?
HACOR score is a very good score, madam. It is non-invasive and we can use it as repeatedly as possible, especially while monitoring the patient on NIV. So H stands for heart rate. So heart rate, we have scores like less than 120, more than 120, like that. pH again more than 7.35, like ranging from 7.35 to less than 7.25. Then GCS scores and then PF ratio as well as respiratory rate also we can take into account. And with that we can give a proper scoring. And then especially if the HACOR score more than 5 after 1.5 hours of giving an NIV trial, that has a very high risk of NIV failure. So HACOR score should be lesser as possible for the patient to get success of NIV.
So we can apply this HACOR score clinically.
Clinically, and that is non-invasive. We can use it as repeatedly as possible.
Okay. So what are the complications and side effects of non-invasive ventilation? Would any of you like to take up on this, or shall I discuss? Yeah. Yeah.
No much complications associated with the non-invasive ventilation unless the patient goes drowsy and we are not monitoring him, or if he vomits, he may aspirate. Sometimes we cannot say complication, they will have nasal bridge ulcers. If we strap them properly or if we give some pressure support around the nose, this small complication can be stopped. As of major complication, we have not noticed till now.
Yeah, I think nasal, oral dryness, especially if you do not humidify, give humidified gases, and gastric insufflation. You want to add something?
Yeah, pneumothorax is a major complication. We should be very careful, especially when using in a patient with trauma, chest trauma, who present to the emergency so regularly. So it's always a major complication that if we ignore, possibility of it causing mortality would be high. So that is an important complication we should be very careful about.
Yeah. Now, with every device, if you need to be successful, you also need, like the main hero in a movie, you need side heroes also and villains, right? So are there any adjuncts needed to improve your success of non-invasive ventilation?
Yeah, definitely. Just now we were talking about the dryness of airway. Here in NIV, there is lot of high pressure and high flow also. This air overwhelms the capacity of our nasal and respiratory system. So there will be a lot of dryness. And there will be, because of this dryness, even they cannot clear their mucus secretion, mucus plugging will be there. So it's always better to humidify the air. In portable ventilator, we always have, we can put in a compartment, we can put the water there. And in conventional, we have this HME filter. Along with that, we can also use the saline nasal spray to their nose so that they'll have comfort while using this NIV mask. The most common complication, as we were discussing, is the nasal bridge ulcer. Because of the pressure and the pain, they won't use the NIV mask. So we are doing a study in our center. Surgeons uses this hydrophobe gel. They use for their dressing of the wound, and it's very soft silicone-like structure which we can cut and put like a bandage around their nose, And if you put the NIV around the nose, this nasal bridge ulcers can be prevented nearly 100%, and the patient compliance is also well. So it acts as an adjunct for the compliance, increase in the compliance of this NIV. Along with this, oxygen helps. Then the good facial interface. If they are not tolerating the oronasal mask, we can give just the nasal mask, or talking to them. All these
Okay.
are can be the adjuncts to improve
Okay.
this thing.
So can any breaks be given during non-invasive ventilation? Any breaks, Dr. Deepak?
See, any patient who's been put on NIV, so obviously the patient would be very sick. So that is when we start on non-invasive ventilation. We cannot immediately start giving breaks. So depend on the subset of patients. Like if the patient comes with acute pulmonary edema, cardiogenic. So these patients do respond to non-invasive ventilation very quickly. Within half an hour to 1 hour, we have seen results that obviously with the use of other measures along with non-invasive ventilation, the patients clinically improve. In such patients, we can definitely start giving break within about 1 to 2 hours. But in patients with COPD, because there will be dynamic changes in the lungs and the airways, so these patients do not respond so quickly. They take time. So we need to give a lot of bronchodilatations and other measures. But these patients, we cannot limit their nutrition. We cannot limit, I mean, if there is any secretion, we cannot, if the patient is on continuous NIV, we cannot take off the secretions. So for all these purposes, we have to give breaks, which is to begin with probably 5 to 10 minutes, and then later on increase the frequency of breaks or the time duration of breaks for up to about 2 hours. So in patients who are recovering, definitely yes, break can be given. But if the patient is acutely distressed and is not responding so well with NIV, the patient as well may go for an endotracheal intubation and invasive ventilation.
Okay, sir. So we need to monitor the patient also who is on NIV. So monitoring you can do with subjective responses like bedside observation, look for signs of respiratory distress, see if the patient is fatigued, see if he is getting sedated. These are all bad signs. Your NIV is not working. Then you see the physiological responses, whether the respiratory rate is coming down, whether the activity of the sternocleidomastoid is coming down, see whether there is a decrease in the abdominal paradox, decrease in the heart rate. Okay. Then air leak, patient ventilator asynchrony, you should look for. See the tidal volume. Observe the readings on the pulse oximeter, intermittent ABG, as madam has already told, and end tidal CO2 monitoring. All these are very important for the monitoring. Now, the last question, how do you wean the patient from non-invasive positive pressure ventilation? Dr. Santosh, can you just tell very brief?
Especially when it comes to weaning in acute conditions, and in emergency as well as in ICUs, we can do like sudden weaning off and then gradual weaning off. So in both the conditions where we can wean them off, these are common criteria, like respiratory rate should come down, which should be less than 24, heart rate should come down, it should be less than 110 or 120, like that. Then saturation should improve, should be more than 92 or 94. Then the pH should have been improved. Especially if the pH is less than 7.35, whether it is metabolic or respiratory, we have worsen outcomes. So it should be, pH should be at least more than 7.35. So these are the things. And then patient, before weaning off, we should ask for the readiness of weaning. Patient should be talked, and even they might not be able to talk to you and they might not be able to respond to you. At least let them become conscious oriented as well. At least they have to listen what we are talking to them. Yes. That is readiness. Assessing for the readiness of weaning is very important. And weaning should, especially for weaning, how can we try, like if it is a ventilation problem, we can keeping the EPAP constant, we can come down on the IPAP levels, especially 2, 4, like if it is 10 IPAP is there, we can come down on 8, 6, like that. If it is oxygenation problem like cardiogenic pulmonary edema, like immunocompromised states or cystic fibrosis, whatever the conditions is, we can slowly come down on the EPAP and titrate according to the saturation that is required for the patient.
So gradually you have to step down.
Yes.
Okay. So to conclude, non-invasive ventilation avoids the complications of invasive mechanical ventilation. acute cardiogenic pulmonary edema, and acute exacerbation of COPD. These are the cases which benefit most with non-invasive ventilation. And non-invasive ventilation should always be offered in a controlled environment with intense monitoring to reduce the risk of failure of non-invasive ventilation. And you should do it in facility where prompt tracheal intubation is also possible. And the mode of NIV should be personalized. As we have already discussed, it should be customized based on the clinical presentation of the patient and whatever modes are available to you. So thank you very much. Thank you to all the esteemed panelists and all the delegates for a very patient hearing. Thank you.
Thank you, Dr. Srinivas Kulkarni, sir, and Department of Emergency Medicine, Siddhartha Medical College, for giving me the opportunity for being the panelist.
Thank you. Thank you so much, ma'am. Now I would like to call upon Dr. Sahana, ma'am, to felicitate Dr. Madhuri Kurdi, ma'am. Next, I would like to call upon Dr. Srinivas Kulkarni, sir, to felicitate Dr. Bhavya, ma'am. Next, I would like to call upon Dr. Santosh Ujjainappa, sir, to felicitate Dr. Santosh, sir. Next, I would like to call upon Dr. Ganesh, sir, to felicitate Dr. Deepak, sir. Next, I would like to call upon Dr. Next, I would like to call upon Dr. Girish, sir, to felicitate Dr. Rajesh, sir. As we come to the last session of the day, this session focuses on one of the most critical transitions in patient's care, weaning from the mechanical ventilator. Understanding when and how to initiate the weaning process is key to reducing complication and improving recovery outcomes. I would like to invite the speaker for the session, Dr. Girish Narayan sir, Professor, Department of Emergency Medicine, St. John's Medical College, Bengaluru. I would also request Dr. Madhu Srinivasa Rangan sir, Professor, Department of Emergency Medicine, JSS Medical College, Mysuru, to chair this session. Dr. Madhu sir completed his MBBS from JSS Medical College, Mysuru, and DNB General Surgery from Bangalore Baptist Hospital. He is a visiting faculty at Administrative Training Institute, Mysuru, teaching a module on role of hospitals in disaster management for districts and state level administrative officers of the state government. He is one of the eminent faculty for the All India Institute of Medical Science and WHO course on strengthening emergency care in primary healthcare setting. He is an instructor at AIMS Advanced Ultrasound Trauma Life Support and an instructor for Advanced Trauma Life Support and Basic and Advanced Cardiac Life Support. We welcome you, sir, and we request you to give a brief introduction about the speaker.
Good afternoon, everyone. Should we are considering the aspect of weaning in the emergency department? We initiate ventilation. Is weaning essential? Is something that we have to look at. These are concepts and ideas that we hope Dr. Girish will tell us about in detail. He comes from St. John's Medical College in Bangalore, which is unarguably one of the longest serving emergency departments in the country. So short-term ventilation and the possibility of consideration weaning, I think we will look forward to what Girish adds to this. Thank you, Dr. Girish.
So, good afternoon. I know the last talk is everyone is looking forward for the workshop, so I'll make it quick and simple. So, weaning from a ventilator, everybody thinks it's damn cool to put the tube in, but it's harder to take the tube out. Okay, so whenever you're planning extubation, it's actually a liberation. The liberation is for the patient. The various things that I'll cover are a spontaneous breathing trial, non-invasive ventilation. We'll talk a little about HFNC and some examples. And before I start, I'll give a disclaimer. I work in the ED. I usually don't have a lot of experience extubating patients. Okay. We run a short 8-bedded short stay EICU where I don't take the more advanced cases. I think that's better with my critical care colleagues. And usually after we give them a nice VAP and cardiogenic shock, then we shift them off under them. And then they curse us a bit. That's the usual program. It's not our focus. So weaning is not, I can't say the weaning that I'll be talking about is the more advanced cases. It'll be a few more simple cases. Short-term weaning, but a few of the fundamentals will be covered. Okay. So I'm an emergency physician, not a full-time critical care guy. I have to say that in the beginning. So why do we say liberation? So this refers to a process of weaning and extubation and includes efforts made by clinicians to ultimately improve the patient situation, and they should not even be on NIV. Okay, a patient doesn't like any of this. Having a tube in their throat or on their face, nobody likes it. Okay, so it's a total liberation for the patient, and it is a process. So what are we going to cover? Identify if recovery has been there, maybe a daily spontaneous breathing trial, conduct the daily SBT, assess extubation readiness, and then plan for the extubation. Basic steps. So what's a spontaneous breathing trial and everything? I'll come to later. So what is the pathway? Like you can see in the picture here, initially, are we ready to wean? Are they breathing adequately? And get ready and extubate. So we'll go through each of these a little bit more detail, but fundamentally is whatever is the reason that we intubated them, is that better? Next question is, are they going to breathe enough? So the big question is, anybody can breathe on a ventilator. Once they're off the ventilator, will they continue to breathe? That's the challenge. So usually when I speak to a patient's family and I tell them we're getting them off the ventilator, the example I like to give them is when you're teaching a child to walk, you hold their hand for some time. And eventually you let go and see if they can take a few steps. So when you take them off the ventilator, you're not holding their hand anymore. And that's why it's very challenging, the weaning process. It's one thing to put a ventilator on a patient, but to try and take them off the ventilator and then go and say, okay, we didn't time this, or you're not doing it properly, we need to put it back in. It's a horrible feeling for the patient, the doctor, the family, and everyone. Even the nurses get quite depressed. Oh, why are you reintubating, sir? What did we do wrong? So it's a tough situation for everybody. So there's a big process to it. So what's the criteria when you're going to wean a patient? So first thing is, whatever reason that you put on the ventilator, has that gotten better? Whether it's asthma, heart failure, or post-op trauma, all those situations, are they better? So if it's a post-surgical patient, make sure that situation has been solved. So frequently we have trauma patients where the surgeons will rush to the OT. They'll have some component of shock and respiratory failure because of that. And then once they come back, we have to make sure that is fully resolved. To get your surgical colleagues on board that you're extubating, whatever the situation is. Now, obviously, if it's a medical cause, make sure that will not reverse once you extubate the patient. PaO2 by FiO2 is a common parameter we say. Some people say above 150 is enough. Some say less. You can also just use saturation as a trick and make sure that the patient is on a lower FiO2 and the PEEP is low. pH should be normal. Normal pH should be there, and they should have a trigger. Okay, if they're not breathing, you can't extubate, obviously. So additional criteria is the hemoglobin above 7. Does the patient follow commands? Are they responding to you? Hemodynamic stability, is it there? Very low or no pressures. So this is something that's debated a lot. Should you get them totally off pressures? So a small dose of pressures might actually help when you extubate a patient. So that's, you have to decide patient to patient. They should have minimal or very little secretions, and they should have a good cough reflex. Okay. So hemoglobin is very important, because if you don't have enough hemoglobin, what happens is you extubate the patient, lesser hemoglobin, lesser blood supply to the diaphragm, work of breathing increases, they get reintubated. So make sure that you have a good hemoglobin on the patient. Other things that you also have to look at is electrolytes. Make sure the potassium is okay. Sodium shouldn't be too low. And whenever we have a patient on a ventilator, one day before, we would have stopped feeding them. We'll want them NPO before we extubate. So we'll give them fluids. Make sure they're not fluid overloaded also. It's very sad, iatrogenic fluid overload, you extubate and then pulmonary edema. It's just something we should not miss. So daily spontaneous breathing trial, check if the cause is improving, what I told you. Is the oxygenation adequate? Hemodynamic stable? Minimal sedation and airway, they're able to protect their airway. Okay, so these are just a few of the fundamental things. Once you remove the tube, will they go back on the tube? Will they aspirate? These are the questions you have to ask. Okay. So there is a criteria. What is a spontaneous breathing trial criteria? Respiratory rate, these are some books recommended. This can fluctuate depending on the patient. Okay. So respiratory rate should be below 35. They should have a good tidal volume. There's an index called RSBI, I'll come to later. ABG or a venous blood gas, whatever you're using, should be stable, and they should have a good cough. So this is something that, when we're doing rounds in the ICU, we don't pay attention to it. The people who know the answer to these questions is the nurses. So it's very important to ask them, how is the patient? Are there a lot of secretions? Ask the same nurse, were you here yesterday? How was he yesterday? Having that understood is very important, because we're only seeing the patient twice or thrice a day. So this is a RSBI index, rapid shallow breathing index. Some authors recommend this because it's a objective way to assess the patient. So what they do is they take the respiratory rate divided by the tidal volume in liters, and if it's higher than 105, it's a decent indicator, that very highly sensitive, that their breathing index, their SBT is normal. Moderate specificity, it's not the sole determinant, but it gives, along with PF ratio, it's another number, takes into account a lot of values, and it gives you a decent number to work with. So if it's less than 105, it's predictive that the spontaneous breathing trial is going pretty well. So what are the techniques that you can do an SBT? You can do it on a T-piece, just CPAP on a low PEEP, you can do a pressure support ventilation, and it should be for a good 30 minutes to at least up to 2 hours. You don't want to do a spontaneous breathing trial too long, because that may tire the patient out as well. Just before you extubate, you want the patient breathing well, comfortable, so they have their best chance of maintaining once you've extubated them. So different trials are there. Should we do a pressure support breathing, spontaneous breathing trial, or TPs? Again, debatable. Pressure support lowers the work of breathing. They say it has a higher extubation success, but the trials are not comparable actually. And there's no difference in the number that get reintubated, but you can try either one, but individualized approach. Maybe with a COPD patient, a pressure support one would work better, but you have to decide patient to patient. So how long should you do the SBT trial? That's a spot. You take them off the vent, you've got them only on pressure support or CPAP or just the TPs. How long should you do it? 30 minutes up to 120 minutes. There's no difference in outcomes on which is better. Longer trials are not beneficial in any way, and judge each patient. So sometimes if you look at a patient for 20 minutes, heart rate is not going up, no fluctuations in BP, they're breathing well, they're coughing adequately, you may know. But sometimes you might want to prolong it. So it's a patient-to-patient decision. And I really feel this is something we should keep our nurses involved in. That they will be judging the patient. They will tell you 45 minutes, he's getting tired. You're not going to be sitting there and watching. So keep them involved and they will tell you this is happening, that's happening. And that will help you guide your decision. So how do you optimize the patient before you do a breathing trial? Minimize sedation. Don't have them on sedation 5 minutes before you do the breathing trial. There should be a good window. Optimize analgesia that they don't have any pain. Make sure potassium electrolytes are okay. Like I said, fluid balance. Don't give too much fluid just before you do a breathing trial. You will extubate, remove the positive pressure ventilation and the PEEP, and suddenly the lungs are full of fluid and you'll be like, only then we'll go check the urine out. So checking the daily input output, the positive balance is a very important thing. My professor used to tell me what's the most important thing you should look at in the morning when you go see a patient, you should look at their catheter bag. If their catheter bag is okay, their heart is pumping well, that's because the kidneys are getting perfused. The kidneys are perfusing well and their lungs are not overloaded. So it's a good indication of 2-3 organs doing well. Use that well. Look how much you gave and how much were removed. So what are the various sedation protocols? So along with the breathing trial, you should do a sedation assessment every day. So make sure there's a window, you assess their sedation, turn off sedation, avoid using benzodiazepines. The one good thing is I'm not an anesthesiologist, and when I was doing PG, to understand the drugs that were there was quite complex, and it's not something we're used to. But today, the drugs that are there with dexmedetomidine, ketamine, fentanyl, handling a patient on ventilator is much easier. Keeping a patient on a small dose of dexmedetomidine keeps them calm. Okay, ketamine comes off very easily. Short-acting drugs are there. So there's a lot more that can be done with drugs today, and you have that flexibility to move from drug to drug. So use them well. Make sure they're off benzodiazepines. I hardly use benzodiazepines today unless it's a alcohol withdrawal patient or somebody like that. And always use a protocol. Everyone should know what's going on. It shouldn't be, I started this drug. Everyone in the ICU on that patient from the nurse should know what's going on, especially with sedation. So remember one thing, that after a period of ventilation, there is some amount of weakness that develops. Neuromuscular atrophy is inherent, that happens. There are ways to judge that. You use ultrasound and everything, but no technique has been proven that this works. Okay. And the fact that the patient has been sitting, laying down only in those positions, there is going to be some fatigue that's already there. And you have to keep them mobile. Physiotherapy has to be instituted early to keep the patient ready for their extubation. This is one test that some of us like doing just to make sure that there's no airway edema. You do a cuff leak. Basically, you deflate the cuff and see if there's any wheeze or any stridor, and that will tell you that they don't have any airway edema. So this is it's a good test, I think, and it's a bedside test. You just do it. The nurse checks it. Is there a cuff? Is there any audible stridor? And you know that once you extubate the patient, they're not going to have airway obstruction. So it's a decent test. And if you want, you can give a shot of steroid. But remember, once you give steroids, you have to wait at least 4 hours before you extubate the patient. So don't give steroid and then 5 minutes later go and extubate. Steroid takes 4 to 6 hours to act. So you have to give it some time. So non-invasive ventilation use. So this is the big thing now. Whenever you extubate a patient, should you use NIV? It's very popular now, NIV. It's cheaply available and patients do well. Supports COPD patients a lot. There's some sketchy evidence that it might help with BAP. And it is more comfortable than having a tube in their throat. So they've done a lot of trials on whether you directly extubate or take them to NIV and then get them, liberate them totally. And there are some advantages. We'll come to some of the evidence. So this was a study that was done in 2020, I think. Major study. This was actually a systematic review, and where they compared non-invasive ventilation with a direct extubation strategy. And they took 28 trials. So the numbers are here. I'll try to just explain. They took 2,000 patients. The one thing about all these trials is they were not very balanced, but put together they're a pretty big number. What they found was that when you used NIV, that means when you're planning to extubate the patient, you might do it a little earlier and take them straight to NIV. Keep them on NIV for some time and then get them off a ventilator totally. So mortality was much lower, 43% lower. Weaning failure is also 41% lower, and you can see that the confidence intervals are all well below 1. So that shows that it does have a significant effect. Pneumonia was also lower. ICU stay was, 5 days lower, but not a big variation, honestly. Hospital stay also, but that's not what we're looking for. But, mortality, weaning failure, pneumonia is lower. And the one thing that this study also showed, the systematic review showed, was that it was very effective in COPD patients. Obviously, we like using NIV for COPD. When we start with NIV, then go to invasive, why not get off with NIV? Is a common sense approach. And so with non-COPD patients, the evidence was sketchy. They said here and there because the patients were not grouped similarly. You can't apply the same standard for a stroke patient and a septic shock patient, is what they're saying. But COPD definitely helps. So NIV in non-COPD, what I was saying is, benefit is uncertain. You really have to select your patients and avoid overuse. And it requires a lot of experience, because what they found is whenever you had a COPD patient, they already knew how to be, cooperative with the NIV. You take a patient who's not been on NIV and then try them on NIV, it doesn't work well when you've extubated them. So this is what they found in their study. So the other thing is high flow nasal cannula. It delivers high volume oxygen, humidified, reduces dead space, very comfortable for patients. We used it quite a bit in the pandemic, you all remember. And this was another systematic review where they compared high flow nasal cannula with non-invasive ventilation for extubation. Okay, this is not for initial use. It's at use at the end of the story. This was done in 2020. The previous one was done in 2022, the systematic review. Here also they took 8 RCTs, 1,600 patients. And what they found here is that the reintubation possibility when used HFNC versus conventional oxygen was 50%, 54% lower. Post-extubation failure is also around 40%. No mortality benefit or reintubation versus NIV. So if you're looking at how many patients went back to the vent, it didn't help. But there was definitely respiratory failure, and reintubation was a little lower, but the reintubation was the same as NIV. Compared to conventional, it's better, but compared to NIV, more or less the same. So what they found at the end of this systematic review was that HFNC is better than just using normal oxygen, but between NIV and HFNC, can't say which is better. So the major obstacle about HFNC is the cost of the tubing. It's around 15,000, 20,000 rupees just to buy the tubings for the first time. But it has extraordinary patient comfort. We've used it on a couple of patients. We've been able to get them out of the ICU much faster to the ward. And they continue on HFNC, and they're happier that they're not on a ventilator. They're out of the ICU, and that itself does a lot for patient well-being. And it brings down the cost. Even though the upfront cost of 15,000 rupees is quite high, the ICU stay and everything comes down. So, like I said, reduces reintubation, helpful in high-risk patients, better comfort. Mortality doesn't change much, but this is not a rescue therapy. You can't use this. I extubated, oh, it didn't work, let's try HFNC. It should be planned. We're going to HFNC and then do it. Don't, let the extubation fail and then try. That doesn't show any benefit. So, which is better, NIV versus HFNC? COPD, definitely HFNC is better. General high risk, NIV is better, HFNC is better. We use it on quite a bit of pulmonary embolism patients, not the acute massive ones, the submassive minor ones. We like using it. The patient does much better whenever we're extubating them. And remember, when you're extubating the patient, the real challenge is what is the patient that you have. These are the patients that are a particular challenge. Elderly patients, longer than 7 days of ventilation, in heart failure. You will have them NPO. So whenever we're on a heart with a heart failure patient, we like to keep them oral, Ryle's tube feeding. And then when we stop the Ryle's tube feeding, we give them IV fluids, and then we overload them. They've already got a compromised heart. It's difficult. COPD, obviously, the risk is there. Once they're on the ventilator, will they become too dependent on the ventilator? And whenever you have a lot of secretions, airway clearance is poor, this is the big challenge that you will find when you're extubating a patient and you're trying to wean them. So again, coming back to, are we ready to wean? Is the patient breathing enough? And get ready and extubate. Assess the readiness of the patient. Is the patient truly, you have to predict this. Prepare a backup plan. If this happens, what do I do next? Discuss the goals of care with the patient's family and mitigate any risk factors. What are the challenges you will face? So whenever we extubate, I think a lot of intensivists try to operate. They try to extubate first thing in the morning so they have the whole day to watch. But today, a lot of people are asking questions. If the patient is ready at 6 o'clock, why don't you have a staffed ICU so you can do it? Okay, it's a logical argument. The patient has to stay overnight one more day just so I can come in the morning and extubate, becomes a little unfair. So this is something you have to balance and make a choice. And ICU beds are quite difficult to hold on to. So if you can extubate a patient and get them out, that's another benefit for the whole system. So can you predict extubation failure? If they have a poor cough, airway edema, lot of secretions, heart failure or hypercapnia, but then if they had any of this, you shouldn't have extubated first thing. Okay, so I think this is a redundant slide when you say predict extubation failure. If you have any of this, you shouldn't have been going for extubation. So what are the parameters of failure? Look, even though you may extubate, what are the things that will tell you that the patient is going bad? I've extubated. If their heart rate or respiratory rate goes up through the roof, obviously something has gone wrong. Extubation hasn't worked. Heart rate is unusually low. BP is very high. Don't only take BP going low, because when a person develops respiratory failure, adrenergic drive kicks in, their BP goes high. So even that is, a sign that maybe they couldn't tolerate being off the ventilator. They're not exchanging gases, the blood gases are looking bad, or they're unusually drowsy, or if they're even sweating. All of these are indicators after a 4 to 6 hour period that this patient didn't tolerate the extubation well. The subtle cues are obviously saturation going down, respiratory rate going up, but look for the subtle beyond the obvious. Bedside predictors are hand grip strength, head lift, command following, respiratory variability. These are things that you should look for. Patient is, following commands and things like that. Can a clinician predict accuracy of this patient will not have any problem, this patient will have a problem? This doesn't work. In my experience, I know this patient will tolerate. There is a protocol to follow the protocol. Nobody is that good to look at a patient and say, I'm going to get this patient off. I know, do it. So have a protocol, get everybody educated from the consultant to the resident to the nurse. Everyone should, if you have a respiratory therapist, bring everyone on board, protocol ticked, and then go and extubate. Plan is assign monitoring level, prepare for rapid reintubation if required, goals of care to be discussed with family in case this doesn't work, what happens, and decide on what's the support if it doesn't work. Before you extubate, again, I'd like to reiterate, treat heart failure, diurese fluid overload, manage delirium, reduce sedation, and optimize respiratory mechanics. So fluid overload is something that's very subtly missed. In the night, somebody would have rushed some fluid, something like that would have happened, and nobody would have looked at it in the morning. When not to extubate, again, unstable hemodynamics. If the patient has any arrhythmia, this is a particular challenge. If you have a patient on atrial fibrillation or anything like that, you control their heart rate. You extubate them, and that extubation itself elevates their heart rate a little. That can trigger another run of an arrhythmia. So you have to be prepared for this before you plan an extubation. Obviously, if there's more, if there's too much acidosis, poor mental status, or if you think that this patient won't maintain an airway. So this airway protection happens, I think, particularly when you get head trauma or in neurological patients. Their GCS is not great, but everything else is looking good. But your decision on extubation will come down, only to that GCS will this guy maintain his airway. That's a challenge at times. And remember, when you cannot extubate, and if you think this patient is going to go on for a long time, talk to the family and consider an early tracheostomy. This is a bit controversial, early versus late. There are a lot of hardcore intensivists saying you do a tracheostomy much faster, reduces the rates of VAP, and just do a trach and get them off the vent, because then you have airway protection. Anything goes wrong, you don't have the process of intubation. But this is highly controversial, very debated. I think sometimes it does work because you can get them off a patient. It's a challenge for the family on day 2 of being on the ventilator. I want to do a tracheostomy. But critical care physicians debate this back and forth. Fortunately, I've not had to take this decision a lot because I don't keep my patients for that long. I give it to my critical care colleagues and they usually handle it for me. So you have one situation of a one-way extubation. So this will happen where you take the decision, or the clinical team takes the decision with the family that we're going to extubate, and whatever happens, happens. So there's two causes. One thing, it's a DNR. Family says we don't want any further care. The other thing is where you extubate and you say we're going to see if he can hold it, and you really push it. Aggressive, suctioning, positioning, keep them active, and somehow avoid the intubation. This is also something that can be considered patient to patient. There's no studies on this. This is patient to patient. The reason I put this up is because we may have this situation a lot in our ICUs. Document everything clearly. Okay, it might not be a DNR, but it's almost running parallel to a DNR. So be careful. The advantages of protocols is you get things right. Everybody is on board. Anybody can do it. Don't the judgment call. I know this patient will tolerate. No. Clear protocol, it reduces, chances of reventilation. ICU length of stay definitely comes down, and care is standard. Everybody knows what's going on. Okay, if you are not there, the next consultant comes in, they know what to do. That flow should be there when you have a protocol. Complications of a failed extubation, obviously cost, higher mortality, higher stay, rates of VAP definitely go up, and the patients just don't do well. They'll never go back to being the same. The first chance is your best chance. So let's talk about a few patients. COPD patient failed spontaneous breathing trial. So what would you do? You'd consider an early NIV. That would be the safest thing to do. Reduce intrinsic PEEP. Remember, auto PEEP is something that will be happening, and always play that before you extubate, and help relax the respiratory muscles, and NIV is the way to go. We use it quite a bit and we're very happy with it. Take them off the vent one day, CO2 narcosis, one night, bring down the CO2, extubate them onto NIV, and we just continue care. So it's a very quick process. We're very happy with it. Patient will get shifted to ward with NIV, but they're off the vent. And another 2-3 days they're off. Once they're in their ward, they do much better than in the ICU. Heart failure patient, volume overloaded, risk of weaning failure. Make sure the patient doesn't have any shock. Check their echo. Make sure their LV dysfunction hasn't worsened being on the ventilator, and diurest adequately. The negative balance has to be higher than the positive balance at least for 36 hours before you extubate this patient. There should be no water in the lung. And remember, your lung ultrasound will be unusually good when they're on a ventilator. The minute you remove the tube, fluid will rush in. It's a pressure dynamic. Neuromuscular weakness, I believe that this is the hardest one. Poor cough, poor tidal volume, requires longer spontaneous breathing trial before you do it. So you'll definitely have to do 2 or 3 days of SBTs before you can judge that, okay, I can take him off. It's a challenge again. So summary of best practices. Protocols are required. Use pressure-supported SBTs if possible, NIV in COPD, HFNC if you can get around the cost. I recommend it a lot. And always have a plan for what's going to happen next. Key takeaways, liberation is multi-step. Evidence-based strategies exist. Read evidence. Ideas are constantly coming out in the realm of ventilation. And care has to be individualized. You can never say, this is how it works for every patient. Okay, there will be some individualization of care whenever required. And again, I'll re-emphasize, work with your nurses, respiratory therapists, physiotherapists, and everyone. That's what really helps. I can't say that I've done a lot of this, but I think the critical care team with the advanced cases of prolonged ventilation and VAP, they probably do a much more rigorous process than what I do in my practice. But These are just some of the basics. Thank you.
Thank you, Dr. Girish. That was very succinctly presented. Important points were highlighted. It's a pleasure to listen to you. I had a whole bunch of questions that I thought I'll ask you, but you've already answered them all. If the audience has any questions, I do have one thing to ask you, Dr. Girish. You were very clear about when to pull off patient. You also told us about how it is a short-term ventilation that you deal with. Only in some patients that you will consider weaning within the ED. How early is too early to consider weaning? What I mean is, if you're extubating a patient, there must be some time interval where if you're extubating that patient, then you have to ask yourself, should you even have intubated that patient? Should you even have ventilated? So when do you start incorporating this consideration to, is this patient ready for weaning?
We think about it in our ER and in our ICUs, even when we're intubating, whenever the way our ER works is whoever is intubating and bringing into our ICU, when they discuss the case with us, the first question we ask them is, how long do you think it'll take? I ask because I've not seen the patient in the ER. So whoever's putting it in, I'll ask them that point, like, you've seen the patient, what are you looking at? How long do you think this is going to take? I think that assessment by the primary care doctor who has seen is paramount. And if the primary cause is treated well, I don't think as ER physicians, we should be thinking, this is their headache, let them manage it. We should know that, okay, this is what's going to happen day after tomorrow. It's very important. So that's where we start the planning. So there are many times, in the middle of the night, if I've got a good, one of my smarter consultants or PGs who are there, and they call me and say, sir, I'm going to extubate, he's looking too good. Even in the night, they'll pull one of those off. And it's rare, but it's very happy. They've intubated in the morning, night they've extubated. Morning, I come in and say, okay, everything is nice. And I get to tell the patient family, "Ella chennag agide, karkondu hogbidi ward ge." It's a good feeling. So you require aggression. I think you have to keep a constant watch on the patient.
Thank you. Any other questions? Thank you, Dr. Girish. Wonderful talk.
Thank you, sir, for that inspiring presentation. I warmly request Dr. Madhu, sir, to felicitate Dr. Girish, sir. Thank you, sir. I'd like to also request Dr. Srinivas, sir, to felicitate as chairperson.
Now I'd like to call upon Dr. Smita ma'am, and I would like to request Dr. Srinivas sir to felicitate Smita ma'am. Next, I would like to request Dr. Srinivas sir to felicitate Dr. Chandrama.
We conclude here. The sessions are all over. Now we are going to have a small tea and then we'll go to workshop station. 20 minutes each workshop station. Our faculties are there. You can ask. Till now you have learned theoretical part. Now practically you can have workshop. Each workshop will have 20 minutes time. And already groups have been made. You can divide into the groups. Stations are there at emergency department. Stations are at emergency department. No, tea will be given there only. 5 o'clock tea will be given at emergency only. Directly you go to emergency, ICU and yellow zone. There are 5 stations are there. Please go and have the sessions properly. Okay. Thank you everyone. Thank you so much for patience hearing and attending things. So nice of you. Thank you. Thank you. Thank you for the anchors. They are very good modulation and also singing for who is that? Nidhi also. All warrantors, everyone, they worked very well. I am very much thankful to you. We expect you same thing, cooperation next also. Kindly go to workstation, help them.